Global Cancer Alliance and the She Alliance for Spirituality in Health and the Environment. These initiatives have received wholehearted support from policymakers, industry captains, community leaders, health experts, celebrities, and influencers. Respected brands and advocates have also joined the Council, becoming allies in the mission for a healthier world.
I think this wellness is an important initiative. I will definitely be interested to know the conclusions of your deliberations, and I'll definitely take these issues and your suggestions forward to the logical conclusion.
हेल्थ सर्विसेज कैसी होनी चाहिए, ये तो महत्वपूर्ण विषय है ही, पर उसके पहले हमको हॉस्पिटल या डॉक्टर के पास जाने की जरूरत न पड़े, इसके लिए हमारे एयर पोल्यूशन और वाटर पोल्यूशन को हम कैसे सुधारें, इस बात पर जोर देने की आवश्यकता है।
कहते हैं छिटी जल पावक गगन समीरा, पंच तत्व निर्मित यह अदम शरीर। ये पंच तत्वों से निर्मित यह शरीर पुनः पंच तत्व में ही मिल जाता है। तो हमें उन पंच तत्व का, जिससे इस शरीर की रचना हुई है, आकाश, पृथ्वी, अग्नि, वायु, जल, इन सबका ख्याल ही नहीं रखना, बल्कि इन पंच तत्वों का रक्षा करना हमारा पहला कर्तव्य हो जाता है।
In the digital world, the Council reaches millions with credible source of knowledge empowering them to protect their health and prevent diseases. Through its various initiatives harnessing the power of social media, the Council impacts over 100 million lives annually. Join IHW Council in creating a world where limitless potential knows no bounds. Together, we can achieve a happier, healthier world for all.
We are glad to showcase a brief summary of the work done by IHW Council so far. Well, there's a beautiful quote that I would like to share here before we introduce the context of the summit. Medicines cure diseases. I'm sure you all have heard this quote. Medicines cure diseases, but only doctors can cure patients. The last 3 years have very well taught us that good health and robust health infrastructures are the primary requirements for productive and prosperous economies. The pandemic has changed healthcare systems for good and revolutionized the way health ecosystems worked world over. One of the most pertinent changes has been the way patients have advanced from being passive receivers of healthcare to being active participants in their healthcare journey. Patients are no longer recipients of healthcare. Instead, they are active participants. A few years back, patients used to listen to the physicians, but now they interact with them. Hence, it becomes very important to understand that the patients are the primary focus or hub around which healthcare needs to revolve. A patient-centric approach in healthcare is not just about changing the way treatment is given, but also bringing about qualitative access to healthcare at scale. For the patient, this should mean better healthcare delivered anytime, anywhere. For the providers, it should mean the ability to care for patients without feeling overburdened or stressed. This calls for us, regulatory authorities, government, and healthcare systems to collectively rise to challenge and transform healthcare and to realize the vision that is the patient first. This initiative was conceived by the IHW Council. Ladies and gentlemen, may we please put our hands together for IHW Council for conceiving such a fantastic initiative. Through the Patient First initiative, the IHW Council provides a platform for all important stakeholders from the healthcare ecosystem to come together on a single platform to address the issues and gaps for a patient-centric healthcare ecosystem, also from their respective perspective. Also to deliberate on the future trends and other important aspects of a healthcare system that puts the needs of the patients at the forefront. Ladies and gentlemen, we would also like to thank all the sponsors who have been a very important, vital part of the summit today. This event is supported by Public Health and Family Welfare Department, Government of Maharashtra, an initiative by IHW Council. The supporting partners are Walter Kluwer and Takeda Pharmaceuticals. Healthcare innovation partners are SSI Innovations. The healthcare partner is AMP Diagnostics. The hospital partner is Jupiter Hospital. The diagnostic partner is Agilus Diagnostics. The diagnostic tech partner is VI-Scan Diagnostics. Communication partner is Teamwork Communications Group. And digital media partner is Teamwork Solutions. We would like to thank all the partners for partnering for the second edition of Patient First Summit and Awards. Ladies and gentlemen, we commence the summit with the first discussion, for which the topic today is evolving healthcare systems and patient-inclusive models for universal health coverage, for which I would request you all to please join me in inviting the moderator for the session, Mr. Kamal Narayan, CEO of IHW Council. Ladies and gentlemen, can we please put our hands together and welcome him on stage? A very warm welcome to you, Mr. Narayan. We would also like to welcome all the dignitaries who will be joining us for this discussion. Mr. Manoj Saxena, Managing Director, Bayer Zydus, and South Asia Head, Pharma. We would also like to invite Dr. Sanjay Maheshwari, Cancer Surgeon, Urologist, Medical Director, MP Birla Group of Hospitals. A very warm welcome to you, sir. We would also like to invite Ms. Sampada Gosavi, General Manager and Managing Director, Astellas Pharma India. A very warm welcome to you, ma'am. And we would like to invite Mr. Vishwanath Swarup, COO BSV, to kindly join us for this discussion, wherein the topic is evolving healthcare systems and patient-inclusive models for universal health coverage. As the session has been moderated by Mr. Kamal, so we shall hand over the session to you, sir, and we request you to kindly take it over. Thank you, sir. Can we get the cordless mics on the stage, please? Thank you. And as we have all our dignitaries present on the stage, may I request you all to please have a little, I would rather say in Hindi, thodi zordar taaliyan ho jaye, to welcome all the dignitaries on stage. Thank you so much. It is indeed a wonderful. Sure. Okay.
Hey everyone, good afternoon. By the time the mics come for our esteemed speakers, let me just welcome all of you for this very unique initiative which we really passionately work towards, bringing patient-centricity in healthcare and bringing the patients at the center of the care. Before we go to the questions and I take my seat over there, let me also, because we are today in Mumbai and something interesting happened yesterday in Mumbai. We saw our Team India, kind of continuing its wonderful stride of winning all the matches, and yesterday's win was absolutely stunning. When I saw that, I also felt that how about if the Team India, which we all comprise of, the Team India of Indian healthcare system, can also win all the matches against the diseases we are facing. What kind of outcome we can generate and what kind of society we can build if we are able to achieve these kind of winning streaks in something which is impacting our lives on day to day, which is also hampering the potentials of millions of people. We are facing challenges of diseases which are increasing in unprecedented numbers, and impacting the lives and productivity of not only individuals, families, but also the whole nation. So how about making this, kind of victory go on these areas? And I think that is where we will try to discuss today, that when we want to kind of strengthen this fight against diseases, we want to bring the best of the care to our patients or the people, and make sure that they not only win over the diseases but also can come back to the same level of productivity, back to normalcy, and also achieve the best of their potential. What is the role going to be of these patients themselves in the whole healthcare system? So let me go to. So good morning, good afternoon to all of our esteemed speakers today. When it comes to healthcare, as I mentioned about that, how to make patients more, participative in the care, and also when we talk about bringing patient centricity in the healthcare system, we normally start thinking that patient centricity is something which is seen and experienced in hospitals by the doctors or from the doctors. Our MC for the event also mentioned an interesting, saying, kind of mentioning that medicines can cure diseases, but only good doctors can cure patients. Interestingly, in this opening panel today, we have one doctor and 3 people who work in the area of medicine. I think that also gives some kind of message that when it is about patient centricity, it is not only about doctors who can bring that. And I think all those who are involved from drug discovery to drug delivery also are important partners when it comes to patient centricity. So let me then begin this whole discussion and try to understand that how our important partners from the pharma side, from the medicine side, look at patient centricity as a concept, as a practice, and also as a mission when they work in ensuring that patients get the best of the medicines and the most, the advanced therapies in their respective areas. So let me begin with Manoj. Manoj, you have been leading an organization which is bringing a lot of innovative therapies in multiple areas, from women health to cancer care. How do you see patient centricity as a concept being strengthened by organizations like yours, where the whole from the research to the delivery of the drug, those aspects, that how it is going to be experienced by the patients, what is going to be the involvement of the patient, and how it is going to empower the patient to kind of tackle their diseases or problem in a better manner, and it can also become a complementary support for the doctors who are treating those patients. How do you look at this whole piece?
First of all, let me congratulate IHW for holding the Patient First Summit. We all are here because of the patients. I guess when we say patient centricity, whether it's pharma companies, doctors, hospitals, diagnostic partners, patient groups, everybody is looking at the outcomes or the quality of life. How can we improve our patients? Yeah. In that, when I represent Bayer, we actually do a lot of work to really understand what is patient centricity. I think a lot of time people misunderstand patient centricity by doing a project, by doing a campaign. Patient centricity is not about that. How do you design your clinical trial at a very, very early stage when the product has just come out of the lab and you are looking at planning phase 2, phase 3 trials? You have to really look at it. What does the patient centricity mean? How can you make your clinical trial which are designed to benefit the patients? How have you made sure that you have inputs of patient organizations, patients who are suffering with that disease? Then, of course, when you commercialize the drug, a lot of time you're doing it because it's a regulated market. You're doing through doctors, and actually within Bayer we train our everybody who is customer facing, whether it's a medical person or a marketing or a sales rep. We call it, the training is called as patient focused interactions. So the whole communication approach of our sales guys or our marketing guys is a manner to the healthcare practitioners, to doctors like him, is that the focus is on the patient care. Focus is on understanding, unearthing patients, yeah. And then programs, and the easiest program, people look at is the affordability. I think a lot of time the whole patient centricity means is access. I don't think access is patient centricity just. Yeah, access is a given, which we have to look at it, and access as multi-factor. And why I say so is, at a given point of time, where does a patient is very, very important. For example, we all know diabetes, hypertension are chronic diseases. Patients have to continue those medications. There are many other NCDs as well. Chronic medications needs continued therapy, but we all know in India, only 6 months, 9 months, people continue and then they drop the therapy. Why? Understanding that why is the patient centricity. Understanding what you can do so that they can continue and adhere to therapy. Understanding what we can help the doctors to communicate well on diseases. How can we educate them so that they feel? At the end, the focus of patient centricity is empowering the patients to decide what is good for him or her. It's very, very important. And when we say only from an affordability piece, there are many examples. You look at anemia in India, 50%
और फिर उसके बाद डेड बॉडीज को शिफ्ट करने में प्रॉब्लम आती थी, जिंदा को तो लाने में तकलीफ होती थी। ऐसी जगह पे एक बहुत सुंदर अस्पताल में मेरे, बिकॉज आई हैव ए स्मॉल प्रेजेंटेशन ऑल्सो, so I'll show it that bit later on in my spotlight. Probably that's the best time to show it. But now coming back to the healthcare model, which very rightly has been put in red color, it is the first which has been pink color, it has been mentioned first. And patient में I जो है वो एक pink color का है और 7 sponsors हैं शायद, 7 main sponsors which I could see. So how do a patient becomes the patient-centric? So this model which I have brought is a Rubik cube. You have all seen it in your childhood and probably giving this model I have designed for healthcare myself, and I call this as patient-centric model of healthcare in anywhere in the world. Now you have to match the colors. So we have 6 surfaces. One is technology, other one is policy, third one is doctors, fourth one is pharma industry, fifth one is this, sixth one is that. There are many things. And we keep rotating it. So when we keep rotating and we try to match color, at the end of puzzle,
patient, because still now our supply side on healthcare has been very restricted. That is changing. So it is also a wake-up call, because still now the incumbent supply side, so to say, smell the coffee and align with the times. On healthcare has been very restricted. That is changing. So it is also a wake-up call, because now the incumbent supply side, so to say, smell the coffee and align with the times. That is changing. On healthcare, so it is also a wake-up call, because still now the incumbent supply side, so to say, smell the coffee and align with the times. So to say, smell the coffee and align with the times. That is changing. So it is.
Manoj, when it comes to delivering solutions, and would you like to highlight certain areas where your
We know as an industry, alcohol, tobacco, banking, and healthcare are the top industries where the society does not trust us. Yeah. So there is a significant trust deficit, because they think, and what Dr. Maheshwar is saying, that his relationship with pharma is not viewed very rightly by the society, and we need to change that by keeping the patient in the center and understanding it. And what does that understanding mean is, look at your product innovation, look at what solutions you're offering, look at the way you communicate to them in their own language. This is the key. And in that, what work we are doing, for example, in the HMB with Preserve the Uterus, is exactly there. We understand what women are looking at. Nobody wants to lose a uterus, but here we trying to sell a product, here with the doctors, and absolutely we're not going anywhere. There are many examples. For example, we had a product for DME and wet AMD. This is a retina surgeon's product. It's an injection which goes into the eye. We came with a patient support program, having a counselor, everything. Understanding and listening to the patient, we had to change our program. Because we realized, unlike wet AMD, DME is a bilateral disease. Both the eyes are affected. So if we will just be the industry and apply our thinking based on clinical trial, based on the feedback which we are getting from doctors, we can be 60-70% right. But if we have to really be understanding the patient's insights, listening to them, we realize DME is a 2-eye problem, not just 1-eye problem, right? And we redesigned our campaign, our program, our patient access material. The same is for endometriosis, where we are actually in India working with the patient groups, women with wings. It's a 1,200 women community, very, very dynamic. We have changed the entire understanding of endometriosis, so which is a patient journey in terms of how a woman visits 6 to 7 gynecologists before she understands that she has endometriosis. Yeah, so it takes 6 to 7 visits to a clinician before she gets diagnosed of endometriosis, and what different ways of looking at it. What are the implications on it? So the solutions are tremendous. On that, on many disease areas, they have nowhere to talk. There are all male pharmacists in India. When they go to a pharmacy shop, there are no female guys. We are in contraception. We developed a chat bot. Now that has got nothing related to selling medicines, right? We developed chat bot primarily so that in the privacy of their comfort of home, they can find answers to their individual problem. Science is moving for personalized therapy, and
the operating theater staff, they're all completely trained. And then we currently have 16 installations, mostly in India, but then also 2 others globally. You can see here from large tier 1 cities to small tier 3 cities. And currently we've also placed a system in Dubai in Aster DM Healthcare. And then recently I launched a program in Johns Hopkins University in Baltimore, Maryland. So I think that I will conclude there. I know I've only been given 10 minutes, but here's our young team. I can't leave without giving them credit. A young, bright team of Indian engineers, and the average age of them is 26, 27, and I tell you, we're so proud of what they've been able to accomplish. No one in the world thought that this could be done in India, and we're very happy to show them that we were able to do it. So thank you very much.
Thanks a lot, Mr. Srivastava, for joining us virtually. Now, moving on to the next segment, the next session for discussion is on role of diagnostics in patient-centric health ecosystem. And for this session, I would like to invite the moderator for the session, Dr. Captain Sandeep Sharma, CEO, Manipal Health Map. A very warm welcome to you, sir. We request you all to please join me in welcoming.
The second is technology, which is proving to be a big disruptor, and it's also kind of changing the landscape. And the third, obviously, is the patient convenience, patient touch points. While it was something which was undergoing a gradual movement, but post-COVID, I think the patient's convenience, patient's touch points have actually moved more towards making the diagnostic industry kind of reach out to them rather than having them reach out to the industry. So I think those are the few things that we're going to, over this period of patient-centric diagnostics, kind of discuss with our speakers here. One of the things that really comes into mind is, the customer and the patient. I mean, essentially, what we would like to do is understand what the patient needs, understand what the pain points of the patient are, and how to kind of service them or resolve them the best, in the best possible manner. So I think we're going to kickstart this first with Jay, because Jay has been looking at customer, oriented service protocols in various parts of this thing. So Jay, just to kind of help us, what are the changes that you perceive are happening towards the, from the patient side, and any novel approaches or any strategies that may help the industry put its foothold, more firmly on the ground?
From my perspective, I think customer centricity in diagnostics for healthcare has been key focus here now, especially after COVID. And I think in the earlier days, the key focus was the doctor do what the doctor says and just follow what his instructions are. But in today's era, customers are now taking their own decisions, getting their own decisions on what path labs or what hospitals they want to choose. Customers are now taking the decision of how frequently would they like to do their annual checks or preventive checks to ensure that they are cognizant of their health and wellness and well-being. So these are key changes that we see from a customer standpoint. What we also seeing is now customers are looking for comfort. Thanks to technology, but at least luckily in diagnostics, human touch will not be replaced by technology. Technology would be an enabler, would do value adds, but the human touch of your hands where you draw bloods, your hands where you help a patient in getting up if he or she is hospitalized. So human touch is always going to be the key focus area. But yes, technology is being an enabler where patients want their reports on a tip of a button through the app, through the WhatsApp. Patients want to book their appointments through the applications. Patients want to have teletalks, discussion with the doctors over a phone. So these are key changes that we're seeing from I think the post-COVID era that we come across in diagnostics.
On the same point, one of the things that's happening in diagnostics is earlier it's largely an unorganized sector, right? So they were like those larger players which were offering a wide realm of packages and diseases and so on. But we've seen a lot of technology-based startups coming in. Not to say, I mean, the world is changing, the demands are increasing, those guys are dishing out great quality stuff. From a customer standpoint, barring the tariff wars that kind of come in, what else is really the customer concerned about? How does one create a differentiator as far as that is concerned?
So tariff war is going to be in every industry. Every new player is going to come and try to disrupt the market by getting unique pricing, by focusing on customer acquisition. Again, my personal belief is if an organization focuses on one unique initiative or a differentiator that can be given to their patients. Now, let me give you a small example. In my previous stint, we started offering trend reports. So what was the HbA1c level of a patient 6 months back, 3 months back? What is it now? How is it improving? So if any kind of key differentiators that can be capitalized by an organization, which can bring in customer loyalty, customer trust, because one good part about diagnostics is, patients might not really want to quite oftenly change their doctors or their path labs or their hospitals. Maybe where they build a trust, build a loyalty, build a commitment. So, as I said again, so while these new aggregators might come in, but how can an organization have that differentiator, ensuring there's trust, loyalty with the patients?
Oh, thank you so much. And you did touch on technology, which gets me to the other two gentlemen out here. We'll start with Mr. Mukherjee first. Sorry. So, how do you envision technology? We all keep talking about technology, disruptor, critical care, better patient outcomes. Would you want to shed some light on, you've been doing a remarkable work with a lot of oncology and critical care cases and stuff. So how do you use technology and how does it affect patient outcomes and in return kind of get the trust and the differentiator in a better patient outcome which eventually defines the acceptability of the product, let's put it this way.
Sure, thank you. So first of all, thank you to IHW Council for this session and pleasure to be here. So yeah, I mean, technology, of course, is an enabler. Once upon a time, the discussion was technology is an option. It's no longer an option. And one of the prime examples that come to my mind is UPI. Before COVID, we did see some implementation, but during COVID and post-COVID, UPI is everywhere. It's become a part and parcel of our daily lives. So that's technology for you. So there were reservations earlier, but now, of course, it's common. So coming specifically to Sandeep's question, see, technology at the end of the day, no matter how disruptive it is, it has to enhance, the patient experience and, of course, the patient outcome. So from a patient standpoint, he or she needs to feel that, yeah, this is different from the options that I had earlier. And from a clinician, from a doctor's standpoint, he or she needs to feel that, yeah, this is really complementing me and my skills. Answering a specific question to the technology that we at Niramai have implemented. So basically, so we have a screening solution for early detection of breast cancer, And we know that, breast cancer is one of the most common forms of cancer amongst women today. And unfortunately, the mortality rates are very high. And the main reason for that is late detection. Coming back to that question, so here we are offering a solution which is, which is suddenly making, of course, coming to the cost aspect at a far lower cost as compared to current modalities. So that's where, when it comes to the end user, and here the lady in question, so she has a solution now, which to her is more welcome, more convenient, more easy, and she can even do the screening, at the privacy of her home. Imagine a breast cancer screening happening at your, at your home. So unless and until the technology, brings in convenience, additional convenience to you without compromising on quality and outcome, technology hasn't really lived up to expectations. So technology has to bring in that, differentiator.
Thank you so much. Which also gets us to Raghavendra next. Technology is equipments, its processes, sorry, is that? Technology, when we speak about its equipments, its processes, its applications, its, the engineering and the research part. And you've been at the forefront of using technology to better patient outcomes, looking at, so how would you visualize where is the interface of technology today vis-a-vis the diagnostic industry, and where do you see this going forward, which will actually alter patient outcomes or have more predictive management of disease management?
No, I think it's a great question. The reason why I say this is, if you actually look at the way the whole diagnostic space is evolving, is tremendous, and it's moving at a very, very fast pace. More towards, like you rightly said, more towards precision, personalized, and then actually moving into the predictive. So your precision, personalized, and predictive is what is going to be. And I'll give you a very classical, my own story, how I have been a beneficiary of the technology, I would say engineering, AI, ML, and then how the whole thing has been, how I've been benefiting. So there are two instances. One instance is we've all heard of the genetic testing and whole genome sequencing, which has become very popular now. And I'm one of the beneficiaries of how I've used that technology. So I'm a very chronic migraine patient. So it's like been there for the last 25, 30 years. And I'm sure many of you have gone through this, or in our families, we have gone through this migraine. I've taken all kinds of medicines. When I've gone through this particular whole genome sequencing, where your engineering and equipment is there, which actually does your sequencing of your DNA, you take your blood, you do your sequencing, and then there is this whole lot of panels that have been developed, and you subject your DNA to these panels, and there are about 220 genes that have been explored about my migraine. And now my doctor says, when I've shown this report, my doctor clearly says that, boss, you know what? You are very, very healthy in terms of your genes for migraines. This means genetically I'm not supposed to have any migraine at all. That's on one side. Now let's understand the root cause of why this is happening. Now when you look at the whole sequence and then see the respiratory allergens on the other side, there are about like 32 genes have been analyzed. And what the outcome or the AI that has thrown out is that I'm completely prone to the respiratory allergens. I mean, in the sense like whether it is pollen or cold or anything. Now the doctor is correlating both of them. And this doctor says, here is the answer or the root cause for your migraine. It is not the migraine which is actually the problem. The problem is your respiratory allergens. When you're subjected to these allergens, there's a sinus that is getting developed, and this sinus is actually triggering your migraine. Now, instead of the migraine medicines, there's a simple regular therapy, what she suggested, how do I, not allow me to get into those allergens or things like that, basic, the routine therapies, and then, some of times it is the histamines, antihistamines. So believe me, from last 7 months, I have not got any migraine till date. And this is the biggest beneficiary, I would say, that I've been benefited out of the technology, I would say innovation, technology, and the patient outcome.
There's another example I'll give you. My nephew, who is about 21 years old, there's a huge history of diabetes in our family, and unfortunately, my nephew has been detected with diabetes. Now, I'm from IAC, so I'm a molecular biologist. I know little deep about it. So I said, okay, let me subject this gentleman also to the genetics. Now, first time when he went through the reports, doctor, and it's a usual way that, when your HbS-Ag is above 6.5, and your blood sugars are about 250, the first thing is, doctors would start with a metformin drug. Now, when we did this genetic analysis of my nephew, what we have found that is he's mutant on GCK gene. What it means is, if a particular patient is mutant on GCK gene, he doesn't need any medicine at all. A diet and your regular exercise would actually control that. And that's exactly what we have done. So he's off the metformin from last 6 months. And these are the two beneficiaries that I would say I personally have benefited out of the technology, innovation, AI, ML. So now you can imagine the power of technology, the power of innovation, and how it's going to completely change the paradigm. And you see a lot of examples of this, and especially, why does a cancer patient has to get a genetic analysis, in the 4th stage? Can he get the genetic analysis in the 1st stage itself, right? I mean, you can actually see the whole pattern. While this is still evolving and there is no endorsements, there are a lot of publications, scientific publications, which endorse all this. And if you can use that, I think there's so much of patient-based outcomes. And I'm sure, world is going to definitely benefit out of this technology, innovation, and this particular area is definitely going to benefit. That's my views, Dr. Sandeep.
No, absolutely. Thank you so much. In fact, you mentioned about cancer patients. I mean, till about, a couple of decades back, chemotherapy is one particular area where, today when you talk about it, when you look about it, it's gone through a transformational change because of the genetic, interface that's happened. Anyway, coming back to Dr. Shilika has joined us virtually, and we will get back to her. Doc, thank you so much for joining us. Sanchit, you mentioned integrated diagnostics within patient support program, and that's proving to be transformational. Hi, Dr. Shilika, we'll come back to you, after this question. Thank you for joining us. So, what do you really, how do you describe it, and how is it making an impact? Would you want to share with us?
Sure. Putting things together, I would say on behalf of, pharma industry. Now, for a lot of us, there's a shift of focus. The shift of focus is we are not here to offer a treatment. We are here to offer improvement in health outcomes. Now, this particular, shift of goal itself brings a very interesting and transformational approach. That is one part. Second part is that the treatment, we realize that treatment is only one part of overall, disease management. And in order to do so, we need to be kind of, collaborating with different stakeholders. And here, what's important is the role of diagnostic, gets into play, the role of kind of, repeat visit to the doctors get into play, the role of, non-pharmacological therapy, gets into the play. And what is important is to connect all of these. Today we have a platform of technology. Think of it, if in case I just go back 5-7 years back, how many diagnostic organizations were offering home care service? Now think of it, you have a home care service, you have a treatment, you have a physician who understands, the importance of it. And the moment you kind of start linking them up, and what is important is specifically for chronic diseases or biologics, etc., where the treatment is kind of, for a long term, it's extremely important to figure out, once the treatment started, how the patient is kind of, behaving. And an integrated system typically also captures one of the very important aspects of compliance. Then because of this particular compliance, pharmacological, non-pharmacological, interventions, they kind of, baked in together. And we know what are the, milestones, maybe 3 months, 6 months, 9 months, etc. How the movement would be there. This helps us to really understand, first, like, how the patient is behaving. Second, very importantly, in many cases, the early response is predictor of how the patient would be behaving as we move ahead. And it can happen that, more pragmatic calls are taken in the interest of patient, which is, if you ask me, the base denomination of what we are doing. And last but not is, the real world in real life setting, how the patients are kind of behaving, how the drug is behaving. And there are instances, at least I can think of 2, 3, strong instances wherein this particular integrated approach with diagnostics have either led to inclusion of a condition and treatment option in insurance. This was done in 2019 IRDA guidelines of standardization, which was a big boon for the patient for therapies which are kind of, some of the therapies which are out of pocket, they coming in. Second is also offering something which is kind of quite new to India, but very relevant, outcome-based assurance programs. So that both the doctor and the patient knows that when I'm kind of, putting the patient on this particular therapy, this will definitely, have this kind of impact. So which definitely to me is game changing.
Dr. Kunal, on the same technology piece, and we're delving on that. One of the key things, you're a histopathologist.
Yeah, I'm an oncopathologist. Yeah.
So one of the key challenges that we face in digitizing patient samples is remotely when we are talking about, it's about the sample, extracting the sample, making the slides, then digitizing it in a high resolution format to be read remotely by a doctor. And how do you see that progressing? Because that's been a little bit of a challenge, and that really defines, in a sense, that patients have to travel. Not just get treatment, they could possibly get treatment done in tier 2, tier 3 cities. But because of lack of availability of the proper diagnostic techniques, they have to kind of come to metros and tier 1s. How do you see that technology in your field evolving?
So, I would like to give a very pragmatic answer to that question. See, we have to understand that today diagnostics is way beyond diagnosis. We are in an era, as we've already discussed, that, let's say about cancer. We are in an era where we have moved from a broad spectrum chemotherapeutic era to a more target-based treatment and immunotherapeutic treatment. And with this, we've had, like digitization has been in radiology, we've had advent of digitization even in pathology. How that has really helped us is that, imagine, let's say there is a patient sitting, forget about a tier 2, tier 3 city in India, let's say in some remote part of Africa. They would get a preliminary histopathological evaluation done there, which would, in many tissue is the issue. Things that shouldn't be missed out.
Thank you. spoke about trust, you spoke about, no, those are values that only a human mind will be able to. So how do you perceive this, or how do you feel using some of these to kind of address the patient? Because largely, I've been in this industry for a couple of decades now, it's also the acceptability of the patient, which actually defines compliance, which defines outcomes. So how do you see this?
My perspective again would be, it's important to capture the voice of customer. Every patient, every customer is different. The personas of patients are different. An expectation of a senior citizen versus an expectation of a parent whose child's blood is going to be drawn, and versus a patient who is between an age group of around 30 to 45 is different. So capturing the voice of customer is one of the key important aspects, basis which you can customize your services, deliverables, and patient management at all aspects. Now, maybe at Agilus, the way we manage a senior citizen, when we're drawing blood, we ensure that we use butterfly needles, because they could be having thin veins, difficult veins. When it comes to pediatric patients, we try and using a painless spray. So, so understanding what a patient wants for a specific age group and trying to customize your deliverables or givings is one of the key things that we focus on.
So in some respects, it's not, you wouldn't say that technology is being adapted to the patient demands as well in the industry, and not just the other way around?
No, technology, as I said, it's an enabler. It helped me giving the voice of customers. So through technology, we do NPS, we do surveys, basis which the patients or the customers give us the feedbacks. Basis those feedbacks, we do the TNAs, we do process improvements, we understand what is the expectation, what really went wrong, and then basis that, we try and fine-tune our processes, which in turn helps us in giving a better patient experience.
So basically using technology to understand the patient better and get the best delivery systems aligned.
Absolutely, absolutely.
In fact, when we are talking about compliance, and you mentioned, Surjit, that early detection, breast cancer, we all know breast cancer is one of the most aggressive of cancers, and early detection is what really helps. But coming back to the compliance, your thoughts on advocacy of testing at an early stage vis-a-vis acceptability of the patient to kind of get themselves tested. I mean, where does the world lie in between?
That's a very, very practical, question. In fact, I'll just go a step back. Just the other day, was speaking to a doctor, an oncologist, and he said that, God forbid, if a male member of the family gets affected, it affects one generation. But if a female member of the family gets affected, it affects 3 generations. Her own generation, her parents, in-laws, and her children. So it kind of tells you how important is, early detection. So everybody knows, and again, from an India ethos perspective, with the greatest of respect, women, put the family first and themselves later on. So in the list of priority, she places herself way, way, way below. So while the awareness levels are definitely increasing, that yes, early detection is important, not just for breast cancer, for any disease actually. There is a lot of work, advocacy, etc., that needs to be done, in order to actually get that implemented at the ground level. And we are not just talking about the urban woman over here. We are also talking about, rural India. I can share one example with you. So along with NHM, and the government of Karnataka, we had conducted, community level screenings in one big district in Karnataka. And at the first level, there were ladies, who were identified, who needed further diagnostics by way of an ultrasound. Now, it was a huge challenge, to actually get them over to the district hospital to actually undergo the second round, which is the ultrasound. Ultrasound, the diagnostic bit. Because post that, if it's still positive, then you go for histopathology or biopsy. So that's one of the practical problems, and that's something we are seeing not only in rural India but also in urban India. Actually, a lot of dropouts that happen. So it's a consistent effort. The government is also definitely paying a lot of emphasis on this. As we can see from a healthcare perspective, the accent is slowly but surely moving from a infectious disease to more of NCDs, non-communicable diseases. And that is where I think a lot of opportunity lies.
Thank you. And you bring out a very interesting point about multiple agencies working together, which, Raghavendra, would you want to kind of collaboration between, sorry, is that working? No. Yeah. So, Surjit spoke about government agencies, but generally speaking, when we talk about patient centricity, that is the final goal. That's at the end of the line. There is a lot of effort, there is a lot of thought that needs to kind of go in before. What do you feel about these collaborative efforts of multiple stakeholders? How do you see it, and how important is that to kind of get to patient centricity? Now let's zoom out and understand what it takes to kind of get there. So just wanted to have your thoughts on that.
So the way we look at it today, with the way things are evolving, I mean, not just in one industry, but every collaboration is given. Without collaboration, it's very difficult to move forward, whether it is, whatever you want to talk, there's this collaboration efforts that are involved. So when it comes to very specific for a healthcare or a diagnostics or therapeutic industry, the collaboration, I would say, it starts from the discovery, invention, and then, need-based kind of collaboration is what we would look at. I mean, so what I mean by that is, in isolation, there is a lot of innovations that's happening using technology and how it's used. At the same time, you see there's a lot of need from the doctors or from the diagnostic space. But now imagine there's many instances where we come across where, the discovered or the innovation, doctor says, without this I'm still being, how is it going to benefit me? But now imagine if there's a collaboration or if there is a collaboration between the need and then the innovation, or need-based kind of an innovation, and that's what we call the inputs towards the discovery or inputs towards the innovation. It's not just the product, but also the process innovations, what we call. That's something that, it's large. But to very specifically, what I've encountered in my company is, while we have developed one of the very innovative technologies of detecting the TB and the multi-drug resistance, and there's a lot that's happening. But unfortunately, the translation of this technology from a lab to the commercial is where the whole issues are. Imagine, we don't have the expertise of moving it from a lab to the regulatory kind of manufacturing. And then from there, it has to move towards the commercials. And then from there, commercials, it is more towards the adaptability of the diagnostic centers or the hospitals or the doctors. So this is where the big challenge is. Now imagine if you are able to collaborate from a discovery piece or an innovation piece, and then move it to a CMOs, what we call, contract manufacturer, regulatory approved kind of manufacturers. That's the collaboration what we were looking for. And from there, the distributors or the channel partners, and then the acceptability. I think this is something that at the end of the day, the whole approach is how patient is going to benefit out of it, right? If this happens, then I think what we call as the lean, you can actually remove a lot of waste in terms of time, effort, money. Most of the things can be removed, and then you can get a very seamless, low cost kind of an outcome. And that's what we've been working on, yeah.
That's actually the prime focus. I mean, eventually, before the session prior, we did speak about how the costs are going to kind of keep going down, and obviously the masses need to come in, and that's where the industry needs to move. Sanchit, you mentioned about measurement systems. I'll be honest, I was a little stumped there, and I wanted to kind of ask you, measurement systems, within the diagnostic space? I mean, what were you wanting to speak about, and can you just enlighten us on that?
Sure. Being cognizant of time, I'll be short here. So what really happens is we try to, imbibe and look at the real life scenario with a clinical trial so that doctor really knows that what kind of, therapy I'm providing. Is it working and to what extent it's working? And because at the end of the day, in real life, the scenario is so very different, unlike a standard clinical trial on the basis of which typically the decisions are made. So wherein what we do is, now think of it, if in case we are talking about a number of diabetes drugs being put for a diabetes patient, there it could be the standard diagnostics which we kind of keep putting it at every 6 months, 4 months, etc. Or a classical case which kind of I would say industry is somehow not using so much, and this links to the point which Jay was also mentioning, bringing the patient touch. And here I'll give a very interesting example. Think of it, patient-reported outcome measurement prompts as a subject. Somehow we are not leveraging. I'll be honest here, and probably the role here is to kind of engage the patient more. And a classical case in point would be, last year I was kind of talking at University of Hyderabad, for which I did a small study. I, with the help of some of the service providers, obviously randomized and blanked out, we kind of studied almost about 74 programs for which data was available, of which only 2 introduced patient-reported outcome measurements. And the beauty was, in both of these particular programs, pre and post, the patient engagement levels and outcomes both improved considerably. Now, we didn't have so much of data points to really do any kind of statistical analysis on that. But this particular measurement one is obviously, leading to better engagement with the patient, and both were kind of, for conditions which impacted elderly. Their compliance also, increased. And as a matter of fact, typically a lot of these programs, they do measure when a doctor says, visit me after so many days. So it could be, a repeat visit after, say, 6 weeks, 2 months, etc. The number of misses was kind of in single digit, which is phenomenal. And, matrices can be built based on program. Now, only thing is like, there's no one size that fits all.
No, thank you. That helps. Kunal, the next, you are on the front end. Let's put it this way. What are the challenges? Let's talk about, we're in the interest of time, we're going to kind of just wrap this up, but you are the closest possibly to the patient, to delivering care, to kind of, what do you feel are the challenges, or what can be improved, or what could be enhanced, so to speak, to kind of ensure that, the best possible care is given in the most appeasing or comfortable of ways?
So I think that's a very pertinent question, and there is a very simple answer to it. As diagnosticians, we should remember that whatever sample we get, there is a patient behind each sample. The moment you look at a case with that approach, the way you approach a case changes completely. We need to understand, let's say, I look at histopathology. So I'll like to give you an example. There was a case of an acute myeloid leukemia which came, and this boy had a skin lesion for last 2 years. And TDT is a marker of lymphoblasts in pathology. So somebody had seen this, and it was rich in T cells. So they called it T lymphoblastic lymphoma/leukemia. So the clinician called me and said that the patient had AML, and now the patient has T lymphoblastic leukemia/lymphoma, and the same diagnosis has been given by 2 centers. So when I saw the slide, it was indeed T cells which were proliferating. It was TDT positive. But a T lymphoblastic lymphoma leukemia, a single lesion, for 2 years, you will not see that clinically. So the moment you have a patient-oriented holistic approach, you tend to start thinking differently. Eventually, I subjected that to T-cell receptor studies, and it was a polyclonal population. And very few cases have been reported, but it was actually an indolent T lymphoblastic proliferation, which is non-neoplastic. Now, just imagine the two diagnoses and imagine what would happen. You know, our diagnosis is what the management depends upon. As I told you, that today's pathologist is far beyond diagnosis. We give the clinician what mutations are present so that they can use targeted treatment. We give whether PDL1 is positive or not so that they can give immunotherapy. So the whole management rests on us. Another case, very similar case, was of a patient who was referred to me, a lung mass, and huge lung mass, you know, and it was reported outside as colorectal adenocarcinoma. Now, for everybody in the audience, we have, for lung adenocarcinomas, we have TTF1, which is a marker, and for colorectals, we have CDX2 and SAT-B2. Now, the pathologist didn't do anything wrong. When I analyzed the case, it was negative for TTF1, which is the lung, and it was positive for CDX2 and focally staining for SAT-B2. So was it colon? But the problem was when they did a colonoscopy, there was nothing in colon. So how do they treat this? So again, you know, there is a variant called pulmonary enteric adenocarcinomas, which are lung adenocarcinomas. They are negative for lung markers, but they stain positive for colorectal markers. So, you know, the moment you have that holistic approach as a diagnostician, I think that would change a lot of things in you know, how we go forward. Thank you.
Dr. Shilika, is she still there? Because now we just get her on for one last question. If she's not there, we can... Okay. Yeah, Dr. Shilika, you spoke about... Yeah, you can hear me. Yeah, okay. I've been here. So, you spoke about dental diagnostics per se. I wanted to, you know, there are a lot of advances in... So, by the way, just to let you know, 25 years I've been an implantologist, so I understand. Been a clinician before I moved on to the Manipal group in management in various capacities. So when you do diagnostics, are you talking about guided surgeries? You're talking about implant planning? You're talking about reconstructive surgeries as well? Or you're just talking, because I assumed that you were just, you know, talking a little bit about what all diagnostics can do, but where is it headed and how does it benefit the advanced surgical, you know, cases is what we wanted to hear from you.
Right. So when it comes to diagnostics at VScan, my startup, we cover the full array. So when it comes to the first step is like your basic checkup, which is you know, where you require a 2D scan, which is the OPG. We provide OPG scans. When it comes to you know, CBCT, which is a 3D scan, that we provided for a single root canal as well to a full mouth implant surgery. That means we take the scan, we analyze it, we plan the treatment, we take the burden of diagnosing alone away from the doctor, in the context of that we use these scans to create data points and create a diagnosis and plan the treatment in collaboration with the doctor. So we collaborate with them, we plan the treatment, the doctor executes the treatment. Many times we take a post-operative scan to you know, give that doctor the surety and you know, of course that doctor is able to then use that scan as a patient education tool, which is a very important factor for dentists and you know, doctors as well. When you have something, you can actually show your patient that, see, this is what it was like, this is what it is now. It really changes the mindset and it brings about trust. Apart from this, we are also working in the oral cancer screening space. Over 35% of the global burden of oral cancer comes from India, and in India I can say over 80% of the cases are diagnosed at stage, you know, at a stage where treatment you know, is challenging, and it is more surgical than you know, they have to, I mean, when it comes to oral cancer, it's not just like any other cancer, because a part of your face gets removed, right, which and your face, to most people, a face is their identity, your face, your name. These are things which define who you are. So it's a big emotional and a mental battle for a patient I mean, the patients I've seen with oral cancer, I cannot explain. While of course every cancer is very, very difficult to deal with, oral cancer really you know, it really impacts people at very deep level. So I think for us, we are trying to screen at an earlier stage and detect it early. We're a touch point for over 3,000 patients who walk in today for dental diagnostics, and my target is to take this number up, to go into the lakhs on a monthly basis and screen more people for their oral health, etc. We're also adding intraoral scanning as a service, which is creating a 3D digital model of your mouth in the computer, which again allows you to plan better, design better, and these are the primary tests which are currently happening. Now on the futuristic side of things, salivary biomarker testing is picking up, wherein they are internationally, a lot of people are seeing whether saliva can act as give you those, use biomarkers in the saliva instead of going in for blood, because that becomes less technique sensitive, it becomes quicker. There is research happening. We are in talks with people to launch salivary biomarker testing as well. Apart from that, I see 2 to 3 years from now, AR, VR and the link between robotics. Can a dentist sitting in India treat a patient outside of India using a robot and using a digital system that can connect and relay information from here to there without lag? Or can a dentist in Bombay treat a patient in Bangalore, for example, right? So these are the things that we are looking as an organization to be able to facilitate, to create a network of distribution of the best technology, right, to each and every dentist, and to also ensure that the outcomes are improving using technology as an enabler today. And tomorrow, of course, we see physical centers and we see technology acting as two products on their own, bringing the ecosystem together. So that's what I see, and I think dentistry is on the rise. We've had over $250 million come into the in the industry to facilitate dental treatment, to drive access, to drive availability across various startups and chains. And I think diagnostics, and that's the reason I have bet my everything in life on it, is I think this is going to be a game changer in dental as well, and actually disrupt the industry in a positive manner.
Thank you so much. So just to conclude, first of all, I think we've had a very interesting discussion, and we've got, fair representation from various parts of the industry which make up the ecosystem, which actually defines patient outcomes. So patient outcomes is just a word, but there is a like I said, a universe out there which needs to be catered to kind of look at the final product. Technology, like we said, is an enabler, but at the end of the day, there is a human out there who needs to be also, we need to hold their hand, we need to manage them, we need to kind of look at what their needs are. And while there could be enough and more of research, engineering improvements, technology, applications, processes, but at the end of the day, I think as a doctor, nothing gives you more happiness than a patient who kind of gets treated, and at the same time, you gain their trust, for them to have trust in you, which leads to compliance, which leads to the outcome. Thank you so much, ladies and gentlemen, and thank you, everyone.
Thank you so much for sharing your insights on this particular topic. We request you all to please step ahead for a group photo op, and I would like to invite Mr. Kamal Narayan to kindly join us for this group photo op. A very warm welcome to you, sir. Ladies and gentlemen, can we please thank all the dignitaries and welcome Mr. Kamal Narayan back on stage. We request you to please pose for a group photo op and share those beautiful smiles to make it a memorable moment. We shall now be presenting a token of memento. We shall be presenting the memento to Mr. Surajit Mukherjee, Chief Business Officer, Niramai Health Analytics. We shall be also presenting the memento to Dr. Captain Sandeep Sharma, CEO, Manipal Health Map. Thank you so much, sir, for moderating the session for us. We shall now be presenting the memento to Mr. Raghavendra Godwaggu, Global CEO, AMP Group. Thank you so much for sharing your insights along with us. We shall now be presenting the memento to Mr. Jay Parekh, Director, Customer Experience, IHS Diagnostics. Thank you so much for sharing your insights, sir. We shall now be presenting the memento to Mr. Sanchit Nanda, Senior Director, Global Patient Solutions, Gilead Sciences. Thank you so much, sir. And Dr. Kunal Sharma, Associate Director and HOD, Center of Excellence and Histopathology, Global Reference Laboratory, IHS Diagnostics. Thank you so much for sharing your insights. Thanks a lot. We request you to please join us for the upcoming next sessions. Please stay with us. Thank you. Coming up next, the next segment is a spotlight address delivered by Dr. Sanjay Maheshwari, cancer surgeon, urologist, and medical director, MP Birla Group of Hospitals. A very warm welcome to you, sir. Well, I remember mentioning about having a little bit of blood circulation by putting our hands together and welcoming our next guest on stage. Thank you.
No. No. Yeah. Hello. Good afternoon, everyone. I think so. It's time for lunch. Looks like that. I just would like to take 10 minutes exactly, quickly, because most of the discussion which we had in the previous session was very comprehensive and very elaborative, touching upon all the sides of healthcare per se. Now, I just want to, what I see here in this crowd is a crowd coming from big cities. And I am from a very small town and you can say a rural-based model. For last 4 decades, I have been working in a small village which had a population of 40,000, 50,000 people. Now it has grown to a big city. So this is the hospital which I have in Satna, which is belonging to our group, MP Birla Group. And now this is into 5 wings we have, spread on 100 acres. And these are the group of hospitals which we have in big cities: Bombay Hospital, Bombay, Indore. Then we have Bellevue Clinic, Calcutta. We have one in Chittor, one in Sindhi district. This is the cancer unit where, because my basic training is as a cancer surgeon, so we have started a cancer unit to 2008, state of art with Linac. And to tell you that affordable healthcare remained the key thing for me and for our group per se. So we started state-of-art Linac brachytherapy with a cost of 18,000 rupees for the whole 1.5 month treatment. It was the cheapest Linac therapy in whole world. And we could treat many thousands of patients in the first year only, because there's no facility of such kind in that region in 2008, but the hospital was started about 33 years ago. So this was the hospital which when I was young, when I joined this hospital 33 years ago, there was no tree. It was a dry land. It is the cement city of India. And this is what it is now. We are spread on that, and more than 2 lakh trees are there. So taking care of environment and becoming a hospital which is surrounded by oxygen cylinder of this jungle is the most important thing, and which we saw this during the time of COVID. It was very helpful for this people. You can see we have our cable unit there. This is an aerial view, and we have our cement plant and city. And what I wanted to emphasize upon this crowd, because I see leaders from various industries, from various specialities, and from various hospitals, diagnostic, is that we must have joining hands in training program. Otherwise, to treat 140 crore people, and then after say about another 20 years, we will be 170, will be 200 crores. The tip of iceberg on healthcare will just remain a challenge for the coming years without really going into the cause and without going into R&Ds. So I think so a lot of points which were raised I have noted down, and as a healthcare leader in rural area, I have understood that you people are doing wonderful things. Now what is required is with the effort of Kamal and his IHW team, I want to send you a message that we must train people and we must skill develop. And I started this program in 2000, where we have trained 4,800 underprivileged kids, child labor kids, who were collecting panni, gobar, kachra, प्लास्टिक जमा करते थे और 2 रुपये उनको दिन के मिलते थे, और अब वो 45,000 से 50,000 हर महीने का कमाते हैं सैलरी में, और वो मेरे साथ कैंसर सर्जरी में असिस्ट कराते हैं, और कई लोग तो सिजेरियन का पहला इंसिशन भी लगाते हैं. मतलब मैं आपको इसलिए बताना चाह रहा हूँ, वो बच्चे जो कि 10वीं पास थे, हम लोगों ने बहुत बड़ा प्रोग्राम लिया है, and now we are taking up 20,000 students in UP. तो एक upscaling कर रहे हैं. नीति आयोग people had, I think so in the evening we will have some people coming from नीति आयोग. तो I was in discussion with नीति आयोग. There is a need when we talk about people, those who are on a larger scale of treatment, then we have to have training program, which is the most important thing. And as like our histopathologist talked, like people from pharma industry talk, there is a need for rural-based research and development program. See, you can't be treating people looking into city, because इन लोगों के पास 10 रुपया भी नहीं रहता जो treatment करा सके. 80% of my population stays in villages, and by the time they reach Bombay, Pune or Nagpur, their diseases are from stage 1 to stage 4. मैं आपको दिखाऊंगा उसका एक just. We started the first telemedicine center in this country in North India in 1996 with ISDN line. 4 ISDN लाइन से हम लोगों ने चालू किया था. टेलीपैथोलॉजी, टेली रेडियोलॉजी उस ज़माने में जब किसी ने देखा नहीं था उसमें. तो कर सकता है इंसान आसानी से, अगर आप लगन से काम करें, आप लीडर डेवलप करें. You all are leaders, but now you will have to percolate many more leaders through these type of programs. Otherwise ये साइंस आपके साथ जाएगा 140, 170, अपन लोग बस टिप ऑफ द डिजीज़ को ही ट्रीट करेंगे. पूरा आइसबर्ग जो है वो नीचे है इस कंट्री में, सभी कंट्रीज़ में नीचे ही धंसा हुआ है. तो अगर आप उसको ट्रीट नहीं कर, ये मैं मैसेज दे रहा हूँ, ये कोई ऑरेशन नहीं है, ये कोई लेक्चर नहीं है. मैं सिर्फ इतना बताना चाह रहा हूँ कि मेरी जीवन का जो 40 साल जो मैंने गाँव में दिया है, वो आपको देना चाहता हूँ कि आप इसको और आगे बढ़ाएं और आपके साथ जो भी काम करता है उसको बोलें कि गांव में जाइए, गांव में असली डिजीजेस गांव में ही हैं। शहरों में वही आता है जो गांव से हार जाता है, और बाकी शहर वाले तो बीमार पड़ते हैं तो उनका तो ट्रीटमेंट हो ही जाता है। ये वो बच्चे हैं जो कि चाइल्ड लेबर थे, एंड यू कैन सी ILO की चीफ जेंडा ऑफिसर सतना आई थी, और इस तरह से वो लोग का ट्रेनिंग प्रोग्राम हम लोग करते हैं। नाउ देयर इज अ नीड फॉर डेटा एनालिसिस विच हैज़ बीन ओवर एम्फेसाइज्ड in all the conferences we try to talk about, and spreading the knowledge which I was talking about. And of course we are into a lot of new technologies with international partners onto sensing technologies. We have histopathology का जिसकी बात चल रही थी, digitalization का, we have more than 40,000 digitalized slides. We have done it 2 decades ago. So I got the first CD from Singapore. Apple की पहली CD मैं लेके आया था इस कंट्री में। मैं आपको इसलिए बताना चाहता हूँ कि ये काम हो रहा है, गांव में ये काम हो रहा है। वेलोर में प्रोफेसर मामन चंडी के साथ जब मैं काम करता था तो I have seen all this. Sandeep is here. I am a student from Manipal, and Dr. Ramdas Pai came to Satna to see our work which we have done, and recently I was in Manipal to give the keynote on to rural healthcare, which is the thing. तो अब जो है मैनलेस हिस्टोपैथोलॉजिस्ट हो जाएगी, हमें ज़रूरत नहीं लगेगी। ऐसी चीज़ें अब बन रही हैं, इलिनॉय में वी आर वर्किंग ऑन इट। सो इट विल बी ए नीडल which will be required. It will take the tissue, it will auto-analyze, and it will give the report with AI, which you will have to finally see it. I'm not saying that, but yeah, that's the one. And of course, this is what we get the disease. It went into Guinness Book of Records. We removed 66 kg tumor from patient's belly. This is the size which you get. So basically diseases, they don't reach you. शहरों में पहुंचते पहुंचते बहुत तो मेरा और रवि का जब भी डिस्कशन होता है, रवि कन्नन हु इज वर्किंग इन सिलचर, तो हम लोग यही बोलते हैं कि गांव में अगर आप लोग देखेंगे तो बीमारियां इस तरह से 66 kg ट्यूमर में 80 इंचेस के डाया में आपको मिलेंगी। और फिर वो रूबिक क्यूब का तो मैं बता ही चुका हूँ। वी स्टार्टेड द फर्स्ट टेलीमेडिसिन सेंटर बिकॉज आवर पॉलिटिशियंस दे डोंट हैव टाइम फॉर हेल्थ केयर। तो बोले कि मेरे पास टाइम नहीं। मैंने कहा सर हम एयरपोर्ट पे ही आपको दिखा देंगे। तो खजुराहो एयरपोर्ट पे ही हमने टेलीमेडिसिन सेंटर 2007 में उनको दिखाया था करके। ऑफ कोर्स वी हैड द फर्स्ट टेली कार्डियोलॉजी कॉन्फ्रेंस फ्रॉम सतना. And then we have one unique program which I wanted to share with you is the skill development program, and our students are going to various centers. BITS Pilani Hyderabad campus में genomics में जाते हैं। तो पहले जो पहला बैच है वो हमारे घर में उनका पर्सनल इंटरव्यू लिया जाता है। इन बच्चों ने पहली बार ट्रेन देखी थी, पहली बार ये कैंपस में गए थे, पहली बार शहर में गए थे। ये गांव के सीधी डिस्ट्रिक्ट के बच्चे हैं, तो उनके चेहरों पे खुशी और इस तरह से जो प्रोग्राम्स होते हैं ये कम्युनिटी कॉलेज के। ऑफ कोर्स आई एम नॉट जस्ट गोइंग थ्रू ऑल द स्लाइड्स बिकॉज ऑफ टाइम इज़ लेस, बट या वेरियस प्रोग्राम्स ऑफ सर्टिफिकेशन प्रोग्राम्स विच वी रन देयर, एंड ऑफ कोर्स दीज आर all kind of training programs which we do, and very sincerely it's being done. We have 300 bedded hospital which we are running there, and then इन लोगों को पूरा इस तरह से ट्रेनिंग करते हैं कि ये 6 महीने में 1 साल में बहुत अच्छे हो जाते हैं। उनका ग्रेजुएशन भी इनको सम्मानजनक स्थिति में दिया जाता है ताकि इनके पेरेंट्स लोगों को ये लगे कि हमारे बच्चे जो हैं, जब तक आप इनको कम्युनिटी में ट्रेन नहीं करेंगे तब तक ये आपकी हेल्थ केयर में कोई भी मॉडल को आप सक्सेसफुल नहीं बना सकते इस कंट्री में। इन बच्चों को आपको सिखाना पड़ेगा कि आपकी बीमारी क्या है, और पहली स्टेज में ये बच्चे जब पकड़ते हैं उस बीमारी को, और ये अगर करेंगे तो इस तरह से ये आते हैं, और फिर जब ट्रेन होके जाते हैं तो फिर नाउ आई हैव बीन this is which we have what I wanted to pass. One more message was that we got to have international good institute collaborations also, apart from India के जो top institute हैं वो help करें. The problem is most of the teaching hospitals in this country, most of the big institute in this country, they don't come to small places. They are not coming to smaller cities or villages. वो बस फिर वो ROI देखने लग जाते हैं. तो मैं तो आपके RIL रैनबैक्सी लैब में मैंने बहुत मेहनत करी थी मारवा जी के साथ आज से 25 साल पहले, लेकिन कोई आया नहीं हमारे शहर में क्योंकि ROI नहीं निकलता था. The problem is with most of the people of diagnostics, सब लोगों को आना पड़ेगा तब हम बहुत बड़ा डेटा क्रिएट कर सकते हैं. This is breast bras which we have developed. उसका FDI हमको अप्रूवल भी मिल गया है. इसमें नैनो पार्टिकल स्मीयर थर्मल की जो कोई बात कर रहे थे उससे भी बेटर है ये टेक्नोलॉजी. एंड ऑफ कोर्स just to conclude here is that I want to pass on a message to most of you is that my 4 decades of work in a rural healthcare was a very significant one. I was trained from one of the top institute of this country and then in Cornell, but I chose small place because I felt that's where 80%, 90% of Indian population is there. तो आप जब इनको ऑपरेट करते हैं, आप जब इनको देखते हैं, जब आप इनको असहाय पाते हैं, तो शायद ऐसी कॉन्फ्रेंसेस का मतलब और बढ़ जाता है. और मैं मेरे तरफ से, मेरे इंस्टीट्यूट की तरफ से कमल और उसकी टीम को धन्यवाद देना चाहता हूँ आप सभी लोगों का कि आपने खाने के इस मौके पे मुझे सुना, एक छोटे से गांव के सर्जन को सुना. लेकिन मेरा संदेश आप लोगों के लिए ये ज़रूर है कि आप जब आगे जाएं तो ट्रेनिंग के लिए बच्चों को प्रेरित करें और अपने नॉलेज को, क्योंकि लाइफ बड़ी छोटी सी है, तो इसमें देके जाएं. देके जाने के लिए सिर्फ ROIs नहीं चाहिए. हमारा ग्रुप जो है MP बिरला ग्रुप ने बहुत काम किया है फिलैंथ्रॉपी में. तो मैं आपको बताना चाहता हूँ कि उस तरह के काम को अगर आप आगे बढ़ाएंगे तो ये इस तरह की कॉन्फ्रेंसेस, पेशेंट फर्स्ट जो लाल कलर में आई है, तो आई हैज़ टू गिव टू पेशेंट फर्स्ट. तो मैं जब खुद करूँगा, पहली बार करूँगा, तब इस जो पिंक कलर की सार्थकता आएगी. और जितने लोगों ने यहाँ पे नीचे स्पॉन्सर किया है, मेरी आप लोगों से रिक्वेस्ट है कि गांव में जाइए, गांव में बहुत काम है. और हमारे प्रधानमंत्री जी का मैं संदेश देना चाहता हूँ कि आज भारत को एक ऐसा प्रधानमंत्री और एक अच्छी ऐसी टीम मिली है जिसमें कि हम लोग बहुत सारा काम कर सकते हैं. और आने वाला भविष्य आपका मंगलमय हो, आने वाली दिवाली आपके लिए मंगलमय हो, इसी कामना के साथ धन्यवाद.
Sir, आपका बहुत बहुत धन्यवाद. I'm certain that we all believe in this one saying that the most toughest experiences come from the humble beginnings. Right, ladies and gentlemen. Sir, thank you so much for sharing your insights. Not being from a medical industry, but understanding every word that you shared. Well, I think it's the most biggest blessing for us. Okay, well, ladies and gentlemen, it's now time for lunch, and we have a very short networking lunch break. We request you all to please be back by 2:10. If possible, so that we can start the next session on time. We thank you so much for your cooperation and see you all post-lunch. Thank you.
village in the state of Tamil Nadu in India, a healing journey begins. Meet Paril, a vibrant 6-year-old boy whose infectious laughter and love for adventure have captured the hearts of everyone around him in the family. Paril's father, Vardharajan, a hard-working farmer, toils under the warm sun, providing for his beloved family. As the day comes to a close, they all come together, basking in the joy of each other's company. Paril's storytelling, a cherished tradition, fills their hearts with happiness. But life can take unexpected turns. Paril fell severely ill, and a shadow of worry descended upon this close-knit family.
என் பேர் வரதராஜனுங்க. சத்தியமங்கலம் தாலுக்கா சிக்கரசம்பாளையம் கிராமத்தில் ராம்பயிலுங்கிற இடத்துல இருக்கிறேன். எனக்கு வந்து 2 பசங்க. அதில் வந்து பெரிய பையன் பேர் பாரில். அவன் வந்து ஸ்கூலுக்கு போயிட்டு இருந்தான். ஸ்கூலுக்கு போயிட்டு டெய்லி ஸ்கூலுக்கு போவான், வருவான், விளையாடுவான், நல்லா ஹெல்த்தியாக தான் இருந்தான். அப்புறம் பார்த்தீங்கன்னா திடீர்னு ஒரு நாள் அவனுக்கு வயிற்று வலி வந்துச்சு. அப்போ நாங்கள் அந்த மாதிரி ஹாஸ்பிட்டலில் பக்கத்தில் போய் பார்த்தோம். பார்க்கும்போது இந்த மாதிரி அவங்க சரின்னு சொல்லிட்டு வயிற்று வலிக்கு மருந்து மாத்திரை கொடுத்தாங்க. சரின்னு வந்தோம். திருப்பி 2-3 நாள் கழித்து மறுபடியும் வயிற்று வலி வந்துச்சு. அப்படி என்னன்னா எனக்கு வந்து ரொம்பவே அப்செட் ஆயிடுச்சு. இந்த மாதிரி எனக்கு பிடிச்ச பையன், ரொம்ப என்னோடய குழந்தை வந்து எனக்கு ரொம்ப அவன் மேலே நான் ரொம்ப பிரியமாக ஆசையாக இருப்பேன். ஸ்கூலுக்கு போயிட்டு நல்லா விளையாடிட்டு இருந்த பையன் திடீர்னு இந்த மாதிரி ஆகவும் ரொம்பவே நான் வந்து மனசு ஒடிஞ்சு ரொம்ப இதாகிட்டேங்க ஃபஸ்ட் டைம். அப்புறம் தான் ஹாஸ்பிட்டல் போய் பார்த்தேங்க. பார்த்ததுக்கு தான் இந்த மாதிரி ஆப்ரேஷன் பண்ணி ஆகணும் அப்படின்னு சொன்னாங்க. சரி பண்ணிக்கலாம் அப்படின்னு சொல்லிட்டு பண்ணணுங்க.
In their pursuit of hope, they reach Hindustan Hospital, where they meet Dr. Ramalingam, a beacon of healing in the city of Coimbatore. In the heart of nature, amid the serenity of a quaint village in the state of Tamil Nadu in India, a healing journey begins. Meet Paril, a vibrant 6-year-old boy whose infectious laughter and love for adventure have captured the hearts of everyone around him in the family. Paril's father, Vardharajan, a hard-working farmer, toils under the warm sun, providing for his beloved family. As the day comes to a close, they all come together, basking in the joy of each other's company. Paril's storytelling, a cherished tradition, fills their hearts with happiness. But life can take unexpected turns. Paril fell severely ill, and a shadow of worry descended upon this close-knit family.
என் பேர் வரதராஜனுங்க. சத்தியமங்கலம் தாலுக்கா சிக்கரசம்பாளையம் கிராமத்தில் ராம்பையிலுங்கிற இடத்துல இருக்கிறேன். எனக்கு வந்து 2 பசங்க. அதில் வந்து பெரிய பையன் பேர் பாரில். அவன் வந்து ஸ்கூலுக்கு போயிட்டு இருந்தான். ஸ்கூலுக்கு போயிட்டு டெய்லி ஸ்கூலுக்கு போவான், வருவான், விளையாடுவான், நல்லா ஹெல்த்தியாக தான் இருந்தான். அப்புறம் பார்த்தீங்கன்னா திடீர்னு ஒரு நாள் அவனுக்கு வயிற்று வலி வந்துச்சு. நாங்கள் அந்த மாதிரி ஹாஸ்பிட்டலில் பக்கத்தில் போய் பார்த்தோம். பார்க்கும்போது இந்த மாதிரி அவங்க சரின்னு சொல்லிட்டு வயிற்று வலிக்கு மருந்து மாத்திரை கொடுத்தாங்க. சரின்னு வந்தோம். திருப்பி 2-3 நாள் கழிச்சு மறுபடியும் வயிற்று வலி வந்துச்சு. அப்படி என்னடா எனக்கு வந்து ரொம்பவே அப்செட் ஆயிடுச்சு. இந்த மாதிரி எனக்கு பிடிச்ச பையன், ரொம்ப என்னோடய குழந்தை வந்து எனக்கு ரொம்ப அவன் மேலே நான் ரொம்ப பிரியமாக ஆசையாக இருப்பேன். ஸ்கூலுக்கு போயிட்டு நல்லா விளையாடிட்டு இருந்த பையன் திடீர்னு இந்த மாதிரி ஆகவும் ரொம்பவே நான் வந்து மனசு ஒடிஞ்சு ரொம்ப இதாகிட்டேங்க ஃபஸ்ட் டைம். அப்புறம் தான் ஹாஸ்பிட்டல் போய் பார்த்தேங்க. பார்த்ததுக்கு தான் இந்த மாதிரி ஆப்ரேஷன் பண்ணி ஆகணும் அப்படின்னு சொன்னாங்க. சரி பண்ணிக்கலாம் அப்படின்னு சொல்லிட்டு பண்ணணுங்க.
In their pursuit of hope, they reach Hindustan Hospital, where they meet Dr. Ramalingam, a beacon of healing in the city of Coimbatore, who offers them a ray of hope. With a glimmer of optimism, they embark on a journey to find a cure for Paril. Dr. Ramalingam, a compassionate and skilled healer, his expertise and a new age surgical system hold the promise of a brighter future for Paril.
இல்லை ஃபஸ்ட்டு நாங்கள் போன உடனே வந்து அவர் இதை பார்த்துட்டு இங்கே சத்தியமங்கலத்தில் வந்து இந்த மாதிரி ஒரு ஸ்கேன் எடுத்திருந்தோம். அதை காமிச்சதுக்கப்புறம் அவர் வந்து பார்த்துட்டு நான் இங்கே ஒரு ஸ்கேன் பண்ணி பார்த்துக்கிறேன், இதான் வந்து இந்த மாதிரி ஸ்டோன் இருக்குது கன்ஃபார்ம் தான். அதுக்கப்புறம் வந்து அந்த யூரின் பிளாடருக்கு வர அந்த குழாயில் வந்து ஒரு பிளாக் இருக்குது, 2 இடத்துல பிளாக் இருக்குது, அடைப்பு இருக்குது, அந்த அடைப்பை எடுக்கணும் அப்படிங்கிறத ரோபோட்டிக் சர்ஜரி தான் பண்ண முடியும் அப்படின்னு அவர் சொன்னாருங்க. அப்போ வந்து எங்களுக்கு இப்போ இதாக தெரிஞ்சிச்சு என்னடா இந்த மாதிரி ஆயிடுச்சுன்ட்டு. அப்புறம் சரி பண்ணிக்கலாம் அப்படின்னு சொல்லி டாக்டர் ராமலிங்கம் சார் தான் வந்து ரொம்ப சொன்னாருங்க. இந்த மாதிரி கன்ஃபார்மாக வந்து நான் நல்லா பண்ணி தரேன், உங்களுக்கு எந்த பிரச்சனையும் இல்லை, நீங்கள் பயப்பட வேண்டியதில்லை.
A small boy, 6 years old, Paril, who had pain in the right side of the abdomen and fever, came to us about a month ago, and then on evaluation with the CT scan we found that was a 16 mm stone. This is quite a big one for a child of 6 years old. So the collecting system was not dilated. So normally what we will do is, if it is a big stone, we puncture the kidney and then go inside, make it into multiple small bits and then remove it, which will damage the functioning part of the kidney, especially in a child. If it is okay in an adult, but in a child there will be some damage, and if there is bleeding, then we have to do accessory procedures like controlling the bleeding with fluoroscopy and coiling and all, which is not very good for a child. On the other hand, if you go from below upwards through the natural passage of the urinary tract, then the tube may not be that wide enough to accommodate the instrument called the ureteroscopy. So that can result in the long term as what is called stricture. So that is also in the long term we need to keep on following the child. So what we thought is, in the normal course we would do a laparoscopic pyelolithotomy. So I have been very familiar and very comfortable with the laparoscopy, but still I thought why don't we give a shot of robotic surgery, because it can be much more precise in suturing, and the controlling the bleeding will be much more precise. So robotic surgery may be shared better for the pyelolithotomy in a child.
In the confines of the operation theatre, Dr. Ramalingam's skilled hands, guided by cutting-edge technology, work to heal young Paril. It is a moment of vulnerability and strength intertwined as a healing journey unfolds.
Using the SSI mantra, we did robotic pyelolithotomy for this child, and the procedure went on very smooth, and he was back home on the third day. And now after 2 months when we see him, so we followed up the child with ultrasound. He is so very cheerful, and the stone is totally taken out. We didn't break it, we just took the whole stone through one of the ports. Now there is no stone, no dilatation of the collecting system. The child is fine.
The healing journey of young Paril was made possible by a groundbreaking innovation, SSI Mantra, the Made in India surgical robotic system. The remarkable creation, SSI Mantra, was born with a noble vision to make affordable healthcare accessible to the underserved population all across the world. It stands as a testament to the dedication and ingenuity of Indian minds, transforming healthcare from cities to remote villages, touching lives with hope and healing. This technological marvel was once an unthinkable distant dream, but it is made possible by the resilience, commitment, compassion and dedication of unsung heroes striving for a healthier tomorrow for humanity. The Made in India spirit emboldens hearts, impacting lives as this collective effort drives SSI Mantra forward. It symbolizes a nation's resolve to empower its people with the gift of health, regardless of their background or means. The highly advanced SSI Mantra surgical robotic system, brimming with innovation and sophistication, has emerged as a game changer in the realm of surgical healthcare. Powered by the latest technology, it empowers doctors to perform with unparalleled precision and expertise.
என் பையன் பாரில் பேரரசுங்க மந்த்ரா ரோபோட்டிக் சிஸ்டமில் ஆப்ரேஷன் பண்ணதுக்கப்புறம் பழைய மாதிரியே ஆயிட்டான். எந்த பிரச்சனையும் இல்லை, நல்லா இருக்கான், ஸ்கூலுக்கு போகிறான், விளையாடுறான்.
In the heart of nature, amid the serenity of a quaint village in the state of Tamil Nadu in India, a healing journey begins. Meet Paril, a vibrant 6-year-old boy whose infectious laughter and love for adventure have captured the hearts of everyone around him in the family. Paril's father, Vardharajan, a hard-working farmer, toils under the warm sun, providing for his beloved family. As the day comes to a close, they all come together, basking in the joy of each other's company. Paril's storytelling, a cherished tradition, fills their hearts with happiness. But life can take unexpected turns. Paril fell severely ill, and a shadow of worry descended upon this close-knit family.
என் பேர் வரதராஜனுங்க. சத்தியமங்கலம் தாலுக்கா சிக்கரசம்பாளையம் கிராமத்தில் ராம்பையிலுங்கிற இடத்துல இருக்கிறேன். எனக்கு வந்து 2 பசங்க. அதில் வந்து பெரிய பையன் பேர் பாரில். அவன் ஸ்கூலுக்கு போயிட்டு இருந்தான். ஸ்கூலுக்கு போயிட்டு டெய்லி ஸ்கூலுக்கு போவான், வருவான், விளையாடுவான், நல்லா ஹெல்த்தியாக தான் இருந்தான். அப்புறம் பார்த்தீங்கன்னா திடீர்னு ஒரு நாள் அவனுக்கு வயிற்று வலி வந்துச்சு. அப்போ நாங்கள் அந்த மாதிரி ஹாஸ்பிட்டலில் பக்கத்தில் போய் பார்த்தோம். பார்க்கும்போது இந்த மாதிரி அவங்க சரின்னு சொல்லிட்டு வயிற்று வலிக்கு மருந்து மாத்திரை கொடுத்தாங்க. சரின்னு வந்தோம். திருப்பி 2-3 நாள் கழித்து மறுபடியும் வயிற்று வலி வந்துச்சு. அப்படி என்னடா எனக்கு ரொம்பவே அப்செட் ஆயிடுச்சு. இந்த மாதிரி என்னடா எனக்கு பிடிச்ச பையன், ரொம்ப என்னோடய குழந்தை எனக்கு ரொம்ப அவன் மேலே நான் ரொம்ப பிரியமாக ஆசையாக இருப்பேன். ஸ்கூலுக்கு போயிட்டு நல்லா விளையாடிட்டு இருந்த பையன் திடீர்னு இந்த மாதிரி ஆகவும் ரொம்பவே நான் மனசு ஒடிஞ்சு ரொம்ப இதாகிட்டேங்க ஃபஸ்ட் டைம். அப்புறம் தான் ஹாஸ்பிட்டல் போய் பார்த்தேங்க. பார்த்ததுக்கு தான் இந்த மாதிரி ஆப்ரேஷன் பண்ணி ஆகணும் அப்படின்னு சொன்னாங்க. சரி பண்ணிக்கலாம் அப்படின்னு சொல்லிட்டு பண்ணணுங்க.
In their pursuit of hope, they reach Hindustan Hospital, where they meet Dr. Ramalingam, a beacon of healing in the city of Coimbatore, who offers them a ray of hope. With a glimmer of optimism, they embark on a journey to find a cure for Paril. Dr. Ramalingam, a compassionate and skilled healer, his expertise and a new age surgical system hold the promise of a brighter future for Paril.
இல்லை ஃபஸ்ட்டு நாங்கள் போன உடனே வந்து அவர் இதை பார்த்துட்டு இங்கே சத்தியமங்கலத்தில் வந்து இந்த மாதிரி ஒரு ஸ்கேன் எடுத்திருந்தோம். அதை காமிச்சதுக்கப்புறம் அவர் வந்து பார்த்துட்டு நான் இங்கே ஒரு ஸ்கேன் பண்ணி பார்த்துக்கிறேன், இதான் வந்து இந்த மாதிரி ஸ்டோன் இருக்குது கன்ஃபார்ம் தான். அதுக்கப்புறம் வந்து அந்த யூரின் பிளாடருக்கு வர அந்த குழாயில் வந்து ஒரு பிளாக் இருக்குது, 2 இடத்துல பிளாக் இருக்குது, அடைப்பு இருக்குது, அந்த அடைப்பை எடுக்கணும் அப்படிங்கிறத ரோபோட்டிக் சர்ஜரி தான் பண்ண முடியும் அப்படின்ட்டு அவர் சொன்னாருங்க. அப்போ வந்து எங்கள் இப்போ இதாக தெரிஞ்சிச்சு என்னடா இந்த மாதிரி ஆயிடுச்சுன்ட்டு. அப்புறம் சரி பண்ணிக்கலாம் அப்படின்னு சொல்லி டாக்டர் ராமலிங்கம் சார் தான் வந்து ரொம்ப சொன்னாருங்க, இந்த மாதிரி கன்ஃபார்மாக வந்து நான் நல்லா பண்ணி தரேன், உங்களுக்கு எந்த பிரச்சனையும் இல்லை, நீங்கள் பயப்பட வேண்டியதில்லை.
A small boy, 6 years old, Paril, who had pain in the right side of the abdomen and fever, came to us about a month ago, and then on evaluation with the CT scan, we found that was a 16 mm stone. This is quite a big one for a child of 6 years old. So the collecting system was not dilated. So normally what we will do is, if it is a big stone, we puncture the kidney and then go inside, make it into multiple small bits and then remove it, which will damage the functioning part of the kidney, especially in a child. If it is okay in an adult, but in a child there will be some damage, and if there is bleeding, then we have to do accessory procedures like controlling the bleeding with fluoroscopy and coiling and all, which is not very good for a child. On the other hand, if you go from below upwards through the natural passage of the urinary tract, then the tube may not be that wide enough to accommodate the instrument called the ureteroscopy. So that can result in the long term as what is called stricture. So that is also in the long term we need to keep on following the child. So what we thought is, in the normal course we would do a laparoscopic pyelolithotomy. So I have been very familiar and very comfortable with the laparoscopy, but still I thought why don't we give a shot of robotic surgery, because it can be much more precise in suturing, and the controlling the bleeding will be much more precise. So robotic surgery may be a shade better for the pyelolithotomy in a child.
In the confines of the operation theatre, Dr. Ramalingam's skilled hands, guided by cutting-edge technology, work to heal young Paril. It is a moment of vulnerability and strength intertwined as a healing journey unfolds.
Using the SSI mantra, we did a robotic pyelolithotomy for this child, and the procedure went on very smooth, and he was back home on the 3rd day. And now after 2 months when we see him, so we followed up the child with ultrasound. He is so very cheerful, and the stone is totally taken out. We didn't break it, we just took the whole stone through one of the ports. Now there is no stone, no dilatation of the collecting system. The child is fine.
The healing journey of young Paril was made possible by a groundbreaking innovation, SSI Mantra, the Made in India surgical robotic system. The remarkable creation, SSI Mantra, was born with a noble vision to make affordable healthcare accessible to the underserved population all across the world. It stands as a testament to the dedication and ingenuity of Indian minds, transforming healthcare from cities to remote villages, touching lives with hope and healing. This technological marvel was once an unthinkable distant dream, but it is made possible by the resilience, commitment, compassion and dedication of unsung heroes striving for a healthier tomorrow for humanity. The Made in India spirit emboldens hearts, impacting lives, as this collective effort drives SSI Mantra forward. It symbolizes a nation's resolve to empower its people with the gift of health, regardless of their background or means. The highly advanced SSI Mantra surgical robotic system, brimming with innovation and sophistication, has emerged as a game changer in the realm of surgical healthcare. Powered by the latest technology, it empowers doctors to perform with unparalleled precision and expertise.
என் பையன் பாரில் பேரரசுங்க மந்த்ரா ரோபோட்டிக் சிஸ்டமில் ஆப்ரேஷன் பண்ணதுக்கப்புறம் பழைய மாதிரியே ஆகிட்டான். எந்த பிரச்சனையும் இல்லை, நல்லா இருக்கான், ஸ்கூலுக்கு போகிறான், விளையாடுறான்.
In the heart of nature, amid the serenity of a quaint village in the state of Tamil Nadu in India, a healing journey begins. Meet Paril, a vibrant 6-year-old boy whose infectious laughter and love for adventure have captured the hearts of everyone around him in the family. Paril's father, Vardharajan, a hard-working farmer, toils under the warm sun, providing for his beloved family. As the day comes to a close, they all come together, basking in the joy of each other's company. Paril's storytelling, a cherished tradition, fills their hearts with happiness. But life can take unexpected turns. Paril fell severely ill, and a shadow of worry descended upon this close-knit family.
என் பேர் வரதராஜனுங்க. சத்தியமங்கலம் தாலுக்கா சிக்கரசம்பாளையம் கிராமத்தில் ராம்பையிலுங்கிற இடத்துல இருக்கிறேன். எனக்கு வந்து 2 பசங்க. அதில் வந்து பெரிய பையன் பேர் பாரில். அவன் வந்து ஸ்கூலுக்கு போயிட்டு இருந்தான். ஸ்கூலுக்கு போயிட்டு டெய்லி ஸ்கூலுக்கு போவான், வருவான், விளையாடுவான், நல்லா ஹெல்த்தியாக தான் இருந்தான். அப்புறம் பார்த்தீங்கன்னா திடீர்னு ஒரு நாள் அவனுக்கு வயிற்று வலி வந்துச்சு. நாங்கள் அந்த மாதிரி ஹாஸ்பிட்டலில் பக்கத்தில் போய் பார்த்தோம். பார்க்கும்போது இந்த மாதிரி அவங்க சரின்னு சொல்லிட்டு வயிற்று வலிக்கு மருந்து மாத்திரை கொடுத்தாங்க. சரின்னு வந்தோம். திருப்பி 2-3 நாள் கழித்து மறுபடியும் வயிற்று வலி வந்துச்சு. அப்படி என்னடா எனக்கு வந்து ரொம்பவே அப்செட் ஆயிடுச்சு. இந்த மாதிரி என்னடா எனக்கு பிடிச்ச பையன், ரொம்ப என்னோடய குழந்தை வந்து எனக்கு ரொம்ப அவன் மேலே நான் ரொம்ப பிரியமாக ஆசையாக இருப்பேன். ஸ்கூலுக்கு போயிட்டு நல்லா விளையாடிட்டு இருந்த பையன் திடீர்னு இந்த மாதிரி ஆகவும் ரொம்பவே நான் வந்து மனசு ஒடிஞ்சு ரொம்ப இதாகிட்டேங்க ஃபஸ்ட் டைம். அப்புறம் தான் ஹாஸ்பிட்டல் போய் பார்த்தேங்க. பார்த்ததுக்கு தான் இந்த மாதிரி ஆப்ரேஷன் பண்ணி ஆகணும் அப்படின்னு சொன்னாங்க. சரி பண்ணிக்கலாம் அப்படின்னு சொல்லிட்டு பண்ணணுங்க.
In their pursuit of hope, they reach Hindustan Hospital, where they meet Dr. Ramalingam, a beacon of healing in the city of Coimbatore, who offers them a ray of hope. With a glimmer of optimism, they embark on a journey to find a cure for Paril. Dr. Ramalingam, a compassionate and skilled healer, his expertise and a new age surgical system hold the promise of a brighter future for Paril.
இல்லை ஃபஸ்ட்டு நாங்கள் போன உடனே வந்து அவர் இதை பார்த்துட்டு இங்கே சத்தியமங்கலத்தில் வந்து இந்த மாதிரி ஒரு ஸ்கேன் எடுத்திருந்தோம். அதை காமிச்சதுக்கப்புறம் அவர் வந்து பார்த்துட்டு நான் இங்கே ஒரு ஸ்கேன் பண்ணி பார்த்துக்கிறேன், இதான் வந்து இந்த மாதிரி ஸ்டோன் இருக்குது கன்ஃபார்ம் தான். அதுக்கப்புறம் வந்து அந்த யூரின் பிளாடருக்கு வர அந்த குழாயில் வந்து ஒரு பிளாக் இருக்குது, 2 இடத்துல பிளாக் இருக்குது, அடைப்பு இருக்குது, அந்த அடைப்பை எடுக்கணும் அப்படிங்கிறத ரோபோட்டிக் சர்ஜரி தான் பண்ண முடியும் அப்படின்ட்டு அவர் சொன்னாருங்க. அப்போ வந்து எங்களுக்கு இப்போ இதாக தான் இருந்துச்சு, என்னடா இந்த மாதிரி ஆயிடுச்சுன்ட்டு. அப்புறம் சரி பண்ணிக்கலாம் அப்படின்னு சொல்லி டாக்டர் ராமலிங்கம் சார் தான் வந்து ரொம்ப சொன்னாருங்க. இந்த மாதிரி கன்ஃபார்மாக வந்து நான் நல்லா பண்ணி தரேன், உங்களுக்கு எந்த பிரச்சனையும் இல்லை, நீங்கள் பயப்பட வேண்டியதில்லை.
A small boy, 6 years old, Paril, who had pain in the right side of the abdomen and fever, came to us about a month ago, and then on evaluation with the CT scan we found that was a 16 mm stone. This is quite a big one for a child of 6 years old. So the collecting system was not dilated. So normally what we will do is, if it is a big stone, we puncture the kidney and then go inside, make it into multiple small bits and then remove it, which will damage the functioning part of the kidney, especially in a child. It is okay in an adult, but in a child there will be some damage, and if there is bleeding, then we have to do accessory procedures like controlling the bleeding with fluoroscopy and coiling and all, which is not very good for a child. On the other hand, if you go from below upwards through the natural passage of the urinary tract, then the tube may not be that wide enough to accommodate the instrument called the ureteroscopy. So that can result in the long term as what is called stricture. So that is also in the long term we need to keep on following the child. So what we thought is in the normal course we would do a laparoscopic pyelolithotomy. So I have been very familiar and very comfortable with the laparoscopy, but still I thought why don't we give a shot of robotic surgery, because it can be much more precise in suturing and the controlling the bleeding will be much more precise. So robotic surgery may be shared better for the pyelolithotomy in a child.
In the confines of the operation theatre, Dr. Ramalingam's skilled hands, guided by cutting-edge technology, work to heal young Paril. It is a moment of vulnerability and strength intertwined as a healing journey unfolds.
Using the SSI mantra, we did a robotic pyelolithotomy for this child, and the procedure went on very smooth, and he was back home on the third day. And now after 2 months when we see him, so we followed up the child with ultrasound. He is so very cheerful and the stone is totally taken out. We didn't break it, we just took the whole stone through one of the ports. Now there is no stone, no dilatation of the collecting system. The child is fine.
The healing journey of young Paril was made possible by a groundbreaking innovation, SSI Mantra, the Made in India surgical robotic system. The remarkable creation, SSI Mantra, was born with a noble vision to make affordable healthcare accessible to the underserved population all across the world. It stands as a testament to the dedication and ingenuity of Indian minds, transforming healthcare from cities to remote villages, touching lives with hope and healing. This technological marvel was once an unthinkable distant dream, but it is made possible by the resilience, commitment, compassion and dedication of unsung heroes striving for a healthier tomorrow for humanity. The Made in India spirit emboldens hearts, impacting lives as this collective effort drives SSI Mantra forward. It symbolizes a nation's resolve to empower its people with the gift of health, regardless of their background or means. The highly advanced SSI Mantra surgical robotic system, brimming with innovation and sophistication, has emerged as a game changer in the realm of surgical healthcare. Powered by the latest technology, it empowers doctors to perform with unparalleled precision and expertise.
என் பையன் பாரில் பேரரசுங்க மந்த்ரா ரோபோட்டிக் சிஸ்டமில் ஆப்ரேஷன் பண்ணதுக்கப்புறம் பழைய மாதிரியே ஆயிட்டான். எந்த பிரச்சனையும் இல்லை, நல்லா இருக்கான், ஸ்கூலுக்கு போகிறான், விளையாடுறான்.
Yeah, boo, I like it. No, I can't deny it. But I know you can tell I'm excited. Oh, girl. Step like you're dancing close. Feel a little boom coming through on you. Now, girl, I know you felt it. But boo, you know I can't help it. You know what I wanna do. Baby, move and cry. Oh, yeah. I get so excited. Feel so good. So real. Try, but I can't fight it. You. And it's so real. You know.
Close connection. Retro reloads. Got your head popping. Don't break your neck.
Find Close Connections on SoundCloud, YouTube, Mixcloud, or podcast at DJ Close Connection.
Every day now, I can feel you watching me from afar.
Good afternoon, everyone. Welcome back, ladies and gentlemen. We appreciate the ones who are here on time. Thank you so much. Can we have a huge round of applause for ourselves? It is time to break the ice post-lunch because that is the time wherein we get a little loosen up, isn't it? I was being told that this is going to be a very intact summit, so you're not allowed to make any jokes, any fun moments. So I mentioned that, okay, this is not going to happen at all, but there can be a little bit of icebreaker. So everybody please put your hands out, let the positivity in. Sir, if it is okay. Everybody please put both your hands up and let's clap on the count of 3. Okay, 3, 2, 1. Can it be a little harder? 3, 2, 1. Thank you so much. And Miss Himani is here. She's telling me, please wrap it up quickly. I shall obey to your orders. Ladies and gentlemen, so far we have discussed on the various topics, that is evolving healthcare systems and patient-inclusive models for universal health coverage and role of diagnostics in patient-centric health ecosystem. It is now time to move on to the next session of discussion, which is revamping hospitals for better quality care. Ladies and gentlemen, this session will be moderated by Dr. Sanjay Maheshwari, cancer surgeon, urologist, and medical director, MP Birla Group of Hospitals. Can we please welcome him with a huge round of applause? Welcome back, sir. I would also like to invite our speaker who will be joining us on stage, Dr. Shilpa Tatke, Group COO, Jupiter Hospital. A very warm welcome to you, ma'am. We would also be inviting Dr. Madan K. Gopal, Advisor, Public Health Administration, Division, National Health Systems Resource Center, who will be joining us virtually. And we have Dr. Urvashi Prasad, Director, VC Office, Niti Aayog, who will be joining us virtually as well. Ladies and gentlemen, as the session has been moderated by Dr. Sanjay Maheshwari, we hand it over to you, sir. Thank you so much.
Hello. Can you all hear me? Well, right. Good afternoon. I think so. You all had good lunch. Looks like that. People are silent and sleepy slowly. But anyway, this is going to be a very interesting subject which has been given to the best speakers from health sector and from policymakers of this country, from Niti Aayog. So I'll just, because this happens to be a very complex and a very interesting topic for which we have eminent panel today. So I welcome Dr. Shilpa and people, those who are joining us from online. Yeah, we have one more speaker who is joining, Dr. Madan. Can you hear me, Dr. Madan? Hello? Right. Your sound quality is also good and visuals are also good. Welcome, good afternoon, sir. This is Dr. Maheshwari this side, and by the side on the dais we have Dr. Shilpa from Jupiter Hospital, and Dr. Urvashi also will be joining us online. She is not there as it. So we will start the session, and the time given to me the right time, like what कौन सी वो ट्रेन चली है, जन शताब्दी है, कौन सी वंदे भारत, वो बिल्कुल सही समय पे चलती है और सही समय पे छूट जाती है. अगर आपकी ट्रेन तो आप लोगों को टाइम दिया गया है 2:50 ऐसा कहा है मुझसे, तो आप लोग टाइम का ध्यान रखेंगे विशेष. Topic which is there, that how do we improve the infrastructure in healthcare, and finally the care delivery to a needy patient who comes either to the peripheral level or to referral hospitals in cities. So first let me straight away go to Dr. Shilpa, because she is managing a very large chain of group of hospitals, and I feel that Jupiter Group is doing very well in Mumbai, and one of the hospital you took over in Indore also, madam?
Yeah, that's true.
Right, okay. That belonged to my friend first.
Okay.
Agarwal, Girish Agarwal
Yes.
was the owner, so he sold out his equity. But anyway, let me begin with you. You have seen big hospitals, and you have seen infrastructure and caregiving at peripheral levels also. So how do you give your suggestions, or how you feel that things can be done from private partners or from government side, that we can improve upon to the systems which are existing in healthcare, and if there is any need for urgency to be taken care in healthcare per se?
Thank you, Dr. Maheshwari, and pleasure and privilege to be here. I know it is siesta time probably for all of us, but same time we ensure that we keep you engaged. So coming back to this, yes, there has been in healthcare delivery, if you talk per se for hospitals, as all of us are aware, in India at least the healthcare system is in such a way that at least 65 to 70% of the spends are from out of pocket and comes to private healthcare. So today private healthcare, a decade back there was a scenario that private healthcare were mostly actually encroached and was dominant with trust hospitals and public hospitals to some extent. Today there are lots of corporate players who are in the market, and healthcare delivery per se, if we say about for the hospitals, it has definitely improved. I'm saying you asked me about basically public health system support as well. So though public health system support as such is not in terms of infrastructure and the facility, however, government is emerging now as a payer. If we say that there are lots of government norms and regulations today, which are actually bound to help us in giving better care for patient. Another unique perspective from government is like their reach to the remote areas also, and with their PHCs and rural setup is too good, which is not the case with private players. However, we can always count on private players when it comes to quality. So I think public and private can complement each other with this quality and reach point of view. Another thing is like whether it is a small public hospital or whether it is a bigger corporate player or bigger private public hospital, quality is immaterial. Because when it comes to patient safety, whether patient goes to the smaller setup, rural setup, or patient comes to a bigger corporate setup in urban areas, anybody and everybody today expects patient safety and quality. Awareness also has increased to a great level in the last decade. we all are bound to give quality. Infrastructure plays a very vital role. Actually, today, if you see the lobbies of good corporate hospitals, they nearly compete with the five-star hotels. At the same time, the care norms also are becoming stringent. Previously, there was no structured way that the care was getting delivered. However, with the Joint Commission, with the NABH, which is our own, the quality norms are getting structured. With AI coming in picture, things are improving. Better monitoring is now possible. And with this, definitely, the standards of patient safety and care delivery is certainly enhancing.
Now, you mentioned about the quality norms, whether it is JCI, whether it is NABL, NABH, or safety norms or the rules and regulation from the government policy makers. So I'll definitely pose this to Niti Aayog ma'am and Madanji also once they have. Can we have Dr. Dr. Madan? Is he there?
Yes, very much there.
Yeah, Dr. Sahab, let me first welcome Dr. Urvashi. Welcome, ma'am.
Thank you, I'm here, yes.
Right. I'm Dr. Maheshwari, and by the side we have Dr. Shilpa on the dais here. So, welcome you both for this session, afternoon session. We have discussion going on to how do we revamp the infrastructure or the healthcare or the care provider, education system, or safety norms or regulation policies. There are so many things which I have to ask Niti Aayog, because I've been involved into rural healthcare for a very long time, and I wish to know from you, ma'am, that there are so many, about 78 norms are there, and Niti Aayog, the name has changed from Yojana, Panchvarshi Yojana to Niti Aayog, but norms have not changed at all. In fact, they have become more strict. In a population of 140 crore और हर अस्पताल को अगर 70 से 80 नॉर्म्स बनाने पड़े तो काम और डिफ़िकल्ट हो जाएगा. तो कैसे अपन इंफ्रास्ट्रक्चर को इम्प्रूव करें, फायर सेफ्टी, गांव के बीच में एक नर्सिंग होम जो आज से 70 साल पहले बना था, वो कैसे अपने फायर को लगाएगा? वो तो उसमें जाने की जगह नहीं है, वहाँ पे ठेला भी नहीं जा सकता. तो उन गांव के उन नॉर्म्स को क्या करें? अस्पतालों को बंद कर दे जहाँ पे पेशेंट का वॉल्यूम लोड इतना ज़्यादा है, इतना वॉल्यूम रहता है. तो ये क्वेश्चन मेरे एज ए क्लिनिशियन भी हैं और एक जनमानस जो एक नया एंटरप्रेन्योर बनना चाहता है हेल्थ केयर में, उसके भी हैं, और ये नीति आयोग के लिए. बताएं मैडम.
जी, तो नीति आयोग और आई थिंक मेरे कॉलीग डॉक्टर मदन भी इस पे बहुत अच्छे से कमेंट कर पाएंगे. तो सिर्फ नीति आयोग ही नहीं इन चीज़ों को डिसाइड करता है या करता है, बल्कि हम लोग तो पॉलिसी थिंक टैंक हैं, तो हर चीज़ हम लोग नहीं डिसाइड करते, बट सर्टनली हम लोग इनपुट्स देते हैं बहुत मेजर पॉलिसीज़ में. बट और भी बहुत सी एजेंसीज होती हैं जिनकी वजह से बनते हैं. तो मतलब आई थिंक इस इशू में ऑब्वियसली नॉर्म्स की जो बात आप कर रहे हैं, ये अलग अलग तरीके से इसको देखना पड़ेगा, और अलग अलग एरियाज़ की जैसे आपने बात की कि अर्बन एरियाज़ हैं, रूरल एरियाज़ हैं, ट्राइबल एरियाज़ हैं. तो आई थिंक उन तरह से ही अब हम पॉलिसी स्पेस में भी इस इशू को देख रहे हैं. और आयुष्मान भारत के अंडर भी इस एंगल से, इस लेंस से हम देखने की कोशिश कर रहे हैं कि जो टियर 2 भी है, टियर 3 है, स्मॉलर सेंटर्स हैं, वहाँ पे किस तरह के नॉर्म्स होने चाहिए, वहाँ पे किस तरह की लेकिन जो क्वालिटी स्टैंडर्ड्स हैं वो भी बहुत इम्पॉर्टेंट हैं. तो वही एक इसमें एक तरह से कभी कभी कॉन्फ्लिक्ट आ जाता है कि नॉर्म्स कुछ तरह के नॉर्म्स आप रिलैक्स कर सकते हैं, लेकिन ऑन द अदर साइड you cannot relax, compromise in any way on the quality standards, the patient, this thing. So a lot of those things are very complex, and but I think certainly evolution हो रहा है, और हम लोग भी अलग अलग तरह के इनपुट्स लेके इंडस्ट्री से भी सब लोगों से इनपुट्स लेके स्मॉलर प्लेयर्स से भी लेते हैं हम, बिकॉज एज वी नो कि इट्स नॉट जस्ट अबाउट द बिग हॉस्पिटल चेन्स और द बिग हॉस्पिटल प्रोवाइडर्स, but actually also a lot of the smaller players, especially when we talk of smaller urban centers, rural areas, tier 2, tier 3, etc. So I think we tried to take, and we are continuing to take those inputs and accordingly give inputs on how do we rationalize the norms while ensuring that the patient interests and the safety and the quality and all of that is not compromised. So I think that is work in progress. Certainly there's a lot of scope for improvement. But like I said, this is an issue which involves a lot of stakeholders, central, state, even at the center there's many stakeholders. So that is how we try to approach this issue. But I think Dr. Madan can also shed a lot of light on this.
Thank you, madam, for your input. Can I ask Dr. Madan to throw some light on the question which is the common one to both of you? Dr. Madan?
Okay, thank you very much. You have asked a very pertinent question, because when we have rolled out the PMJ program, at that time, just when we were making the projection how many number of beds would be required, the NSSO data was there. The hospital inpatient utilization per person was around 3% at that time. Had he had that 3% utilization, do we have enough beds for catering to the needs or not? That was the question which we posed to ourselves. At that time, we are having around 80,000 odd government and private health institutions, of which private comprises 62,000, and they contribute to around 11 lakh beds, the private people. And around a similar number, that is around 10 lakh beds, are from the government side. So as the other panelist has also mentioned that the government is having reach and the other thing, the infrastructure efforts are also being made. Coming to your question, you have asked that so many licenses are required for starting and health establishment. When we were trying to, based on the question how many more beds are required, then we did a study. When I was, before my this assignment, I was working with Urvashi and was contributing to the policies and other things at NITI Aayog. So at that time, when we were doing the investments into tier 2 and tier 3 cities, we have come across all the things. We have talked to the single chain hospitals, we have talked to the hospital owners as well as the venture capitalists, the investors and others. We have talked to everybody. Your 73 points are in some of the states, it ranges from 50 to 75 licenses which are required to start a medical establishment. That's there. So what I would be just sharing that we are very much conscious about this fact that it is 74, 75, and that is a very, very deterrent for this. But 3 years back, what has happened is, when I was working in NITI Aayog, we have been able to get a letter released from the Ministry of Health to all the secretaries of the state, saying that you have to start with a single window licensing for all the institutions. Because these kind of things takes time for getting into implementation. It's still work in progress, but many of the states, they have taken the idea and they have started the single window clearance for establishment of the nursing homes. The other aspect, the wider aspect is about the patient safety, because hospital itself is an ecosystem. We should always appreciate that hospital is an ecosystem. It creates an ecosystem around itself. If a single hospital is open, you see how many shops, the restaurants, the hotels and other things also evolve along with the hospitals. There are very many outliers, because the old hospitals, we have to find out the way how to make them patient, because the fire compliances and other things, they are from the patient point of view. There are certain outliers, we do agree that outliers are there. We are trying to see that how we address that issue of bringing them also into the net of this quality and other things. I have seen many hospitals, because I was involved into the entry-level NABH accreditation. Uh, when I was handling this RSPY program and we started this quality initiative, we thought that one country, one quality should be there. At that time, NABH was coming up with a small accreditation for the small hospitals. Then we realized that we should be having a staggered kind of quality so that small hospitals which can adhere to the entry level thing, they can be at least motivated to go toward progress and the full accreditation. But this entry level accreditation has become a hit, but major deterrent is first and foremost is the fire this. That's the challenge which is there. If an old institution is there, we want to improve its quality and standards. So that's the first deterrent which is there. But I think work is in also progress how to address this issue and see that how are we able to make a breakthrough in this. So that's one of the areas. A lot of work is to be done. But these outliers are there. But if somebody is making a new institution for investment purpose, the healthcare has been labeled as an industry since 2017 in the budget speech 2017. Healthcare is, apart from that, we have been pushing the banks, even we have been able to made it as a priority sector lending. But people are not coming forward to take loans. That's a financial part. Second thing is many of the states, they have started the single window clearances for encouraging the investments into the hospitals in these small cities and the other cities. That's the second thing. Apart from that, a lot of PPP models are also come up to incentivize the investments into these hospitals so that our healthcare institutions can come. That is through the viability gap funding of Department of Economic Affairs and the other PPP mode. Some of the state government, they have come up with their own scheme to set up super specialty hospital either in CAPEX, OPEX or hybrid of these modes. That kind of efforts are also going on. But the bottom line is we have to increase our beneficiary base. We have to see that how best quality of services are provided to the patient. That's our whole intent. That's why we are trying to see that whatever problems and other things which are being addressed, we are trying to address all these thing issues. Over to you.
Thank you, Dr. Madan. I'll come back to you again, both of you. Dr. Shilpa, I wish to know that I addressed that thing in the morning also, that what is the role of big hospital, private hospital entrepreneurs to impart education to village level infrastructure and patient care giving and system adaptation and their knowledge enhancement which is being done in your institutions?
Partly I would also answer this question, and I would also touch upon the earlier question. Basically, when we have said that there are stringent norms when it comes to rural setup or the smaller nursing homes or smaller hospitals. I'll just give you one example of a very recent actual practical example. I had got one patient's narrative with me, and patient was 9-month pregnant lady. She had initially gone to a smaller nursing home setup. Patient was in maternal distress as well as there was a fetal distress. Incidentally, this particular nursing home, the consultant was very well known and a single owner. They did not have lift. Patient 9-month pregnant, she was actually required to be carried in jholi, in bedsheet, to the downstairs because they did not even have basic facilities, even like USG. So she was to be shifted out. And after that, she was referred to a bigger hospital. So, of course, yes, there has to be norms required. And as Dr. Madan mentioned, there has to be a single window system which will facilitate patient safety, at the same time less of bureaucracy. Now, coming back to this particular question, yes, I agree that being corporate hospitals, bigger chain hospitals, we owe a lot of responsibility towards our counterparts, which are basically maybe smaller nursing homes or in the places which are in the remote area. So there are two ways of doing with it. One, when it comes to education for better practices, we can always, and which we are doing also. What we are also doing is like, of course, apart from this routine DNBs and CPS and all fellowship courses, we are also trying to impart knowledge through telemedicine. That is one touch point, wherein we are connecting with rural areas. We are also conducting peripheral OPDs, wherein we are not only conducting OPDs for seeing and screening patients, kind of hub and spoke model, but we also ensure that by conducting CMEs, we do ensure that the refresher courses or routine regular trainings are conducted even in the interiors of Maharashtra and Madhya Pradesh, because we have also set up in Indore. So that is one way of doing it. Also, when it comes to infrastructure, like basic norms like fire, yes, I agree it appears stringent even from NABH perspective when we assess the facilities. But at the same time, considering the recent incidences of fire, these norms play really very crucial role. I still remember the practice which were in rural areas, in rural hospitals and in PHC system around 20 years back, and today there is a considerable improvement, maybe because of threat of law and regulatory bodies. But at the same time, it has imparted considerable role for patient safety. We also do one thing, not only in rural areas, but also the surrounding nursing homes. We do train them in basic SCLS, BLS, even to the junior most healthcare workers. We also, I mean, if it is like an open forum, if anybody actually asks for a guidance, we do also tell them what are the basic infrastructure requirements, what is the manpower. We also actually take initiative of training the manpower. Only thing is like that awareness and that openness in the hospital sector is still to come up to the level. Thanks.
Now, can I have Dr. Urvashi? Hello, ma'am. I just want to know. I just want to know at policy making, are we having some revisit to grievances redressal? Grievances is from both sides, healthcare provider and healthcare giver. So address to healthcare giver is being addressed very well by government, by consumer forum and so many things, and police thana, and these are all practical problems which I want to ask, because once it is Niti Aayog, I always have lots of my queries as a clinician. What happens to doctors, nurses every day? There are lots of stories of being beaten up and all that. So are we having some rules only? Are we having some numbers कि कोर्ट में चले जाइए, आप ये कर दीजिए, थानेदार को बोल दीजिए, हम देख लेंगे, या हर रोज हम इसी परेशानियों से जूझते रहें और 140 करोड़ को तो ट्रीट करना ही है हमको, क्योंकि वो तो हमारा धर्म है ना. तो हम कैसे करें? मतलब मैं ये इस क्वेश्चन को इतनी फोरम के सामने इसलिए रख रहा हूँ कि ये मेरे 40 साल का एक्सपीरियंस है कि हमारी प्रॉब्लम कोई सुन ही नहीं रहा है इस देश में. 75 साल से डॉक्टर सिर्फ सेवा के लिए है और मार खाने के लिए, ऐसा हमको संदेश आता है. आपका इस पे क्या है? और मदन जी से भी मैं यही चीज़ पूछूंगा.
तो ये एक्चुअली बोथ टू वे इशू ही है. बिजी बुला रहे हैं. ये टू वे एक तरह से इशू ही मैं तो देखूंगी इसको कि जो पेशेंट साइड भी है, मतलब आई थिंक इट इज़ नॉट यूजफुल फॉर अस अगर हम उसको पेशेंट वर्सेस डॉक्टर देखें, बिकॉज एक तरह से ये पूरा इकोसिस्टम है जिसमें कि डॉक्टर्स को एक्चुअली हम लोग बहुत हद तक जो एक तरह से दर्जा दिया जाता है, वो कई बार वो गलत भी उल्टा ही पड़ जाता है कि लोग कहते हैं कि डॉक्टर भगवान है, और भगवान तो नहीं है, इंसान ही है. वो अपनी ड्यूटी कर सकता है, अपना बेस्ट दे सकता है. लेकिन उससे ज़्यादा कोई ज़रूरी नहीं है कि वो हर किसी को बचा पाए या हर सिचुएशन में किसी की मदद कर पाए। तो आई वुड से कि ये एक पूरे दोनों तरफ से पहलू से देखना बहुत ज़रूरी है। जो कि आपने कहा सही बात है कि डॉक्टर्स के खिलाफ बहुत वायलेंस, बहुत सी चीज़ों के रिपोर्ट्स आते रहते हैं और आजकल सोशल मीडिया की वजह से तो और जल्दी हमें ये बातें बहुत वायरल हो जाती हैं, सब इंटरनेट पे सब दिख जाता है लोगों को भी। लेकिन ये चल रहा है काफ़ी टाइम से, ये एक कॉन्फ्लिक्ट है ये काफ़ी समय से चल रहा है। और इक्वली हम दूसरी तरफ देखते हैं, अभी एक वीडियो सरफेस हुआ था इंटरनेट पे कि एक पेशेंट बिकॉज उसने जो एटलीस्ट जो खबर चल रही थी कि उसका HIV पॉजिटिव स्टेटस था या जो भी उसने उसको कंसील किया या जो भी इशू है, जो कि हम जानते हैं कि हमारी सोसाइटी में सोशल स्टिग्मा है और उसके बहुत डीपर रीजंस हैं कि किसी ने कोई ऐसा क्यों किया हो, चाहे वो गलत चीज़ हो, लेकिन उस पेशेंट को ब्रूटली पीटा जा रहा था उस वीडियो में, तो वो भी सही नहीं है। ये भी हम नहीं कर सकते कि पेशेंट्स की तरफ भी हम इस तरह का वायलेंस दिखाएं एंड दूसरी तरफ से वी कैन नॉट ऑल्सो शो इट टुवर्ड्स द मेडिकल फ्रेटर्निटी। सो फ्रॉम अ पॉलिसी पॉइंट ऑफ व्यू दोनों ही साइड्स को हमें बट इट्स नॉट जस्ट अ पॉलिसी इशू, इट्स अ ब्रॉडर इशू, इट्स ऑल्सो एन इशू फॉर द मेडिकल फ्रेटर्निटी, इट्स एन इशू फॉर एवरीवन कि हम लोग इसको ये जो एक लैक ऑफ हार्मनी कभी कभी इस रिलेशन में जो एक बहुत ही इम्पॉर्टेंट फंडामेंटल रिलेशनशिप है पेशेंट और डॉक्टर की और इतनी सैक्रोसैंक्ट और इम्पॉर्टेंट रिलेशनशिप है, इसमें जो इस तरह की ये एक्रिमनी आ जाती है उसको हम कैसे एड्रेस करें। तो ऑफकोर्स पॉलिसीज़ हैं, नॉर्म्स हैं, लेकिन उनका इम्प्लीमेंटेशन बहुत इम्पॉर्टेंट है एंड लाइक आई सेड इम्प्लीमेंटेशन हैपन्स अक्रॉस द कंट्री, स्टेट लेवल, सब स्टेट लेवल, सिर्फ एक सेंटर से बैठ के उसको कंट्रोल नहीं किया जाता, वो सब पूरी तरह हमारा स्ट्रक्चर डिसेंट्रलाइज्ड है, फेडरल स्ट्रक्चर है, तो हर कोई रिस्पॉन्सिबल होता है कि अगर कोई नॉर्म भी हो तो उसका इम्प्लीमेंटेशन सही तरीके से होना चाहिए। तो वो इम्प्लीमेंटेशन मॉनिटरिंग बहुत ज़रूरी है कि अगर एक हॉस्पिटल सेटिंग है या कोई भी मेडिकल सेटिंग है उसमें जितना कि हेल्थ केयर प्रोवाइडर सेफ रहे उतना पेशेंट सेफ रहे, दोनों का हमें इंश्योर करना बहुत ज़रूरी है। बट लाइक आई सेड इसके ब्रॉडर इश्यूज़ हैं और सबको मिलके इसमें काम करना पड़ेगा, क्योंकि अगर कई बार क्या होता है कि अगर कोई मेडिकल फ्रेटर्निटी की तरफ से या हॉस्पिटल की तरफ से समथिंग इज़ हैपनिंग विच इज़ अनएथिकल और विच पेशेंट्स आर फीलिंग कि हमें ओवरचार्ज किया जा रहा है या कुछ हमारे साथ गलत हो रहा है, तो वो भी एक बहुत एक्रिमनी उसमें बिल्डअप होती है। ऑफ कोर्स वायलेंस इज़ नेवर द राइट आंसर, दैट वी ऑल नो, but we also have to ensure that we keep up the highest standards of ethics and practices, and on the other side we have to ensure that जहाँ patients का अगर इस तरह का कोई situation हो रही है तो we should have very stringent measures for controlling it, for monitoring, for having corrective measures in place. So I think I would like to not look at it as one versus the other, but I would try to look at it as a whole, and that is how at least we try to offer any solutions or suggestions. But like I said, that suggestions, solutions are only as good as their implementation, and so that is what we really need to focus on.
थैंक यू मैडम। एंड डॉक्टर मदन, आपका इनपुट इसमें कुछ थोड़ा बहुत, क्योंकि टाइम का कंस्ट्रेन है, तो आई वुड लाइक टू वाइंड अप आफ्टर योर इनपुट्स।
बहुत शॉर्ट में इनपुट दूंगा, बिकॉज सोल्यूशन बहुत सिंपल है। मैं एक स्टेट में CEO था एक प्रोग्राम का, जो पेयर्स एंड उसके ग्रीवांसेस की बात कर रहे थे, एक स्टेट में वो प्रोग्राम को मैं चलाता था, तो उसमें हॉस्पिटल्स की बहुत कंप्लेंट थे। तो व्हाट आई डिड कि एक डायलॉग एस्टेब्लिश किया, हॉस्पिटल के साथ संवाद किया। जब अराउंड 400 हॉस्पिटल्स, प्राइवेट हॉस्पिटल्स, सबने आकर दिया, सबने बोला, मैंने बोला ठीक है, यू आर आस्किंग अबाउट योर पेमेंट्स, यू विल गेट द पेमेंट, बट आई वोंट लाइक टू हियर एनी ग्रीवांसेस फ्रॉम यू, ग्रीवांसेस फ्रॉम द पेशेंट, नॉट फ्रॉम यू। तो ऐसा रिजल्ट व्हाट हैपेंड, 1-2 हफ्ते ऐसा चलता रहा, वो आकर सुनाते रहे, मैं सुनता रहा, लेकिन बट व्हेन द इंटेंट वाज विजिबल दैट कि उनके जो पेमेंट थे जितना भी क्लियर होता जा रहा है इंश्योरेंस कंपनी का, तो दे वर ऑल पेड ऑन टाइम, तो ऐसा रिजल्ट में कॉन्फिडेंस आया। तो उसके बाद majority of the people, they have started functioning, and there was a good coordination between the patients and the doctors. That's one thing. ये बहुत बड़ा issue है, violence against the doctors and the main problem is with the explosion of the information. The expectations are being raised too high. या तो अस्पताल के जो फ्रंट एंड रिसेप्शन में एक्सपेक्टेशन हाई हो जाते हैं, या थ्रू इंटरनेट एंड अदर का नॉलेजेबल एक्सपेक्टेशंस आर टू हाई. दे वांट दैट कि अगर कोई भी चीज़ हुआ है, गलती उनकी भी हो, तो दे विल कम एंड स्टार्ट शाउटिंग एंड दिस. आई डोंट नो दैट काइंड ऑफ टेंडेंसी एंड सोसाइटल वैल्यूज हैव बिकम. तो उसको करने के लिए दोनों तरफ से काम करना पड़ेगा. एट नेशनल लेवल ऑल्सो वी आर ट्राई टू ब्रिंग विद प्रिवेंशन ऑफ वायलेंस अगेंस्ट डॉक्टर्स, लेकिन ड्यू टू सम रीजन, सम डिस्कशंस एंड अदर थिंग्स वो थ्रू नहीं हो पाया. बट लेकिन मैनी ऑफ द स्टेट दे डू हैव एनेक्टेड सम एक्ट्स. लेकिन एक्ट्स इम्प्लीमेंट करने के लिए दे हैव टू क्रिएट लॉट ऑफ अवेयरनेस एज वेल एज यूनिटी अमंग द हेल्थ प्रोफेशनल्स. सिटीजन के लिए तो आपने बहुत सारे फोरम्स हैं, लेकिन डॉक्टर्स की वॉइस उठाने के लिए कोई बात नहीं करता. सुप्रीम कोर्ट के बहुत सारे ऑर्डर्स हैं, रूलिंग्स हैं, उसके बावजूद भी लोग उसके बारे में पता नहीं, उसके कारण पुलिस आकर एक्शन ले लेती है. तो दैट काइंड ऑफ थिंग्स वी नीड टू क्रिएट लॉट ऑफ अवेयरनेस अमंग द पीपल. बट ये बहुत ज्वलंत मुद्दा है. इट्स नॉट दैट इट्स अ सिंपल सॉल्यूशन लाइज देयर. लॉट ऑफ अवेयरनेस इज क्रिएटेड. Some of the state governments, they are moving in the right direction. At the central level also, the act was there. Act was contemplated, लेकिन वो किसी तरह से पहुंच नहीं पाया. But still, this is the topic which is debated at the highest level also. It's not that we are not aware about this kind of problems and everything. But main जो grievances, जो other problems बता रहे हैं, payments के grievances, that can be sorted out. वो एक बैठ कर ही आपको you have to establish a dialogue with the state local agencies or the people who are handling it. एक बार कॉन्फिडेंस लेवल और डायलॉग रेगुलर बना देगा. एक बार जाकर बोलने से नहीं होगा. इट हैज़ टू बी कंटिन्यूस डायलॉग सो दैट आपकी प्रॉब्लम वो सॉल्व करे, उनकी जो व्यथा है वो आप देखिए कैसे एड्रेस कर सकते हैं. इट हैज़ टू बी बोथ वेज.
थैंक यू.
डायलॉग विल गो ऑन एंड ऑन, बट सॉल्यूशन एकदम से दोनों को मिलकर ही निकालना पड़ेगा.
Thank you, Dr. Madan, Dr. Urvashi, and Dr. Shilpa. I just felt that you have comprehensively covered all the topics of basic infra to grievances to what is the need, what is the policy maker which they have to do. तो हेल्थ केयर में एक समरी के रूप में मैं शायद इसको इस तरह से बोल सकता हूँ कि एक अच्छे गीत को बनाने के लिए साहिर लुधियानवी जी का गीत लिखना, रफ़ी साहब को उसको गाना, राज कपूर को उसकी एक्टिंग करना और फिर उसको पिक्चर के अंदर एक अच्छी हीरोइन के सामने गाना, इन सब को मिला के वो गीत जब बनता है तो कश्मीर की कली का वो गीत बनता है, जो आज तक हमको याद है कि जिसमें शम्मी कपूर पानी में डूब के गिर जाते हैं ताली बजाते हुए. तो उन्होंने वो गीत को 3 बार करवाया कि मैं ताली ज़रूर बजाऊंगा और मैं गिरूंगा भी शर्मिला टैगोर की पहली हंसी को देखते हुए. और ये हेल्थ केयर सिस्टम भी ऐसा ही है कि कहीं कोई हंस रहा है, कहीं कोई गिर रहा है, कहीं किसी को संभालना है, कोई दुखी है, कोई नाव पे बैठ के झूल रहा है. लेकिन एक अच्छा गीत, एक अच्छा हेल्थ केयर सिस्टम जब बनेगा जब सब लोग मिलके इसको एक यादगार पेशकश देंगे. और मेरा आप सभी लोगों से ये हमेशा गुजारिश ये रहेगी कि अच्छे गीत को बनाना है इस नए भारत में, और इसमें सब लोग खूब सारी जितनी मेहनत कर रहे हैं और मेहनत करें. प्राइवेट हेल्थ केयर प्रोवाइडर्स की ड्यूटी और बढ़ जाती है क्योंकि इनके पास इंफ्रास्ट्रक्चर के साथ साथ टेक्नोलॉजी भी रहती है, अपडेटेड भी रहते हैं. तो इनको बताना भी पड़ेगा नीचे. ये बोल के हम अपना पल्ला नहीं झाड़ सकते कि भाई आप लोगों को कुछ नहीं आता है, आपने ये जांच क्यों नहीं कराई. जब आपने हमको बताया नहीं तो हम कैसे, हम तो गांव में पड़े हुए हैं, तो हमको कैसे कौन समझाएगा. तो हमको आपको समय समय पे बताना पड़ेगा, आपको आना पड़ेगा गांव में. महीने में नहीं, 2 महीने में, 3 महीने में एक बार कोई डायग्नोस्टिक वाला पहुंच जाए, एक बार कोई डॉक्टर पहुंच जाए, आके उन प्राइवेट अस्पताल वालों को, जो छोटे छोटे नर्सिंग होम्स हैं, जो छोटे जीपीज़ हैं, जो आरएमपीज़ हैं, कई सालों से प्रैक्टिस कर रहे हैं, उनको आप समझाइए. तो जब समझाएंगे तो हम एक बेटर भारत का निर्माण कर सकते हैं, ऐसी मेरी आशा है. और नीति आयोग और जो पॉलिसी मेकर हैं, जो दिल्ली से
और जो राष्ट्र की अपने राज्यों की राजधानी है जहाँ पे पॉलिसीज़ बनाते हैं, उनको इन सब चीज़ों का ध्यान रखना पड़ेगा कि छोटे छोटे सेटअप जो आज से 50-60 साल पहले बने थे उसमें 70 नॉर्म्स नहीं लगा सकते। ग्रीवेंसेस में जब तक हमारी भी नहीं सुनेंगे, हमारे साथ भी न्याय नहीं होगा, तो हम भी दुखी रहेंगे, और जब हम दुखी रहेंगे तो पेशेंट भी दुखी होगा ही होगा, ये बात पक्की है। तो इस चीज़ का ध्यान मैं सिर्फ आकर्षित करता हूँ, कर तो हम सकते नहीं हैं कुछ, क्योंकि हमारे हाथ में पॉलिसी रहती नहीं है। पॉलिसी बनाने वाले तो सब सफ़ेद शर्ट और सफ़ेद पैंट में रहते हैं, तो उन लोगों के लिए ये बात पहुंचानी हमको ज़रूरी है। थैंक यू सो मच। थैंक यू मैडम। और मैं चाहूँगा कि आप
Thank you so much, sir. Thank you, ma'am. We request you to please step ahead for a photo op, and then post that we shall be handing over the mementos. Sir and ma'am, आप दोनों please photo op के लिए आगे आइए. Kamal sir, welcome back. We would like to thank Dr. Shilpa Tatake, Group COO, Jupiter Hospital, for sharing her insights. Thank you so much, Dr. Sanjay Maheshwari, for sharing your insights. It's time to capture the memorable moments. Thank you so much, ma'am. Thank you so much, sir, for sharing your insights along with us on this topic. Well, that was indeed a provoking session, but ladies and gentlemen, please hold on to your breath because we have an exciting session coming up. We have a fireside chat between Mr. Amitabh Dubey, Country President, Novartis India, and Mr. Kamal Narayan, CEO, IHW Council, who will be joining us on stage and sharing their insights. Ladies and gentlemen, please put your hands together as we welcome Mr. Amitabh Dubey and Mr. Kamal Narayan on stage for a fireside chat. Over to you, sir.
Good afternoon. So after this intense session where we heard the problems of clinicians, the problems of our rural India, and also the desire and passion to change that. And that's what I think the the message from the previous session, that almost every stakeholder of this country, and also especially the healthcare, they have desired to transform where we are. And in this journey, we have now with us Mr. Amitabh Dubey, who has been in leading role of many pharma companies, some of the major brands globally, and has seen healthcare system closely within our country as well as outside India as well also. So Amitabh ji, when it comes to bringing patient centricity, this word is good to hear apparently, but how do we decipher it? What exactly patient centricity is, and how do you see it from the different lenses which you have been privileged to have?
So first of all, Kamalji, it's an honor to be here, and thank you for inviting me. I wanted to say that IHW Council, this Patient First Summit, is one of its kind, and is one of the platforms where we can get different stakeholders together to put patient at the center and then look how healthcare systems can support patients. At Novartis, we have been always trying to keep patient at the center of what we do. And our whole objective remains to improve and extend patients' lives. As an organization, if you look at it, we have evolved over the last 100 years from being a chemical-based company working on dyes, to moving to protein-based therapies, which were recombinant products and monoclonal antibodies, to now gene and cell-based therapies and newer technologies with radioligand therapies. While we do this, we always keep patients in our sight, that how do we improve their life. When you talk about patient centricity, I look at three things. One is patient adherence. Second is about patient engagement. And the third is about patient empowerment. Patient adherence, what I mean is that in our country, we need to work collectively to ensure that patients adhere to their treatment, and they are kept in the center of everything while we look at their therapy areas, their healthcare journey from diagnosis to treatment. They should be the one who are adhering to all the treatments. When we look at patient engagement, we should engage patients early in the healthcare strategies, policy making. They are the ones who should be, in fact, leading the policy journey in the country. And patient empowerment means that we should be empowered. Patient should basically be empowered for his treatment and should have the entire know-how of what he's getting treated with. I wanted to give an example, and I was talking about therapy areas. If you look at some statistics, Kamalji, I will just try to go back, that we have roughly 20,000 plus genes in our human bodies. And more than 60% are non-coding RNA. And when I say non-coding RNA, means that they don't make proteins. They are not messenger RNAs. We have 20,000 known proteins. Only 3% are targeted by drugs. We have more than 10,000 diseases known in the world, but we have treatments for less than 500 or approximately 500. So there's a lot to do when we talk about the treatment. And all that can be done when only we have a strong commitment to patients and caregivers. Coming to another point which is important is the digitalization and innovation. And I talk about patient centricity with regards to digitalization. And the reason for that is because I believe that the digital output will enhance the patient journey significantly in this country. Digital interventions have enhanced the R&D processes. Today we use AIs and other modes to fast-track drug discovery and making them faster to the patient. Digital interventions would fast-track the treatment from diagnosis to treatment, and also digital interventions in this country would significantly enhance the awareness of diseases. So in all this thing, the healthcare is going to get more engaging, is going to get more innovative, and is also going to get more exciting. And with this, we have to have patient right in the center while we talk about the healthcare.
Wonderful. Actually, when you talk to somebody of Amitabhji's stature, you get answer of 10 questions, the 9 which you haven't even gone to in the list. So I will try to now go more in detail on those questions. So you talked about patient adherence, patient engagement, and patient empowerment. And these are the three things which are very important, critical when it comes to ensuring the patient centricity in the care which is being provided. So how do you, and even specifically Novartis, try to leverage all three of them and tries to deliver solutions to the patients instead of medicines or product? How do you package it as a whole solution? And how these three things are practically utilized in the therapy areas Novartis is working?
So I'll answer this question in terms of our bold access plan that we have in Novartis, Kamalji. And what I mean by bold access plan is that we try to see scenarios in two ways. One is the top-down approach and one is a bottom approach. When I say top-down approach, I talk about that it's more about health financing and looking at health economic outcomes and how do we ensure that we have better health economic data available to support patient outcomes. When I say bottom up, we generally talk about the value that the brand brings in to patients. What we also look into is how, over a period of time, we are supporting the healthcare system to make an evidence-based decision. And digitalization plays a very significant role in having that outcome-based or evidence-based decision-making. Our end goal is on three fronts. One, to move from opinion-based to outcome-based decision-making. Our aim is also to move from volume-based to value-based decision-making. And our aim is also to look at not just episodic interventions, but look in total wellness outcomes. The second example I wanted to give is about, we have a system which is known as Patient Access Navigation System. That system basically captures all the funding opportunity that a patient can get to access his drug or treatment, basically. And that gives him a bit of insights about where he can go, how he can get funding available across. So we just don't look at delivery of a medicine. We put patient in the center and create a holistic solution with a bold access initiative, as well as ensuring that we provide funding opportunities for patients.
Great. So apparently the three important pillars which you talked about are being practiced in this whole mechanism which your company has devised. The other important thing which Dr. Maheshwari also touched upon in a way, or in general also, like you talked about the transformation of Novartis and coming into more gene based, more precision therapies and all those advanced therapies which Novartis has been kind of innovating and bringing to the people. Many times what happens that everyone with the intent of delivering the best to the patients and best which can be looked at differently by different stakeholders. So for somebody, best can be which is most affordable. For somebody, best can be which brings the best quality of life. For somebody, best can be which is most easily accessible. When you try to bring in the best of the innovation for the humanity, where do you see the challenge that despite this can be the best for the patients, maybe because of certain policies, certain social issues, lack of awareness, lack of education, anything. How do you feel that can be tackled to ensure that that patient-centricity, which is kind of being provided by the technology, by the new innovations, can reach to the maximum people in a society, or maybe to the last person in the row?
Thank you, Kamalji. Our belief is that every patient should have the opportunity to get the best possible treatment. And the way the best possible treatment can be accessed to the patient should be a collective responsibility of multiple stakeholders coming together. It needs to ensure that all different, whether it's patient organizations, government, pharma companies, medical associations, hospital associations, all need to come collectively to look and how do we provide solutions to patients. And there are wonderful examples in this country where this is happening and will happen in the future. I can look at the way the sickle cell program has gone into the country and getting all stakeholders, patient organizations, pharma companies, government, different stakeholders, they have come together to look at how best each patient should be made aware about it. There should be good diagnostics facilities available. The patients should be tested around. The patient should be also having a good treatment. We also see, and I saw Alpana ji also here, great work happening around the rare disease framework. The way all stakeholders are coming together to ensure that the treatments for rare diseases are made more accessible to patients is provided. Same work is also happening around in oncology and cancer. So the answer to you is that the belief is that everybody and every human being who needs the best treatment should have an opportunity to get the best treatment. And it cannot be an alone responsibility of the government to provide it, or the patient himself, or the pharma company. It has to be a collective work done by different stakeholders all coming together to ensure that what is the best way that this collective responsibility or the treatments can be provided to patients.
So you mentioned about two important areas, and I think while patient centricity is something which is equally desirable at every aspect of healthcare, whether it is just a seasonal flu where I'm going to a doctor and want the consultation and I want to be heard and kind of taken care of. Or it is some more severe issues, and especially the diseases which have got got that perception where people are scared about them, and especially you mentioned about cancer and maybe rare diseases are another area. We hear about rare diseases only when we hear about maybe medicines worth 14 crore rupees or something. But at the same time, when we look at, let's say, specifically on the space of cancer, the patients who are going through that journey are fighting at multiple fronts. One can be, and which is more obvious, is about their physical health and the fear of the whole fatality associated with cancer, and which is happening primarily because of the way our healthcare system is so far, where we are diagnosing these diseases much later at a stage. So the patients are physically at stress, they are mentally at even bigger stress. They are getting stressed financially as well, because the treatments of cancer is not that affordable, and especially if we go for better treatment, it gets and they are also many times socially also not getting that kind of support system, that comfort, and many times they have the feeling that they are not being heard also while they are navigating the whole cancer care. So in this specific area, how do you see the patient centricity, which is much more desirable here? Not only desirable, I think it has become the most critical thing to be delivered to the patients. How do you see that patient centricity can be achieved in that, while the patients are navigating this whole complex treatment thing, right from how the diagnosis should go, how the treatment plan should go, how the doctors should be kind of counseling them. Many times we hear that the doctors and maybe the doctors in the hall may differ also sometime, but we do hear that patients are being told that you go for this protocol or this line of treatment, otherwise you have very limited time, maybe 3 months, 6 months or something like that, which also in a way puts the patients in a more difficult situation mentally as well as maybe financially as well. How do you see that whole navigation can be made much more comforting and much more outcome oriented also, and much more kind of be preponed in terms of early diagnosis early, even maybe through the level of prevention, so that we have lesser people going through that phase and we are able to save, protect more people at the prevention level itself, because I think patient centricity would start from the prevention itself than the end stage.
So thank you, Kamalji. And then if you have to talk about cancer, first let me say about that at Novartis, we are reimagining cancer care. And we will not leave any efforts unturned to potentially get a cure for cancer. And we have been working on areas like chronic myeloid leukemia, where for more than 2 decades, we have been ensuring that this blood cancer is no longer a cancer. It's converted into a chronic treatment, chronic illnesses. We have been working on gene therapies, and we have got examples of Kymriah where patients' lives have been transformed. And we have, after 2 decades, we have been able to launch CDK4/6 inhibitors where in all lines of treatment, patients can get potentially better outcomes with the treatment. The main reason for outcomes to be better is early diagnosis. And there are 2 areas where I want to focus on. One is we need to bring in the fact about awareness, and I said earlier on digital usage, about ensuring that the population screens themselves after a certain ages, or if they have predisposing factors on cancer screening. The reason I say this is that if cancer is detected early, and you will hear with a lot of other speakers talking about it, if cancer is detected early, you can potentially look for cure. But if cancer is detected in advanced stages, there is still an opportunity for cure, but then the opportunity declines a bit. So the early treatment, early diagnosis is the key fundamental that we need to change. When you compare to Western world versus us, the key reason why 8 out of 10 in US or Western world will say yes to a fight and win a fight against cancer is because of early diagnosis and access to better treatments. The reason why in our part of the world we struggle is because of late diagnosis and not having access to all the treatments. To doctors, Kamalji, I want to say a bit, I compliment the Indian healthcare physicians. And the reason is clearly that the load of patients that they see on a daily basis and the amount of care that they are able to provide is significant as far as the Indian healthcare system is. We need to have more doctors. We need to have a better infrastructure. We need to have a better surround system in such diseases. And we need to have a system which creates hope in cancer. We should be able to move the needle to a time when if a doctor and a patient are sitting across and the doctor has to tell a patient that you have cancer, the question from patient shouldn't be that how much time do I have? The question should be, what will it take to cure me? That's the journey that we have to make across, and that's where we have to take the country to.
Wonderful. I think we all dream for that, transformation in our, in everyone's healthcare journey. You talked about access, and that's one of the very, the fundamental issue many times when we look at diseases like cancer or rare diseases where the treatments are very expensive. In the morning session, we were listening some of the industry leaders talking about how do they try to create certain systems which can help in financing the treatments. Especially in the cancer space, financing of the treatment, especially the treatment which is maybe effective in a even relatively advanced stages, and also from the point of view the treatments which helps you retain a better quality of life. How do you see that can be bridged in our country? Because as you mentioned yourself, and I personally believe that post COVID-19, if the one of the major challenge we are all staring at is definitely the cancer. The kind of number of people are getting affected and impacted, and the kind of number of lives we lose, almost 8 to 9 lakh people every year, primarily because of the late diagnosis and many times not having the right access for the care. So how do you see that can be bridged? Who are the prominent stakeholders who should kind of take up the challenge, and how the companies like yours can kind of help that achieve?
So Kamalji, to answer that question, you will have to have a full day access meeting with IHW Council leading it. It's a vast topic. And I've said this earlier, I clearly believe access is a joint responsibilities of multiple stakeholders to ensure that people are able to get access to innovative new treatments to prolong and extend their lives. There cannot be a single answer. So we cannot say that X, Y, Z is responsible for access. It has to be collective responsibility. And different stakeholders have to come together, whether it's from healthcare financing, or it's innovative access models, or bold innovative plans, or even looking at a different way to provide insurances. We have moved significantly. Means I always compliment the government for their Ayushman Bharat and the way they have ensured that there is a healthcare coverage. How do we augment that is something that we have to look at it. So you'll have to do a full day access workshop if you want an answer for this question.
No, but I think you, again, as I said, that the people like you will, even in a short answer, can give a good insight, and that's where you talked about, and I'll continue to picking up those things, because you talked about engaging insurance for that. I think that is one area definitely a lot of stakeholders, and again we have to look at from the point of view of the putting the patient first in the whole system. And when we want to put the patient first in the healthcare ecosystem or the healthcare environment, we need to see that where all the patient will be distressed and how we can prevent that. And I think supporting patients financially is also an important step towards empowering them to navigate any healthcare challenge better. You talked about Ayushman. It has been a wonderful, I think, intervention from the government of India, where at least 50% of our people have a certain cover to navigate those health catastrophes. But at the same time, we also see, and which is, I think, with the efforts of all of you and the efforts of leaders like you, the government is also trying to bring in that whole missing middle part of that in this space. But again, the question comes back to that if we want to empower the patients to access better quality of care, better quality of medicine, better quality of support, we need to further enhance it. And as you also at the very beginning said, that it cannot be the responsibility of government alone. I think every individual is supposed to put in their own bit towards ensuring that. How do you see that different stakeholders coming together, maybe pharma sector, maybe the care providers, the insurance sector, and trying to come up with the solutions which is kind of empowering the patients to navigate these possible catastrophes in their life? The number will be less, but at the same time, since when they occur, they have big toll. So how we can do that? How do you see the collaboration as the medium to achieve patient centricity?
So I think all these stakeholders, Kamalji, is they have the same intent. And the intent, if you go and speak to any stakeholders today, is to put patient in the center and ensure that the patients gets the best access treatment. It's just that everybody is working in a separate vertical pillar to ensure that they are providing their own outcomes and their diseases. We've had, again, as I said, examples in India itself where stakeholders have just come together, sat across on the table, and come up with solutions. We have to exactly do that. But what we generally miss when we do these decision makings is that we miss patients or patient organizations on the table while the decisions are made. They have to have a right and say on every decisions that are being made. And that's something that I always encourage, that even in our organization in Novartis, we ensure that even in our clinical trials phase of designing studies, we have patient organizations giving their insights into the design of the clinical trials. We get patient insights right from the commercialization stage. And that's exactly something we need to do in order to get all the stakeholders together to provide the same outcomes.
Wonderful. I think, yes, collaboration is the way forward. Let me just, couple of last questions, Amitabhji. You talked a lot about, or you mentioned at least multiple time about the digital being a prominent medium to achieve patient centricity, empowering, engaging, kind of educating and also making the patient adhere to the, treatments, to the, healthcare supports. How do you see that? Would you like to define it a little bit more, how Novartis is utilizing it? And what can be the probable, scaled up model in that?
So digital interventions right from awareness to diagnosis to treatment and to ensuring a follow-up is there is something that needs to be looked into. At Novartis, we are trying to see that how we can shorten the patient journey using various digital models. But I would just want to go back and I want to ask Kamalji, 5 years back or 10 years back, we would have never anticipated that sitting home, we will manage all our financial transactions of a bank through digital medium. We would have never imagined that we will be booking all our travels and doing all our travels at home without intervention of a travel agency. Healthcare has to move in an area where empowerment comes to patients. How do I digitally intervene right from awareness to ensuring my health records are available with me at any given point of time, to ensuring that I'm able to reach doctors through digital mediums if required, to ensuring that treatment, I can go to a hospital and then do a follow-up on a digital matter. Digital interventions are going to change the healthcare scenario. Do we have a right model currently? No, we don't. But do we have a right intent? I believe that the country has a right intent to move up with a digital health mission and digital footprint getting stronger. What it would look like, we still can only imagine. But I personally believe that there has to be electronic record systems available so that people can move. If we can move with our Aadhaar card, we can also move with our health records in a digital format. We move with our financial, I don't think so anybody today is carrying more cash in their pockets because we have Paytms and other ways too. So similarly, the healthcare has to modify in a digital manner where people are more comfortable through digital interventions to map their healthcare journey over in the future decade.
Wonderful. So to map their healthcare journey and to also navigate it comfortably, I think that is how this digital empowerment will also help our patients to achieve. And I'm sure that Ayushman Bharat Digital Health Mission and the way the government is kind of trying to give the health ID to everyone, like you mentioned about Aadhaar card, and I think Aadhaar card is something which the government is very proactively doing that. So I'm sure that your dream and your vision of ensuring and achieving maximum centricity for the patients, maximum care for the patients will be achieved by the way your company and the various other stakeholders and the players of this important and critical sector are doing. Thank you so much, Amitabhji, for your time and insightful inputs.
Thank you, Kamalji. It's an honor.
Thank you. Thank you so much, sir. We request you to please step forward for a group photo op. And before that, we would like to present a memento and make this a memorable moment. Thank you so much, Mr. Amitabh Dubey, to share your insights along with us. Ladies and gentlemen, I'm sure that we have grabbed a lot of knowledge. Can we please thank him with a huge round of applause? Thank you. Moving on, and the next session coming up is a discussion on the topic that is role of patient communication, online patient groups and patient advocacy organizations in accessible healthcare landscape. I would like to invite our moderator for this particular session, Mr. Prabhat Sinha, Director, Public and Government Affairs, Boehringer Ingelheim, India. A very warm welcome to you, sir. I hope I got the pronunciation right. Thank you. A very warm welcome to you. We would also like to invite the panel members, Ms. Vandana Gupta, founder and CEO, We Care Foundation. A very warm welcome to you, ma'am. It was great to share lunch along with you. A very warm welcome to you, ma'am. Would also like to invite Ms. Bhavna Isar, founder and CEO of Caregiver Sathi. A very warm welcome to you, ma'am. The lady in this gorgeous sari. Very warm welcome, ma'am. Ladies and gentlemen, can we please put our hands together and give a warm welcome to our dignitaries. We would also like to invite Ms. Alpana Sharma, co-founder and director, Patient Advocacy, Cure SMA Foundation of India. We have all our dignitaries present on stage. We request all the dignitaries to kindly take a seat. And as this session has been moderated by Mr. Prabhat Sinha, we request you, sir, to kindly take it over. Thank you so much.
Thank you. So good afternoon, everyone. I can't see whether people are awake or after such a good food, we are, yes, it also energizes us internally, so very good. So I think, first of all, thank you, Kamalji and IHW for setting up this whole event and also especially for this session, because I think I'm the most privileged one to moderate this session where you will be hearing directly from caregivers and people who are living with a particular medical condition about a complex subject. What we heard is access and what role patient organizations and communication can play to facilitate that. So I will not introduce them because I will allow them to introduce them and also their organizations. Can I get the slides, please? I have one or two few slides where we will just set up a boundary of our discussion, because this is such a complex topic where we can go everywhere, we may not touch the subject. So, so that's why you will see this panel discussing more about access and about healthcare. Even we will try to understand what patient means, as basic as that, because a lot of things, once our basics are clear, then we understand things in a better way. And overall in all this thing, what role patient organizations play a role. Now before this, this is a challenge that we all know, nothing new. But just to remind us, when we will be discussing next 40 minutes, is we are living in a country where there is a huge lack of infrastructure, where one doctor treats 1,445 patients. There's a huge gap of trained and skilled resource in our country, right? We need, I don't know, 2070 and 30. Sometimes it's so difficult to remember these numbers, but that is the kind of, it's easy to become the most populous country on this earth, but to serve those patients, do we have these numbers? Rural-urban disparity, we all know. And the most important is the high out-of-pocket expense, because most of us, we pay for our healthcare, and that is where access becomes very critical. Now, again, when we think about access, just remember for this next 45 minutes is, those who need care get into the system or not, to me, that is access in a way. If they are there where they need to be, another thing is that it's not only finance. There are a lot of non-financial things what patients or caregivers might need it, and then you will hear from our panel. And that's why we'll say that now next few minutes we are going to see it from a very different lens. And these are three accomplished leaders sitting besides me. So I'll allow, I'll just say one line for each one of them, right? I don't know whether it's right, but Alpna ji, if I start with probably a disease which very few of us in our country would have heard about, which is spinal muscular dystrophy, SMA. Now I think there would be very few who have not heard about this disease. And it's few mothers who came together and made it a movement in this country. That SMA, the voice of SMA is across. I don't think even one MP in this country, they would have left reaching out and told that there is a need, we exist. So Alpna ji, if then Bhavana ji is, I don't want to talk much about her, but one thing I want to talk is the caregiver. A lot of time we talk about patients first, but I think caregiver sometimes comes even before patients. And you will hear this subject, and when I was talking to her, there are many things that we feel that we don't know, and we need to know about it. So a very focused approach of how to engage with caregivers and putting caregivers' need in front. Caregiver Sathi, the organization that she runs, does in a fantastic way. And Vandana ji, she herself fought cancer years back, and she has been when in this country people started talking about patient advocacy, formally I don't know whether we were knowing patient advocacy, but Vandana ji was doing it for years, and she will talk about WeCare. So Vandana ji, will start from you. If you can just introduce very briefly about WeCare and then ask people to go to your website and know more about you later on.
Thank you very much. Good afternoon, and thank you very much for having us here, and thank you to Prabhat for the introduction. I'm Vandana Gupta. I had cancer 30 years back, which itself I think is a record, and I must say treatment by the doctors and my own ability or desire to fight and come out winner. At every stage it was like, I don't think I will survive, but there was somebody who always came and told me that, you can do better. And so the motivation came in. And then while I was getting better, I thought I must do something for the other patients, because 30 years back, as you can imagine, there was no Google, there was nobody to give any information, and nobody really spoke about cancer because it was a taboo. It was a stigma to get cancer, and it was a taboo to talk about the subject. So at that time, I thought that, if I get well, my motivation would be to start talking to patients and giving them information that they need, which I did not get, and also to tell them, anything that they would like to know about cancer. So that is how, with no knowledge at all about medical areas, that WeCare was, I started working. There was no WeCare at that time. I was alone. I used to go single-handedly to the hospital and interact with the patients, to the extent that they would, actually pull my hair to see whether it was real or a wig, because nobody knew that hair would come back after the treatment. So after a couple of months of being in the Tata Memorial Hospital, we decided to form WeCare Foundation, and that is how the organization came up. And, we grew our organization in a way that whatever is needed by the patients, let us not be very firm on what we want to do. If a patient needs something, how to incorporate that in the program. So we were very flexible in our program, but the main thing was that we should be able to give them information, we should be able to counsel them, and counsel not in the traditional meaning of the word, but it was counseling to be with them. It was like, there's somebody to hold your hand at every step of your journey. To be able to give them finances for their treatment, because we all know that finance was a big problem, and also to have a data bank where they can get food, where they can get accommodation, how they can go to a trust to get funds, what are the bus routes that one should take, something very, very basic. And that is how the organization started. And over the years now, we've been doing a lot of things and many programs have joined in. So like Prabhaji said, please go to our website, www.wecarecancer.org for more information. Thank you.
Thank you. Yeah, so over to you, Bhavnaji.
Good afternoon. Delighted to be here. Thank you for having me. My name is Bhavna Isar, and I'm the founder of an organization called Caregiver Sathi. I believe I have been a caregiver for as long as I can remember. And I would like to quote Rosalind Carter in saying that there are only 4 kinds of people in this world: those who have been caregivers, those who are caregivers, those who will be caregivers, and those who will need caregivers. So can I have a show of hands, or can I ask any one of you to stand up and tell me if you belong to any of these categories? Any of these, or maybe more? And those of you who don't relate with any of these categories, do you think you are friends of people who are caregivers? The second thing that I'd like to tell you is that it is interesting that in South Asia, there is no term equivalent to a caregiver in any of the languages. So if you were to look up any of the dictionaries or translations, you will find words like sevak, sahayak, timardar, but not a term that can be used for a family caregiver. I was in my teens when my father had a terminal illness, a neurological condition called multiple system atrophy. And in being a caregiver at that time, I didn't know that I was being a caregiver. All I knew was I'm doing what a good daughter must do, like all of us do, right? But what caregivers go through, like my mother, who was the primary caregiver, went through during the early days, she was younger than I am today, in caring for my father, I believe that caregivers have to navigate a lot of challenges. It is not just the illness of the patient, it is finances, it is emotional care, it is social isolation, it is many other things. And for women, it is also loss of their careers, financial freedom, sometimes even their dreams. So Caregiver Sathi is the support system for family caregivers across all medical conditions, especially those who provide long-term care, so that they can navigate the caregiving journey with ease. How many of you used a GPS to get here today? So just like you use a GPS to move from one point to another, Caregiver Sathi is your GPS in your caregiving journey. I believe it is also at the intersection of what I have done in my life. I always wanted to be a techie. I could not be. I have been a HR, OD, behavioral sciences person. So I have tried to put my love for technology, my experience in behavioral sciences and learning, and my life experience of being a caregiver to make sure that caregivers of today don't have to go through the challenges that we had to in our journeys.
Thank you, Bhavnaji. Very beautifully explained. Now I move to Alpnaji, if you can introduce you and also a little bit about your organization, please.
Very good afternoon, everyone. Thanks so much.
So very good afternoon, everyone. Thanks so much for the opportunity. I'm honored to be on this panel. And I'm Alpna Sharma, co-founder, director, patient advocacy of Cure SMA Foundation of India. My 11-year-old son, Arav, has a condition, genetic condition called spinal muscular atrophy. And it's a rare genetic condition. When Arav was diagnosed 10 years back, there was nothing in India. But thankfully, I come from a family of doctors. And so when, Arav got diagnosed, we were lucky to be connected with the doctors, and especially we went to abroad where a lot of research was happening. And once I came back to India, I started searching for many other if there is any organization that is working on SMA, there were none. So I started with a Facebook page of 5 families, and today from 5 families, we are more than 1,250 registered patients with us. And we are very grateful to especially Prabhat sir, who has been a mentor, guide to many such patient organizations like us. We are not trained to do what we are doing today, the advocacy with the different stakeholders. But thanks to him, thanks to many compassionate souls we met who guided us, and through Curiosity Foundation, we have tried to bring all these stakeholders together. That is the external stakeholders, which is industry, the government, the HCPs, pharmaceuticals, society, insurance, and the internal stakeholder, which is our parents, patients, and caregivers together. Please visit our website, www.curesmaindia.org, for further details. Thank you. Thanks a lot.
Thank you.
I didn't give my website details.
Sorry?
I was just saying I didn't give my website details.
Please.
But you can look it up. It's caregiversathi.co.in.
Yeah. Please do visit their websites. I think, this was a very brief introduction. But once you will go to these websites, I'm sure there will be something to learn about. So do visit their websites. All three organizations are very active on social media. Follow them on whatever platform you follow them. Because once we try to kind of really follow patient centricity, it's very important to keep listening. And I think a lot of knowledge, a lot of insight you will keep getting from here. So now we'll come back after this introduction, and this was important because now you know the variety that I have on this panel. From a rare disease, oncology, and an organization which works with caregivers. So now, as I said, now when we talk about access, we saw that basketball court, and that it's very difficult to put a ball into this unless you are very trained. I think I always see access in that sense. You try, and then ultimately with multiple people working, one of it puts the ball in. Now, one is in healthcare, one is which providing the access, maybe the healthcare provider, hospitals, doctors, nurses, there are many players who are the provider side. And then there is another side which is who are kind of seeking the services. Now we are going to focus more on how do we reach out to this segment who is seeking services. And in that, how patient organizations have played their role, they are playing their role, and what role they can play. So that we are focused on what we are going to discuss. But as I said, before we start, I just want to go back to you, Bhavanaji, and understand when we talk everywhere, patient centricity, patient first. When we think about healthcare, we think about patients. But do we think in a right way, comprehensive way, whether patient is just patient, one eye, or there are many things in patients? So what you understand with patients?
So last week, I lost my mentor who was very dear to me. He was a very well-known name, also a trustee on Indian Cancer Society. But I knew him when I was working at Castrol. And one of his guidance used to be always, so he is Naveen Kshatriya. I don't know if many of you may know of him. And one of his guidance always at work used to be always start from first principles. Yeah? So I think today if we were to start this conversation and if we were to start from first principles, we would say, who is the patient? So is the patient the person who has the disease or the disorder? Or are there some invisible patients also? What about the invisible patients, the family members, those who don't even have a name, and in many medical fraternity, they might be even called bystanders, but are actually equally involved, have a full stake in the health and well-being of the person who is struggling with the illness. Are they patients too? I believe they are. So if we broaden the definition of who the patient is, not just the person who is navigating the illness, but the loved ones around them who have to watch, sometimes helplessly, and sometimes have many other things to handle. So I would like to invite all of you to change the very definition of who a patient is. And the second thing that I'd like to say is most patients are not necessarily very patient. So maybe we just need to have a different lens.
So this is very important, and keep this during this conversation that when we think about a patient, it may not be a person who is living with a particular medical condition. There are many. And then when we think about access to services, it may not be limited to only to that one person who is living with that condition. There are many things around that. So this brings me to a question to Vandanaji, because you have been working with patients and caregivers. Now, in today's world, communication is, I think there is too much communication or there is no communication. But definitely there is a chaos in communication. You know, there are multiple information sources which patients also access, caregivers also access, and relatives also access. And then once somebody is ill, sick, you know, you get all this information. I was down with dengue, and I think at least 100 people would have advised me to have papaya juice, right? And they also followed it up, that did you take? And then once I got fined, they said that I told you that you took papaya juice, that only increases the platelets. I didn't take. But that is how the communication is happening. But how do you see the knowledge or the information reaching to patients at this point of time?
First of all, I want to say something about patient centricity. Since morning, we have been talking about patient centricity and how important a patient is. But when this session starts, most of them have gone out. There are very few people, and I think they need to be acknowledged because probably they believe in patient centricity. So, you know, we talk more about patient centricity, but when it actually comes to doing or understanding or hearing, we are not really interested in the whole thing. So that is one grouse, you may say, that I have with the people. So I think we can give them a hand, the people who are here and are listening to us. About the information being passed on to the patients. I remember that when I used to have chemotherapy, every evening on the previous day, somebody would ring me up and tell me, chemotherapy mein aisa hota hai. All negatives. And I would go for my chemotherapy thinking I'll never come back. It was like going to a slaughterhouse where I would be just chopped off and I'll come back. This went on for a few days, few turns, and then after that I stopped receiving those phone calls. Because I said it doesn't help me in any way, it's only adding to my problems. So while we are talking to the patients, we tell them that there is a lot of information nowadays on Google which has to be taken with a pinch of salt if you want to read it, or you consult your doctor. Similarly, the caregivers and the relatives are informed that, read whatever you want to read, but don't pass it on or force it on to the patient, because everything that you read may not be correct. So it is best to talk to people, and if there's somebody who is telling you about chemotherapy, radiation, treatment, I mean, my focus is cancer. So please ask them if they've gone through that experience. If they've gone through the experience, it's fine to listen to them. Otherwise, tell them that you don't want to hear it. And as organizations who are dealing with patients, our role is to empower the patient by giving them as much information which is correct and focused to be able to deal with the illness. And that is how I would say that we should all work with. Give as much of correct information to the patients, to the family, and to the caregivers, and to everybody around them, so that the patient is really looked after well.
Now, since we are talking about access to care, we heard in the previous session a lot about, as a country, we have many insurance programs, government has a lot of schemes, but working with this community, do you feel that people have adequate information about various schemes, let's say Ayushman Bharat? And if the answer is, and this is a journey, right, so people may not have 100% information, but what is your take, what is the current situation, and what needs to be done so that we actually, as a patient organization, what would be your wish so that people actually know about these schemes and programs of government?
See, how we deal with this situation is that we ask each and every patient to go to the social work department, because that is the first part. Once they are with the social work department, they get guidance into all the programs and schemes in the correct way. They are guided properly. Which papers they need to take, what they have to do, which category they would fall into, because there are a number of schemes that are going on, and I would not know without doing the financial assessment whether they fit into that program or not. So it is best to take the guidance of a known person. Now, we do know, like in Ayushman, there are some medicines which are passed, approved, but are not coming to various hospitals. Now, so I cannot tell that patient that you will get this in Ayushman, because probably that hospital does not approve of it. So it's best to let them talk to the Ayushman counter about that. About the Chief Minister's scheme, just yesterday I was told that if the person approaches, there is a helpline service 24/7 at the CM's office, and there you can get your reimbursement done right away. So those type of things should be informed to the patient, and I think it's and then social work department, again I say, social work department is really adequately informed. And also, as patient organizations, whoever is working with the patients should get hold of the social work department to train them. So that once we are trained, then we can pass on the right information. When we are studying, then we go to a teacher to get the training. And once we are trained, then we can learn and we can go on into the higher classes and so on and so forth. It's the same thing with the various access programs that are there, whether government schemes are there, whether it is, the state government, because we have different things, whether it's central government, state government. And also there are a lot of companies, pharma companies, which have some access programs for their medicines. But they do inform the doctors about it, but very often the doctors forget to tell the patient. There are times when I've rung up Mr. Prabhat to say that, is this medicine under a program, and if he says yes, then how do we go about it? So if the pharma companies also believed in us and told us about the access programs, it would be very, very helpful, because we could give the right guidance to the patient.
So very clearly you are highlighting that if there is an access program, sometimes patients or caregivers may not be knowing that there is something exists, right? And जैसे गवर्नमेंट में होता है ना, if a letter goes, उसके नीचे CC बहुत सारे stakeholders होते हैं जिसको भी inform, and I think a time has to come when CC has to go to organizations who are actually front-facing patients or caregivers. So that is a very clear-cut ask, or I think the voice that we are hearing, and no doubt about it, more and more such information will help people to get not only access but timely access, because many times it just delays. So a patient might be revolving around, and they just lose a month or so before they come to know that there is an access program.
See, we should believe in equality of treatment. If there is a medicine available, why should only the rich be able to take it? It should be available to all. So for that, as many programs are known to us, the better it will be for the patients.
Very good. So now I'll move to Alpnajit, to you, and the rare disease. While we heard about cancer care, there are many organizations. A lot has been happening for years, but the story is not the same when it comes to rare disease. Especially in case of SMA, when you all started, there was no drug approved in this country. And it's a life and death every day at families at home. And in that condition, how it's not only drug which is available, but how you started working with various stakeholders. If you can just share that journey. It's a journey, because it's a long journey to get access, but I think there has been milestones that you have achieved. So if you can talk about those, some of the milestones which this audience would be happy to know about.
Thank you. Thanks a lot, sir. So SMA is a rare disease, and first of all, the families that are affected by such diseases, they are in a space where, even I was, why me, why my child? And if you, 10 years back also, even if there was Google, there is no definite answer. Even today it is not there. But we have tried to use that technology. At Cure SMA India, what we believed, and that's what we now practice, is for rare diseases as well as I would say for all the diseases, self-advocacy is very, very important. Rare disease affects minuscule population. So until each and every patient becomes a self-advocate, awareness is not possible. We need to make all these stakeholders aware about the condition, aware about our struggles, sensitize them. So what we did was we started actively engaging with all these stakeholders, and that helped us to amplify our voices in terms of improving the access, I would say, to care. When it comes to treatment access, at Cure SMA India, our goal revolves around 3 A's, which is availability, affordability, and accessibility. In rare disease, we know many companies and many conditions where it has been 10 years and none of the drug has been launched because India doesn't have a system of reimbursement or a mechanism where the access to drug is there. And the pharma companies or industry have their reason. They say that what is the point of bringing a drug if the access is not there? Having said that, we worked very closely with one of the companies. We are working with all the SMA companies, the drug producer, and we are very thankful to those companies. It's also, there are examples of co-creating solutions and wins that are there, where one of the drug was launched in India. In FDA, it was approved in August 2020. Within a year, it got launched in India, which is kind of historic. We worked together with all these stakeholders for the expedited access or expedited approval to this drug. Now the drug is available in India, and we are working again to make that affordable and accessible. So there has been many milestones in that journey, where I would say there was partial wins, where one of the state, Kerala, their 40 children are getting the life-saving drug. We have filed petitions. There is an ongoing court case which is happening, where our request has been to get the government attention through these petitions, so that they can bring all these stakeholders, especially pharmaceuticals, to discuss how to bring the access. The reason is, as I remember in the previous session, Amitav sir was also very aptly saying that access is not up to one person or one stakeholder. We all need to come together. And if we come together, solutions will be there, solutions are there. So there's another example for us where there has been win, where there was amendment in Drug and Cosmetic Act of our country. We were instrumental in that, where there was compassionate use of drug was coming. A company was willing to provide that, but in our country the clinical trial rules and many of even the Drug and Cosmetic Act are very old and very stringent. So we got the evidence from our partners organizations based in Cure SMA US, SMA Europe, gave those evidence, and there are bureaucrats, there are people who are helpful as well. We have our task force team of clinicians, about 40 doctors of most clinicians are there, who helped us to form that framework, and was presented and the laws were amended. So, and it's still a journey, because for majority of the patient, the access is still missing, and we really hope that with the collaboration we can achieve at least the full access. Having said that, I strongly believe that for the sustainable solution, especially in rare disease, government intervention is very, very important.
I think this whole work what Cure SMA did with industry, I think it's an example that, and I think most important was trust, that how a patient organization and a company who was about to launch that drug in India worked together and made access possible. And now hundreds of children in this country have got an extension of life. So I think Cure SMA needs a big round of applause from all of you. I think to make this possible, and not only for SMA, but I think the way, along with many other similar passionate organizations, they have been changing the whole discourse. Now, currently, the rare disease domain, those who work in this, is that how active that whole space is. now they have also reached out as a patient organization to court. Now court is asking government to work for a solution. And then in turn, government is reaching out to various stakeholders. In this country, first time probably I have seen where the government has reached out to companies to negotiate on pricing. For so many years in this country, we had only the L1. The life is Q1, but it's L1 when it comes to getting a treatment solution. But now, very genuinely, government has started having those conversations. And in those conversations, and a lot of credit goes to organizations like SMA who took this their own issue to court, and now the court is actually putting pressure on government, and and when a solution comes, it's for everyone. So a lot of good work happening
Must
in that.
mention, Prabhat sir, I keep bugging him with a lot of questions. It's a very tedious journey, the way policies are formulated. Today, if you go to the rare disease portal, there are 999 patients registered, and the total amount collected is just 2,86,000, which is not even a fraction to treat single patient. The picture is very dismal. We all know that when it comes to changing law or the government policy, it is more of a restrictive. And in that, we need guidance from many of the industry. All those who are listening, I would say that getting a seat or hearing the patient voice is very important, because every stakeholder brings their own expertise. We are living with this 24/7. So probably, the kind of insights we can share will help to get the solution faster.
Sure. Thank you, Alpna ji. Now, Bhavana ji, because I think when I see, for example, SMA, I think people who are living with SMA, whether young child or even adult children, I think a lot of work is being driven by caregivers. And in this case, it's a lot of mothers who are actually driving this whole initiative. Now, when we think about access, when we think about caregiver, do we need to do something differently? Because there has been a particular way we have been doing things, communicating and talking about it. What is the new way to do things?
I think I'm going to honor Mr. Naveen Kshatriya again and say that let's start from the first principles. So starting from the first principles, what is access? So if you listen to whatever Vandana ji or Alpana have said, we are talking about access to medication because our primary need is cure. Why do we want cure? We want cure because that is what gives us hope. So caregivers and people we love are looking for hope fundamentally, and at some level feeling helpless. Access is not just about the medicines that you need. You also need access to counseling, hand-holding, support, community, all of which takes a backseat. So I'd like to broaden the definition of access. When we say access, we are talking about holistic care and an understanding of palliative care. Palliative care is so misunderstood. It is seen as end-of-life care, whereas it is actually holistic care, which needs to start much ahead and support all the stakeholders, the patient, the one with the disease or disorder, the family members, sometimes children in the family, and the healthcare workers also. Because the key ingredient of quality of life is not just cure. It is having a good life, having memories, and having relationships that you can look back on, and that requires compassion. But the compassion that we can offer can run out. I'm sure all of you knew during the pandemic, we heard so many stories of people losing their lives, falling ill. I certainly ran out of my compassion. I don't know about you. So my belief is that compassion, which is the key success factor for having good quality of life, is actually a perishable resource, but it is also a renewable fuel. What Alpana can do for her son and out of compassion for the whole community of SMA or what Vandana ji does through her organization, is fueled by compassion. And we need to be able to create access to compassion as well, not just medicines.
So I think in a very simple yet very powerful way, you said access is not only access to drug. I think if one thing we had to remember is that it is not only access to a drug. Many times when we think about access, 80% of our effort we put on thinking about access to treatment, but there is a lot beyond that treatment. Now, we are just 6 minutes away from our time, but when we were discussing to prepare for this discussion, Vandana ji is very passionate about one subject, and I don't want to miss that subject, is when we think about access and specifically access to treatment, and we also heard Amitabh sir talking about it, the engagement of patients starts right at a very early stage, but clinical trials and clinical studies is something which is very critical. If it is not positive, but we don't have a very positive kind of motion about clinical trial. Now, what is your opinion that when we think about access, this is very basic. If we don't have clinical studies and trial, we may not get new drugs also. And how patients and patient organizations are consulted, involved, engaged?
So I as a patient would like to say that clinical trials are an absolute must for the country. But at the same time, there should be no clinical trial or no decision about any medicine without me as a patient being involved in it. So that is the first thing. When the clinical trial is being designed, why is a patient not a part of the designing? It need not be an active patient. It could be a patient advocate who has gone through it. Because they would know the pain points that the patient faces, so they will be able to speak on behalf of the patient. Secondly, while the clinical trials are being executed, then at that time, why is a patient advocate not a part of the team? Because very often patients are not able to talk to the doctors who are giving them the trial or who are taking care of them during trials because of the fear that if I speak too much or if I ask too many questions, the doctor may get offended. So if a patient advocate is a part of the team, it can be somebody without the white coat who can be more like a family person who can answer the questions, who knows about it. So that is another thing which I really feel should be involved in it in the clinical trial phases, that a patient advocate need to be present during the trials. Why is a trial always, when a trial is being given to a patient, it's always said, आपका बहुत अच्छा इलाज होगा, आपको बहुत ध्यान रखेंगे. इसका मतलब पहले का जो इलाज हो रहा था वो बेकार था. So why are you putting that? Why don't you explain everything to the patient? The informed consent form, which a patient is asked to sign, is almost a 10-page document. Fortunately, I would say I've made that effort and it was translated into Hindi when I was in the ethics committee of Tata Memorial Hospital. But the Hindi is so classic Hindi that it is difficult for anybody to understand. I read out a passage in the hospital in the ethics committee and asked the doctors who were present if they understood that. And most of them could not understand that. So doctors who are familiar with the technical terms are not able to understand the informed consent form. Why are we giving it to the patients? And what care are we giving? I have seen patients who don't know Hindi signing a consent form of English, which means we are not being careful about it. So what is the point of doing a clinical trial? I know it's not always that it happens, but it has happened. People are asked to sign the form right away. We are going to give you the best care if you sign this form and give it to us. And they have to sign it and give it without understanding what they are signing, without knowing what they are signing. So I would say the clinical trials must be done, should be done on all the patients, but the things should be explained. Because it is important. I must tell you something. When the clinical trials for the COVID medicines were being done, I wanted to be a part of that clinical trial. And they said you can't be a part of the clinical trial because you are a cancer survivor, which means you are testing the medicine on everybody else, but when it comes to giving, you will give it to me. But you have not tested it on me. So what is the point? I need to understand that.
So I think you very rightly said, nothing about us without us, right? So you have to involve patient organization, and also in all the ethics committee, there is a lay person. It is termed as lay person. I think the lay person should be the most experienced person who are going to be a very critical partner. So I think so when we think about patient first, I think there is every area starting from clinical trial to drug delivery, access program, everywhere there is a role what patient organizations can play. Now we may just take a minute or two extra, but before we end, because the people sitting here are from different aspects, some are from organizations for patients and caregivers, industry and all. So I'll give you a chance to ask one ask, right? What as an organization, if you have to prioritize and say that this is what we want from industry for the betterment of patient community?
So it is, our humble ask is collaboration at all the levels, right from diagnosis to treatment to follow-up to care, collaboration at each and every level. Not just for the sake of it, but we have, as I spoke earlier, we have witnessed the co-creation of solution and many other wins that can help everyone in the society, not just the patients. So from industry, our humble request is collaboration at all the levels. Thank you.
I know everybody will have a lot of asks, but I, as a cancer patient, want to tell people that after a couple of years, we should not be labeled as cancer survivors. There should be a limit. How many years can we continue to be cancer survivors? I'm a cancer survivor even after 30 years. I can't get an insurance. Thankfully, I'm not so young. Otherwise, I would not get a job. If I was younger, I would not get into college. So please don't label me as a cancer survivor is my ask. I mean, not me now, but the youngsters, after a couple of years, they should decide, when they can go. Because if I go to a hospital now, I go with any disease which could be because of my age. It's not because I'm a cancer survivor. So that label has to go, and that is my ask.
Bhavanaji, to you.
Okay, there was a lot of conversation about how can we reduce the tension in doctors getting beaten up and patients not feeling heard and some things around that. Not as a solution, but my ask is that we stop, we are able to step back and be able to give equal footing to all stakeholders. The medical and the healthcare system has a very deeply entrenched hierarchy. And I'm saying it is time we dismantle that hierarchy and treat all stakeholders as equal partners. Because all of us are just touching the same elephant. We are calling the same elephant, but from different perspectives.
Very good. This discussion can continue and continue, but I'm sure with the limited time what we had, as I said, very simple yet very powerful messages that you would have got. And if I have to summarize, I was thinking, so 4 words came to me, which is PACE, PACE. So first is what Alpnaji talked about is partnership. There is a greater need of partnership. Then Bhavanaji, you talked about acknowledgement. I think now we need to acknowledge that the patient community, caregivers, all these things exist. And that's why when we take decision, we need to involve and engage them. Otherwise, sometimes patient-centricity is patient is at center and we all are working around, and patient is also at center, watching that everybody is working for me. But is there a way that patient actually gets engaged? Otherwise, वो न्यूट्रॉन और प्रोटॉन वाला चक्कर होगा, वो घूम रहा है बाहर. So the second is the acknowledgement, and as Vandana ji talked about communication, it is very important to communicate. And E, I will add from my side, is empowerment, because this whole thing will happen when you bring leaders like them on panel like this everywhere. And once you listen to them, I think if our goal is access, I think we will be able to reach this goal of access much faster, more comprehensively. So with this, thank you so much, three of you, for sparing the time, and a lot of good wishes what you all do. Thank you.
Dignitaries, thank you so much for presenting and sharing your insights, your knowledge along with us. Thank you so much. We request you all to please step ahead and come together for a group photo op, and then we shall be presenting the mementos. Ladies and gentlemen, I hope we all had a great time listening to the knowledge and insights shared by them. Can we please thank them with a huge round of applause, everyone? It's that moment of the day to capture some beautiful memories and keep it for a long, long time. It's now time that we present the mementos, and to present the memento, may I invite Mr. Vivekanand Mishra, Vice President, IHW Council, on stage. Please, thodi zordar taaliyan ho jaye as we welcome him on stage. We shall be presenting the memento to Mr. Prabhat Sinha, Director, Public and Government Affairs, Boehringer Ingelheim, India. So we present it to Ms. Alpana Sharma, Co-Founder and Director, Patient Advocacy, Cure SMA Foundation of India, Ms. Bhavna Isar, Founder and CEO, Caregiver Sathi, Ms. Vandana Gupta, Founder and CEO, We Care Foundation, and then we present the memento to the gentleman, our moderator, Mr. Prabhat Sinha. Thank you so much for moderating the session for us, along with the three gorgeous ladies on stage. Thank you so much for sharing your insights, ma'am. Thank you. Thank you, Mr. Mishra, for joining us on stage. Thank you, sir. Moving on to the next segment, which is a discussion on the topic of empowering patients through digital health innovations. We shall be inviting our moderator. I request you all to please join me in welcoming the moderator on stage, Mr. Sachin Jangel, Founder and CTO of GoQ. A very warm welcome to you, sir. We would also like to welcome the dignitaries on stage, Mr. Ajit Chauhan, General Manager, Marketing and New Business, Omron Healthcare. A very warm welcome to you, sir. We would also like to welcome Mr. Pratik Saraugi, Co-Founder and CEO of ActoFit. A very warm welcome to you. And would also like to welcome Ms. Saraswati Mopuru, CEO and Managing Director of Optimus. Very warm welcome to you, ma'am. This discussion is on the topic of empowering patients through digital health innovations. Our dignitaries are on stage. The moderator is here on stage as well. It's going to be a very interesting and a very insightful discussion on the topic that's been mentioned. I request the dignitaries and the moderator to please take a seat. And I would request the audience to please be along with us to absorb the knowledge that will be shared during this discussion. We shall now hand over the session to our moderator, Mr. Sachin Jangil.
Hello.
Over to you, sir.
Thank you so much. We are waiting for Pratik to come in. All right. So while he comes in and join us, let me introduce our panel first, and then I'll come to myself introducing. We have Pratik, who has just joined us from ActoFit. We have, again, what we are going to do is, we're going to have a brief, background of what we do, and then we'll directly jump into what, the topic is about. And then, we'll take it to a level of discussion where, we want to give more insights on each of our organization is doing about, the topic which we have. So, empowering patients through digital health innovation. Saraswati is here. We have Ajit here. So, we'll start with Saraswati.
Oh, ladies first. Good evening, everyone. Thanks for giving us this opportunity to put forward what we are doing and how we can help and make patient-centric, applications using digitalizing technologies that we have these days. So my name is Saraswati Mopuru, and I'm the CEO and the co-founder of Optimus Healthcare. At Optimus, we've built a platform to ensure that you don't become a patient, and we ensure that you live longer. It's a longevity platform. And also for patients, if at all you are into a chronic phase, you're dealing with any chronic disease or early stage diagnostics. So we use technology to help you use the tools to manage your disease in an efficient manner. So we know that patients today, if you will be overwhelmed with a lot of things, how to manage your lifestyle, how to manage your appointments, your medicines, etc. So it's a one-stop shop for people who want to manage their disease and for people who don't want to get to a point where they want to get into that chronic stage.
Sure. Pratik?
Hi, thank you for having us here. At ActiveFit, what we do is we work on chronic disorder reversals. And when I'm talking about chronic disorders, I think very similar to the other panelists out here, we work on preventive healthcare, which is to make sure that the patient does not really need to go to a hospital. And if he does, we want to get him back from that position very, very quickly. When we talk about chronic disorders, we are ultimately talking about more than 50% adults in India or globally, which are suffering from conditions such as hypertension, diabetes, obesity, and PCOS, thyroids. And these conditions are linked to metabolic disorders, or 85% of them are linked to metabolic disorders. So by improving lifestyle changes, as Saraswati just mentioned, or by getting into good habits, you can actually build your body in a way where you reverse or you do not even get into that space. So what we do at ActiveFit is generally with programs, devices, monitoring, diagnostics, and services, right, from doctors to lifestyle management services that help a user not get into that phase. That's it.
Sure. Thank you, Pratik. Ajit?
Yeah, thanks. So good evening, everyone. And first of all, I really want to share the gratitude to the organizer and the sponsor committee for creating the platform. My name is Ajit, and I'm a general manager for Omron Healthcare. We are a Japanese company, and we are very well known for our offerings into cardiovascular and respiratory field. Why this platform is very, very important for us is basically that not only device, but we have a very strong transition globally for device plus service or digital transformation of patient journey. So I'm really excited to have like-minded people who have established a lot of new concepts to actually add values to the customer journey in healthcare. So looking forward to have a great discussion. Yeah.
Right. Thank you, Ajit. My name is Sachin Jangel. I am the CTO and co-founder at Goki. And prior to Goki, I was in the world of gaming as my founder also. Early from the college days, we started doing gamings. We built games and all. Very interestingly, after that, we thought of the idea of coming into healthcare was very different for us. Our approach was very different, and ever since I came here for today's event, I was kind of looking at the patient first logo and part here. While we do work on that segment and that we work on those creative side. Essentially, Goki was formed to do prevention. So we are a preventive healthcare platform where we want to prevent illness. And as today in the early session, Dr. Sanjay Maheshwari said that we are 140, 160, and 200 crores. We are going to be 200 crores. How we are going to handle or how we are going to provide them care of the growing population. So one of the early thought we had was that we require a preventive care approach for managing such a big population, and that's where Goki is one of the major focuses where we want to prevent illness, and the way we want to do is through three words: motivate, empower, and reward. So the empowerment is part of our philosophy when we started Goki. And that's what the topic is today. And to start with, I also like to thanks organizer for giving us the opportunity to present and discuss this topic. As well as I like to open this with a question to all my panelists here, that what they think about this one word of empowering patients. While we have discussed and we have heard today empowerment in the space of fintech, mobility. People are now not carrying cash. People are able to book travel at the ease of home. Everywhere there is a lot of empowerment is happening for consumers, customers and all. So I think largely we need to first understand why this need is there. What's the fundamental need for empowering patients or citizens for the health is. So definitely I'd like to bring in our panelists to present their views on this. Ajit, you want to start?
Yeah, so this topic particularly is very close to my heart, and I think we all are living into the digital decade of India and the opportunity decade of India. When it comes to digital transformation, I think it revolves around 5 fundamental things which we all, maybe as a startup companies, established companies, lifestyle companies, we need to understand. That is there a need? And are we prepared for the needs? Who is going to do, how we are going to do, and then ultimately whether it's going to add the outcome. So I really want to touch upon these points. So when I was going through the understanding of whether we need a digital access, we feel that our country is very diverse. However, this diversification comes with a lot of challenges, like we don't have the right access of healthcare into tier 3, tier 4 or rural India. If you see the distribution of our doctor ratio versus patients, India has 220 million staggering hypertensive population, but only 7,000 cardiologists to treat that. We also have a very uneven distribution of medical infrastructure, and the awareness of preventive care is very, very low. If you see, people are even not aware about lifestyle-driven problems. So the problem is very big. And if you see the prevalence of the challenges and the chronic disease, that's very big. So what about solution? But for solution, are we prepared? When I see the data, and also maybe our accessibility towards internet, smartphones, the digital transaction which we are talking, right? Sachin was also talking about that. It is having a right indication that we are completely prepared in terms of infrastructure. But the idea is that who is going to bell the cat? How we are going to start. Some of us are doing our bits in pieces. So I think the collective collaboration is something which we need to come forward. Government of India has initiated few things. They created a platform called National Digital Health Mission. Everybody, including pharmaceutical company, healthcare practitioners, health tech companies, device company, wellness companies, and up to some extent insurance companies, that all need to come together. And we need to actually try to do something unique wherein we can create the accessibility to the consumers. But how it is going to happen, that's the 4 point. So I think without question, technology, AI, algorithm, machine learning, data is going to be the key enablers for this. And here I really want to put maybe certain data wherein our AI market size in healthcare is growing by 46% of compound annual growth rate, which is going to touch close to $44.5 billion size, which talks about the overall acceptability and penetration of AI into healthcare. You will also be very surprised maybe to know that a lot of new players are coming into this area, and only in COVID time, around 50 new companies registered their AI tools, machine learnings, and got the approval from the government. So a lot of new forces are coming to solve this. But one thing which I really want to keep in mind is that whether the customer is in the center, because if I need to pick all this process, I feel the consumer need should be in the center, and we should see that whether we are going to solve the unmet needs of a real-time need of a consumer at the last mile or no. Then only this technology-driven solution is going to be great. And that's where I see that it would be win-win for all. For customers, we will create right business model of accessibility. For companies, data-driven business model. For country, a lot of reduction into the burden of healthcare problems, also the financial problems, or the cost reduction also. Maybe just a last second I'll take. I was just going through one study which was done by Accenture in USA, that only AI is expected to support US government economy by $150 billion as a reduction of healthcare. So that has the power of, overall reduction and support. So this is going to be win-win for all these 3C, consumer, companies, and the country. That's why it is very, very critical. Yeah.
Right, rightly said. You talked about AI, data, and as well as the platform access and all. And all three of our organizations do have a platform, and we have an offering where we do provide access. We work on data, we work on AI. So I think from that perspective, Saraswati, you are, we are focusing a lot on AI. You are focusing a lot on, not just AI, but also, you're utilizing the power of, mobile and, taking it to the next level. So again, what it means for you and how you are enabling or how you are empowering, as patients and users, on your platform. What's your thought?
As Mr. Rajit rightly said that we are trying to harness the power of technology, I think it's too late. So we should have identified this at a very early stage. I think when all of us started identifying digital healthcare is probably after we were hit by COVID. Only then we realized that, we need to get virtual, we need to have virtual doctor consultations. Until then, all of us were very reluctant to even talk to a doctor on call. We always wanted to physically meet the doctor, but what happened the last 2 years in 2021 and 2020, we did come out of that. I think in India, I feel we are quite resistant to change. And once we break that, which is what is taking a lot of time, and technology is a powerful tool to break that and to penetrate and to give that empowerment, I personally feel that, healthcare should be driven by technology, and then we should harness it and we should reduce the burden of the NCDs. Like rightly said, the other speakers said that we don't even have cure for many of the NCDs, and there are a lot of rare diseases coming up, and some of which we don't even recognize, and healthcare is not even giving that much of importance. So what do we do to reduce all of this? Yes, I feel technology should be used. In what way? Technology should be used in the healthcare, first of all, trying to prevent. Let's get to the point where we want to at least maintain our lifestyle in a better way, in an easy way. How do you maintain that? I think digital tools are a way to, empower your health, and utilizing digital tools in maintaining your health is an essential factor these days.
Rightly said. So I think, one of the other things what we at Goki do with, not just enabling, as I said, our tagline has 3 words, empower, guide, and motivate. So, and reward. So one of the things what we use is the reward mechanism, which again comes from a gaming, that when you do something, you get rewarded for that. So I think that is one of the other thing which we feel, it really helps, and a lot of, motivation as well as empowerment comes from when people get this, instant, motivation. Because again, a lot of time during a journey of a care for a condition and all, it is little, a longer journey to achieve the goals. Ultimately, if you are battling a cancer, or if you're battling or if you are managing a diabetes, it takes a little while. So what really helps people to get motivated and get empowered is by access, getting reward, getting guide. So we have seen, what our previous panel was doing, in terms of caregiver and all. So again, there is something which, again, power of digital, can really help get that access to, people who have, who don't have access to this type of guidance, this type of caregivers. So Goki platform does that. Goki has, hundreds of, we call them coaches. We don't call them caregiver. We didn't actually we didn't find the right word for that. So we thought like, since we are calling our patients as players should be guided by a coach. So that's why we started calling them coach, and that's how it is. So the coaches are there who helps, guides, and then motivate our users, our players. Similarly, I think, with ActiveFit also, what you are doing is harnessing, technology. You have wearables, you have other part. So I think if you can talk about a little bit on, how you are utilizing those to again, empower patients, users to use, wearables, because that's something which, really works for a lot of people. They see something on their wrist all the time. It really helps.
Yeah, I mean, who would know better about that than you, right? And I think Goki has done a fabulous job in in creating a whole gamified version coming from your previous venture and figuring out how to incentivize people with games and motivation to keep them on track. But what we do differently out here and where we add value, where say you build a bridge between a doctor and a patient or a player and a coach, is we add value to the diagnostics that can happen at a virtual level. So we recently built a tool using a lot of AI and ML that can track your body vitals as you can from wearables, even from a phone camera today. What that means is we can access unaccessible parts of rural India, which were previously having to spend 3 hours to go to a hospital or a diagnostic center or spend a lot of money. So with a simple 30-second face scan, we can now detect what your blood pressure, heart rate, respiration rate, stress levels, HRV, and a few other parameters are. We're also working on cholesterol and estimated A1C. And along with that, we have, so all of this data is coming at a 95% accuracy, which means that it can be used for indicative screening. It can be used as a first step, which can then say, okay, now I need to, visit an actual doctor or a diagnostic center because I am prone to having a medical condition with so much confidence score or so much accuracy. And this is where, if we can detect conditions at an earlier stage, we can reduce the cost of healthcare for that patient. We can increase the inflow of patients into hospitals. We can also ensure that people are living a higher quality of life. And this same data can now also be used by insurance companies to identify the underlying risk when they provide the insurance premiums for that customer base. It can be used for pharmaceuticals to actually identify, how to treat a condition better, because a lot of pharmaceuticals are now moving into digital health. And for all the other players out here who are focusing on digital health or providing preventive healthcare solutions through digital health, diagnostics at such a groundbreaking and innovative level can really help level up the game and get their products and users the services which did not exist before. So that is one of the key differentiators that we built and something that we are currently focusing on. And we've got a lot of clinical validations going on, trial studies going on, which are already published, patents that are applied for. One of the patents that has already been granted in this space. And I feel, a lot of us need to keep coming up with new innovations such as this to change the landscape of how we are treating the solution today.
No, absolutely. So, I completely agree, Pratik, talking about, capability of this wearables and these solutions and digital solutions, getting to accuracy level, where, it is accepted by the industry, by doctors and all. So I think I think we need to go a little bit step behind, and I want to ask Pratik this question, follow-up question on this. What are the challenges you faced actually, getting to that level of, accuracy? What kind of, acceptance and, building a trust for the solution which you are offering? So again, what are the challenges as well as how do you overcome those?
Sure. So any and all such solutions require a lot of trials, studies, data population sizing, and obviously clinical studies to be done. And so this is something that we have constantly been doing. And once you get to a certain level of, say, acceptability in the markets, there are also different stakeholders who require different levels of acceptability. So someone like a hospital would be the last one to adopt something like that, but someone looking at a lifestyle change or simply getting a perspective in terms of what their health scores are would be the first ones to adopt it. The next ones, as you would obviously know, insurance companies would be the first buyers of this solution, because they don't really need medically vetted data. But if I was to say cure a patient or treat a patient who's suffering from cancer, right, I would have to rely on industrial grade US FDA approved products. So it is a cycle in itself, and it gets through the stages. But an insurance company just has to simply understand the risk of, or the likelihood at a nominal level when they endorse a patient for a particular policy. But a hospital or a doctor that is treating it has to actually be sure that, okay, this is the condition that he's having. So obviously the range of accuracy has to be different out there. So we're still going through phase 1 and phase 2. We have SAMDs applied for. We have a CDSCO approval coming through, and we have clinically vetted publications already done with peer studies. So that is where we are with this technology right now.
Yeah, absolutely. I think trial is something which is there. Of course, we need to go out and publish this data, get more people to adopt in, and of course, we require somebody who is inclined to and understand and has time and patience to do this. Again, I think similar problems, you might also have faced, and again, the repeated question is that how do you overcome those challenges? How do you see? Because again, since a lot of talk is happening about AI and all, at the same time, a lot of people are scared about, they are afraid of AI. So it is not very easy for them to opt in or adopt. So trust is a key factor into it. Do you want to trust, something which is artificial itself? So what are the challenges you faced and how do you overcome?
I think it's good to know that Goki and Pratik's company and Optimus, we are doing similar things, and we've also built a similar technology of using RPPG, which is the facial scan and the finger scan, where we monitor the same vitals, which is the blood pressure, stress levels of the individual, where people can't afford diagnostics. So our primary focus is B2B. We are targeting corporates, where we are trying to ensure that if the lifestyle changes are brought within the corporate sector, then it will be passed on to their family members. And as a community, this trigger will happen and we'll be able to do this. So I think in terms of the licensing was a challenge over here, because the moment you talk about AI and ML, nothing is standardized in this industry. To be honest, the diagnostics rates or the prices themselves are not itself, even that is not standardized. And people go to a non-NABL labs and they get the test done. And when we come up with technologies, aggregators like us, like Tata 1MGs and all of us, who have subscribed, and we have a set of NABL labs and a set of norms that we follow, I don't think anybody pays attention to all of this. Pricing is a factor because of they think that there is another lab down the road offering at this price. Why are you offering at this price? So I think quality is something that we try telling to people, that we are providing quality services. And AI, there's another fear factor of AI. Okay, what if the machine is wrong? What if we get the wrong diagnosis? That is again the lack of awareness for people. So we need to educate them and pass on the right knowledge, that they understand the healthcare and understand the involvement of AI. Of course, nothing is artificial. We have to make it to happen, and then the machine learns it. It's us first and then the machine next. So yeah, in terms of challenges, yes, we did. We had other challenges of adaptability as well. So there is a lot of resistance, because we are always, when it comes to health, we put it in the back burner. We don't want to spend it, but we are happy to spend 2,000 rupees on a meal rather than spending 2,000 rupees on a checkup or a diagnosis, because we are so reactive than being preventative. So I think the community trigger is quite important. I think we've gone through that approach of trying to spread this across corporates, so that if one corporate is following, the other corporates are also following, to ensure that they take care of their employees, and that passes on to the family members as well. Got
it. So again, rightly said, there are leaders who will adopt first, and then of course, there will be followers who follow in. A lot of examples are there, where, a lot of corporates, especially, are taking initiative to, adopt this type of technologies, as well as, to provide healthcare and all. And during COVID, actually, it, really, got accelerated also, because again, every corporate, every, employee was working remotely. So there was a need of, doing this remotely and adopt technologies, and that really helped a lot. But I think, Ajit, over here from Umaron, your company has been doing these devices and healthcare for decades. I think couple of decades now. So again, what is that learning for us in terms of startups, in terms of adopting new technologies? Because again, these are the challenges you must have faced long back and had already overcome and built all those things. So what are those insights? I mean, we'll definitely love to hear from you, and get some more rocket fuel for us, from your experience. And you are pretty much, I think, for the last couple of years you have been associated with Umaron. So I think definitely there is opportunity for us to learn from you.
I think we all have gone through this in some or other phases, and you are right. So little background maybe about Omron. Omron launched the first blood pressure monitor in 1973. So we are celebrating 50 years of legacy and sold close to 350 million units globally. But one thing which we understand, and that's where the question is, that when we started doing this transition of device to device plus service, we also started facing some or other or same kind of challenges what you are facing as a startup. Like Saraswati was talking about adoption rate and maybe the bounce rate and whatever we call into our jargons. The challenges is that people are yet not very, I would say, okay with having the constant investment into the application and whatever, no matter what strong platform you are creating, keeping consumer engaged is the critical part, right, I feel. So maybe it's a news for you, or I'm not sure, but we also have a platform wherein we have close to 1 million user base of Omron devices, wherein we are creating a very strong remote patient monitoring model, which is not more on the health and wellness side, but more on the medical side of it, because we really want to utilize our devices and their core in terms of creating the medical outcome of remote patient monitoring. And for that, we are doing a lot of collaboration. So just to overcome that challenge of adoption rate, we try to, collaborate with companies like Tricog, which are very strong in terms of their medical support. So they are the leading company when it comes to ECG monitoring. And we collaborated with them, and we are creating a platform called TriCare, which is going to reduce the hospitalization rate of heart failure patient. So basically, we are more now dedicated towards the serious audience, which has got certain challenges with the help of our medical device. At the same time, we are also launching some of the new devices, which are so much first time in India. Like we recently launched a blood pressure plus ECG device, which is actually going to play a very critical role in terms of managing the severe patients who can experience a stroke if at all they are not getting these indicators. But if I need to pick one thing as a learning, I think the monthly active users who come to your platform, how to engage them, how to create the right hook, how to engage them with the right sensitivity towards their health is same learning which I also carry, like you people carry. Yeah. But I think, as I said, that we talked about community, we talked about certain collaboration, we talked about holistic health. If everything comes holistically, there is a possibility of increased number of people. And after COVID, there has been a different trend about maybe acceptability of your health and wellness more seriously. But I think we all are going to the same trend. My recommendation would be, let's be more maybe engagement centric. That engagement should be very easy.
not a technology driven, because I think there is a lot of fatigue today for customers also. There are so many applications in the phone, and there are so many notifications in the phone that and there are so less differentiation sometimes that for them it is too difficult to understand that which is going to solve my real purpose. So that's what would be my, take home, that how we can add a right engagement.
Also, again, the idea is to, not just collaborate between the entire industry, but also look at, startups and other places. So how, is there a platform which, you have to offer to startups to, come together to work with you, collaborate with you, and identify, key, again, India as a focus, again, what's the focus for you to India, in India also, to do this type of collaboration, whether it's with startup, whether it's with healthcare, whether it's healthcare providers, doctors and all. So is there a platform, kind of, formalized platform you have?
So honestly, maybe not a very streamlined platform, but intentionally, we are very much invested into all kind of collaboration. Just few months back, we collaborated with a pharmaceutical company, wherein the idea was to reach and educate close to 100 million young population to just track their health. Because the only way to detect your health issue early is to screen yourself, right? And we are very poor in screening. And if you see even hypertension, most of our young audience understand that maybe hypertension is a problem of late age. It's not early age. But if you see certain data points, a lot of young audience has succumbed to death during maybe their gym time or doing a lot of cardio. So I think screening is very, very important, and we have a very clear thought that we want to collaborate with health tech company, with wellness company, with pharmaceutical companies, and with practitioner as well to educate, because India has a problem of penetration rate. So 220 million people and only 2% is the penetration rate of blood pressure monitoring in India. So you can understand. And in smaller countries, smaller geographies like maybe Brazil, Russia, they have more than 40% of penetration rate. So if I, of course, want to create maybe a platform with you people to, drive this awareness so that people come front, start screening, and screening will give them early detection. Early detection will help them for early monitoring, and then a lot of lifestyle support.
Sorry, I have a question here for you. So what do you think is the problem here? Like, why is it the visibility that we don't have, that like my experience the last couple of months, I've been speaking to a lot of VCs where we are trying to raise funding. So they said, how different are you from the other healthcare providers? We have so many healthcare providers, so many health tech companies coming up, and everybody is into wellness, or everybody is into holistic wellness. But why do we need to fund you? There are already enough players there. So these are the questions that I have heard, as you rightly pointed out, that for this huge population, there is still demand for a lot of companies like us to come forward and reach these people. Why are we facing the penetration problem? What do you really think is the problem there? Is it the visibility, or?
I think first problem is more from
thanks a lot. Thanks a lot for asking that question. Yeah.
Maybe it is a combination. I would not say problem, but maybe challenge which is there in the market. One is about the customer or patient or consumer side, that India as a country, we are not much invested into preventive care. I mean, we do a lot of maybe jokes also, that if we invest in 5,000 rupees of maybe a test, and if at all there is nothing coming, we don't feel good about it that we invested in a 5,000 rupees MRI test or maybe a CT scan test. So we believe and we are living with this kind of mindset. So I think there is a mindset blockage first, and we are not very well invested into preventive healthcare. As you said, that 2,000 rupees of maybe a holistic test looks very expensive comparison to maybe going for a dinner with the family. We also experience that maybe a device is a 2,000 rupees device. Globally, we are known for quality. We also offer maybe 3-year replacement warranty. So if you see, it's like 2 rupees per day for your family investment, but still people are not buying. So I don't see that finance is a problem. I see that the overall ecosystem has this less trigger to invest into the preventive care. The second thing I think, which is maybe a recommendation, is we need to be a little more creative and engaging about what we want to share, right? So I think creativity need to come in place, and gamification done by them is one of the right example, right? Gamification is today something which is working as a right hook. So if I need to maybe talk one thing to create the differentiation, one is about maybe more creative way to engage, and second is how you gamified it and how you also add community, societies, and the bigger population, thought leaders, practitioners also into this. Otherwise, there is honestly, there is no tailor-made solution. We need to be creative, and you need not to be creative to be creative. You just need to, think, visualize, and you will find the way.
Right. So I think one of the key word what I'll understand from you is, and most of the people who are here from all the industry will ask, is the outcome, and that's what it is all about. Whether we are showing data through clinical trials and all, the acceptance of that outcome is very important. And ultimately, if you are running a program, if you're running a care program, if you're running a program through digital solutions and all, people want to ask, what's the outcome, what's the result, did you succeed or not? So I think I'll ask Saraswati about this. Do you see what kind of outcome? Let's talk about outcome. What is the difference you're making? Do you see that using this? And I actually, at the end of the day, when we see the outcome, people feel more empowered. So.
Yes, yeah, that's the biggest thing, isn't it? So when we started pitching to corporates, so the managing directors and the HRs who were the decision makers to, implement this employee benefits or corporate wellness program within their organization, the first question what they asked us was, what is the ROI out of this? What is the return on investment that I'm getting? I'm investing almost around 1,500 to 2,000. I'm already paying their insurance. Yes, insurance they're paying, but they think that they're benefiting out of insurance. They can use it immediately, but what they fail to see it is by using our program, by using wellness, implementing that, you don't have to pay too much of premiums. Your premiums will reduce because your employees are going to be healthy. They are going to maintain a healthy lifestyle. So we then later on they wanted to see a visibility of the ROI. How do I see it on a daily basis that they are using it? How do I know that if he or she likes this program? So when we initially built, we only built the user application, only thinking about the user and not thinking about the person who's actually sponsoring this for their employees within the organization. That's when we felt that we also had to build a data analytics and a dashboard to represent how this, to give them a real-time analytics of the usage of the program and to give them a dashboard view of the improvements that they're able to see. So through our dashboard, we are able to give corporates a visibility of the holistic wellness, what are the concerns within each department, and at demographic levels, which area is actually not healthy, which area they have to focus, and which department-wise, who are the top performers. Again, a slight gamification. So if there is some issue in the sales and if they are red, so we all follow a traffic light system to make it easily understandable for them. So like if we have identified that majority of the corporate employees are having fatty liver, that is because of the junk food that they are consuming. So these are the small changes that they are able to see within the platform. Oh, my organization is going down this route, so I can probably react. So this is the visibility that we gave them. Although they are intangible, although the benefit out of this is far away, probably after a year or two is when they understand that they'll be able to reap the benefits out of this. And this has actually actually reduced, I can proudly say a couple of case studies of corporates that we have. They've seen the reduction of attrition rate within the organization by implementing these wellness programs. And that attrition rate is nothing but a combination of the health, the stress levels, and the wellness of the person. If the organization is not taking care of that, the attrition rate is going to increase. So that is the ROI that we gave them and we've shown them.
No, absolutely. So again, you're talking about corporate, but as a even consumer also or individual also, people are seeing result. People are seeing day to day. They are seeing result in their lifestyle, their well-being and all. Similarly, for Pratik also, since we are in the space of consumer as well. So how do consumers see this? Outcomes, how do they accept these outcomes? As I was giving an example, provided, people are using wearables, people are using solutions and all, they see everyday improvement if they are, monitoring their steps, sleep quality and all, they're able to see that. Those are the small or, real time on a daily basis, they're seeing the outcome. But in a larger, space where we are talking about chronic conditions and all, what kind of outcomes you are able to see, or how individuals are able to accept those outcomes?
Sure. What devices and wearables do is they provide data about your health, data about your body, and be that steps or sleep or heart rate or other factors. But how do you make sense of that data? How do you apply it to actually have a measurable outcome on your health? That is where I believe we all come in, right? And that is where we can measure outcomes in the form of weight loss. We can measure outcomes in the form of HbA1c drops for diabetic patients. And there are so many other metrics that we can measure that delta on. In order to get to that delta, I mean, everyone knows, okay, eating junk food is bad, sleeping 8 hours is good, and doing this is good, bad, etc., etc. But how many of us are able to actually follow it, right? Data shows that less than 1% Indians go to the gym. Data will show that urban population is far inferior in terms of quality of life as compared to non-urban population, whatnot. In order to get sense and move ahead, right, we need to actually work on building habit formation tools. We need to work on identifying what will work for you versus what will work for someone else. So what is good for you may not necessarily be good for someone else. And in order to make sense of that, that is where the wearables again come in handy, and to use that data in the right strategy, the right implementation methods is where hyper-personalization comes in. Be that with meal plans, or be that even with sequencing of meals, what you have before, what you have after. Be that with timing your exercise zones, when you should work out, when you should sleep, what is the most optimal range and the optimal time, and that is where science comes in. So a lot of things that we do is to create adherence, is to create compliance, and to create accountability. In terms of forming habits, again, that is where wearables come in, that is where data picks up, and that is where, say for example, we take a picture of a meal, and that picture would automatically identify what your meal contains. And this is simply built on Vertex. It's something that we've invented. It's just integrated within our platform, right? And this is because 95% of us do not measure or log what we eat, even though we are going through a program on our applications, and therefore the caregiver or the coaches are not able to provide the right guidance in terms of what you should or should not be doing, because they don't know why a sugar spike has happened or why your sleep pattern is not optimal. They don't know what you've had. They don't know when you've exercised. So getting input of that data is very important, and then to make effective changes. So what we do at ActoFit is we take more than 150 data points, right from your glucose spikes to your sleep to your body composition data, your stress data, and then we create algorithms at an AI level around that, and we train and test that over hundreds and thousands of patients, and to arrive at things that will work, and then we adapt that in an AI scalable model so that it can be provided to the masses at an affordable price point, and with regular follow-ups from the caregivers, so that the adherence is slowly and rightly built up.
I think the affordable pricing is something which is also, what probably helps. And but we are talking about the outcomes for a short duration or a chronic condition. What Saraswati's vision is to achieve longevity. That's something which is very, very, something, which we are also passionate about at Goki. What I wanted to understand is, how do you think, that this digital innovation is going to contribute towards, achieving a long and healthy life?
I think when we initially discussed, we rightly touched upon the point. All of us also said that we, in India, in a country like India, where the least importance is given to healthcare, and we don't want to spend too much of health. I think through
But then we want to live longer. Huh?
Yeah, but living longer only comes to us, only it kicks in when we are diagnosed with something. Only then
Our
we
Ashirwad
want
is,
to-
100 saal jiyo.
And even I was like that until I had my own personal issue that I identified when I was hit by autoimmune. When I was not a healthy person. I was not maintaining a healthy lifestyle at all. Although I knew that, I used to crave for, junk food. When I was living in the UK, that's when I had this issue, and that's why I came back to India and I thought that I should develop an app and give this to people so that in a country like India where importance for health is, it's least importance is given. And the reason why I understood behind that is people feel that, preventative healthcare is expensive. It is not. It is made expensive. People think it's expensive. And eating healthy is expensive. No, it's not. And staying healthy is expensive, difficult. No, it's not. I think having a gadget, and many of us these days, whether we hold something else or not, we are always holding a phone in our hand, like how Sachin has carried his phone along here. So we don't tend to forget our phones. And our phones have millions of applications, lots of applications, I would say. So why not have a healthcare application that is provided at an affordable price? I think technology reduces the cost, and we need to utilize that to give out the optimal care, and that's why we are called Optimus. Our app is called Optimus, and we help people. We are your personalized assistants. We give you doctor consultation. We give you, we tell you like how Pratik is all. Sorry, yeah. He mentioned that we have coaches. The coaches they don't know what you're eating, so what we have developed is we tell you what to do and what to eat. And this is quite personalized, and we are your personalized assistants. We analyze your conditions, preferences, and goals, and we give you a personalized plan. Like once you start following something for about 21 days, I think it becomes a habit, and we are trying to break that habit and help you live a longer life and a healthier life.
Absolutely, and that's what we are also believe in at Goki, that you need to live longer, you need to live healthier, and then there are fundamental pillar to that. And if we are able to manage that, that's the formula we have. We are about time, but I have I think one more question for all our panelists here. And since the entire presentation of the industry is also here, we are part of larger ecosystem. So what is our ask? This is something which I picked up from the last panel itself, that what is that our ask from a startup perspective or a young innovator perspective, as well as from a well-known companies perspectives. What is that we ask? What do we want to ask our fellow ecosystem partners?
My ask, I think in the last session also, somebody shared that let's be collaborative, not only for one step, right, from end to end. And of course, in this journey of end-to-end collaboration, there will be a lot of stakeholders who will come, right? So that is one thing. And second, I would say that let's keep consumer unmet needs in the center, and then try to create everything around that. And believe it to me, the main maybe hook, engagement, and adoption will come if the consumer is really feeling that, yes, I'm getting my unmet needs solved. Yeah. So these are the things which I feel.
Right.
I think my ask is similar ask as Ajit's. I think we need startups like us. We need collaborations. We need partnerships. We need big companies to partner up with tech companies like us and to promote the solution that we are trying to offer. It's not an easy survival in the healthcare industry, to be honest. when I started Optimus, it's been more than like 2 years. And yes, and we still haven't made huge profits because we are trying to still penetrate into the market and trying to give more service and more quality services. Versus, I started a small, franchisee food joint, which is making better profits than what I'm trying to make in Optimus. The reason being is healthcare is difficult place to survive, and we startups, we are trying to give a holistic solution in a difficult area, which is preventative healthcare, and where we need support of bigger organization to take this forward.
Pratik, quick one.
Sure. Very quickly, we are working with a lot of pharmaceuticals and hospitals. Pharmaceuticals to help them with digital care programs and therapies, and hospitals to help with diagnostics at some levels. I'd love to initiate some conversations with some of you who would like to know more about what we do and partner with you all from that angle.
Great.
Yes,
So I
very
think
directly and very shamelessly.
Yeah. So I think from my side, the ask, of course, I don't want to repeat what Saraswati and Pratik and Ajit has mentioned, but I do have one ask from IHW is definitely invite us in more of your conferences, more on, your, we love to participate. We love to, talk about, what we are doing, what we are innovating, and we love to showcase. And thanks a lot for inviting us. It was an honor for us to be here and share what we have been doing. And we really got inspired, with previous talks and with previous speakers. So I mean, this is an opportunity for us to showcase. We'd love to do it more, and that's what my ask is. Thank you so much.
Thank you.
Dignitaries, thanks a lot. We request you all to please step ahead, and I'm extremely sorry to come and interrupt abruptly, but we request you to please take a group photo op with that amazing smile of yours to share the moment. Also felicitating Mr. Ajit Chauhan. Well, let me introduce you all to Ms. Nikki Gupta. Panelists who share their insights on the topic of empowering patients through digital health innovations. I'm certain that we all have gained a lot of knowledge from this particular session. Can we please give some Zordar Talia and thank all the dignitaries for sharing their insights. Coming up next, this segment is a spotlight session by Mr. Varun Belgudri, Associate Director Sales, Walters Kluwer, India. A very warm welcome to you, sir.
All right. Good evening, everybody. I think thanks IHW for giving us this platform to talk about us a little bit today. So from a patient outcome standpoint and what we are doing really in India, and we'll try to cover who we are, what we are passionate about. It was really good to hear some of the new things that are happening in the industry. We will cover a market research as well, wherein we try to find out what is the doctor's behavior in a certain aspect. The last 2 points would be something that we are cooking up right now in our innovation labs. We would also like to talk about how our products actually fit into the journey of information discovery for a doctor. Having said that, I think, you know, who we are. You know, Wolters Kluwer is a 185-year-old company. We have had customers with us which probably are much longer than my age as well. We have close to 40 different offices. We are operating in 180 countries. Who we are is we are providers of professional information. We operate in 5 different verticals. Health is one of them, tax and accounting, legal and regulatory, corporate finance, corporate performance, and ESG. People might have heard about Enablon. We also work in corporate compliance as well. So we have 5 different verticals, each with expert solutions. Within health, what we try and do is we try and make the professional's life easier. So right from students, clinicians, we try to get the information to their fingertips, and at the time of point of care, at the point of reference, throughout their journey into a proper practitioner. And what allows them to do is take those critical decisions, perhaps in a much more informed manner, handle those complex cases, handle those unique and rare situations in a very successful manner. We do all this with about 20,000 people worldwide, roughly $5.5 billion company located out of Netherlands. Now, from a health standpoint, what we operate, we have medical texts right from 440 different specialties, different journals. We have associated ourselves with big names. What is really driving us is the digital piece. Up-to-date, Lexicomp are some of the brands we own, which we will also talk about a little bit during the presentation. The other aspects is actually having a research platform as well. This allows actually to become a one-stop shop solution for a particular doctor. We do also have some India ebook library as well, which is one of our medical educational solutions. So we are trying to power the source of information right from the educational days all the way till the practitioners, to the continuing medical education that a practitioner needs. Now, that is the depth of the portfolio that we have, and we continue to improve that. We continue to improve our quality as well as depth across the board. One of the things that has helped us last so long and have customers for so long is the quality of information we give, and that has come out of deep editorial rigor, having that unbiased nature of information. And that's why some of our products are running for decades together. We have our digital solutions, which has probably turned 3 decades. We have some solutions which have gone to about 6 decades. So there is a process to the madness, and that's what keeps us differentiated and continuing for this long. These are some of the things that we have. We have big name journals, societies that we associate with. You name a therapy area, we have a presence in that. Right from cardiology, gastroenterology, obstetrics, gynecology, pediatrics. In all aspects, we have a presence from a content standpoint. The next one is a little bit interesting. So when about a few months ago, we carried out this research, which was a combination of primary and secondary. About 4,000 doctors were part of this. We also involved a premium market, actually a consulting firm to help us with this. We covered about 8 different specialities and about 47 hours of primary research conversation. The aim of this entire exercise was to understand the doctor's journey when he needs information, right from urgent situations to the points of reference, right from his student days to his practitioner days. So where and how does he get that information? Now, what we found out were three things. One of them was that doctors generally triangulate. They try to find it from different sources of information. They sometimes even go to Google. They sometimes go to PubMed. They sometimes ask their peers. But from a digital discovery standpoint, it was what we noticed, a triangulation. One thing that came out was that a decision support system, like a summarized, a concise, a credible information source like UpToDate was really up high on that ladder, especially in those urgent and important situations that they had to deal with. The second thing, what we noticed is people like to dive deeper. A lot of the people wanted to understand, if there is a summary of, there is a finding, can I get into the depth? What is the source of information? Can I get into the scope of the study that was getting in? And it becomes very hard for them to actually get this. And that's where they keep struggling. Sometimes in urgent situations, they have to then rely on their judgment or for a peer instead of the data. So this was the second thing. And the third was that these are extremely busy guys. They're looking for sources which can get them to the information they need when they need it in the quickest time possible. So with this being said, we took this research and we thought that, how can we cook our products into creating a one-stop shop sort of a solution for the practitioners today. Now, with those thoughts in mind, I think there are three products that in combination actually create this solution for us. And this is something that we already have in practice or in the field. Customers are using it. Proven solutions. First one is UpToDate. UpToDate has 30 years of legacy here. About 2 million clinicians worldwide use it. About 37,500 institutions use it on a daily basis in their clinical practice workflow. One thing, in India, up to 2021, we measured the number of users and the number of clicks. We had about 8 million views of our articles. So that was staggering for us. This decision support tool is powered by deep editorial rigor. Again, from experts in their field, there are about 7,300 contributors, multiple journals, about 500 different journals referenced. This one, as you can see, there are more than 80% of the doctors who refer to this as their peers. This is one of the strengths of, one of the feathers in the cap of UpToDate. A lot of the information or people do believe that this is concise, and they about 90% believe that they can get to the information using this credible source. So, a couple of snippets from the market research flowing into this. The second, we have hundreds of research studies pointing out on how efficient this information discovery is on UpToDate. From a drug information, this was another place where we understood that people wanted information and coming together from a drug reference database to get a drug to drug, a drug to condition, and perhaps in those complex situations, what can we do? So we have this tool called Lexicom, which has about 7,000 drug monographs out there with different interactions, built, accessible on an app. Part of the information is already available in UpToDate. So that's how we have been able to tie those things together. Some of the snippets that we got about UpToDate: concise information, extensive, covers 25 different specialties, is easy to get to, available on an app, even offline. Sometimes you don't have coverage. Now, to tie this all together, what we have is called as the Ovid Discovery Service. So this is a place which can give you PubMed-like search results. It can link to UpToDate. It can link to the several tools available. It can link to those journal articles which provide the depth of information. And it gives you a search engine which is super fast. Allows a doctor, a clinician, a researcher, a student, anybody to get to the information extremely quickly. Now, the couple of exciting things that we spoke about. The first one, there is a lot of talk about AI. We actually have announced this on LinkedIn as well. We are coming up with generative AI, because we using the up-to-date, there are about 650 million views out there across the world. What can we do with that information? Can we create agents, or can we create that conceptual AI basis? So that's where we are going. We will catch up on that, and there is something cooking in our innovation labs over there. The second one, which is something that we are excited about, is creating a tool which can be used by from an engagement standpoint to engage clinicians. What we have realized is that a few challenges that are many people face is that there is no reliable, or sometimes can they create a one source of information, or can they create an engagement tool? So this is a mock-up. I got a time check right now. So this is a mock-up of our product. And anybody who wants to get in touch to know more can get in touch with our sales teams. Thank you.
So we request you to please be with us on stage. It would be an honor for us to felicitate you. Thank you so much for sharing your insights along with us, and sorry to interrupt you once again. To felicitate you, I would request Mr. Vivekanand Mishra, Vice President, IHW Council, to kindly join us on stage and present a token of memento. Welcome back, sir. I would request you to please felicitate Mr. Varun Belgudri, Associate Director Sales, Walters Kluwer, India. A very warm welcome to you. Thank you so much for sharing your insights. And ladies and gentlemen, would be very nice enough if we can thank him as well. Thank you. We move on to the next segment, which is a discussion on the topic of harnessing clinical trials and research for better health. I would like to invite the moderator for this particular session, Mr. Uttara Kumar, Consultant, Rapid Advocacy Program for Cancer. A very, very warm welcome to you, sir. Joining in for the session, the dignitaries are Dr. Vaibhav Sarvi, Director and Head, Clinical Study Unit, India and Southeast Asia, Sanofi. A very warm welcome to you, sir. Would also like to invite Mr. Dushyant Singh Baghel, Managing Director and CEO, Nucleome Informatics. A very warm welcome to you, sir. Would also like to invite Ms. Vasundhara Raghavan, Chief Executive Officer, Kidney Warrior Foundation. Very warm welcome, ma'am. We have our esteemed dignitaries who are on the dais. Ladies and gentlemen, can we please give them a warm welcome, ladies and gentlemen. As the moderator for this session is Mr. Uttara Kumar, we hand over the session to you, sir. Over to you. Thank you.
Thanks for that. Thanks. It's a pleasure for me to moderate this session on harnessing clinical trials and research for better health. So when I was thinking about this topic, I thought about, hey, what is the example about this? And then I realized that, hey, we are all sitting in this room. This is not a virtual meeting. We are not in masks. We are not in lockdown, right? So in December 2019, the coronavirus was first identified, right? And within a 1 year time, we had the clinical trial, the research identification of the specific target, and a vaccine was created. Most of us got vaccinated within a year's time post that, right? And then we're back to life as normal, right? Now, this is a clear example of how, with a right impetus, clinical research can actually improve health outcomes and change the world to a better place, right? Unfortunately, the thing is that right now there are a lot of diseases where people still do get sick, sometimes maybe die, which can be avoided. And clinical trials and research can play a very important role in ensuring a better healthy world and better patient lives, right? So with that, maybe I will turn to my co-participants, and maybe I would like to ask Dr. Vaibhav, what is the relevance and importance of clinical trials and research to patients, the health system, and the society at large?
Hello, and first of all, I would like to thank IHW for inviting me for the venue. Now, why do we require clinical trials in the country like India? So we have 17% of the world population, more or less. We have around 21% of the global disease burden. And we participate only around 1.5% of the trials globally. So there is a exponential gap. If we go into equitable distribution, we need 10 times more trial for our participants to be included in the clinical trials. We are actually not there yet. That is the first element. Second, I think Mr. Abhitab during his Fireside chat mentioned there are around 10,000 diseases, but we have medications for around 500. So what about the other 9,500? So to bring the medications there, we require clinical trials in the country. My uncle suffered from Parkinson's disease. There is no known disease as of now which can cure him. And for patients like him, clinical trial is the only hope that there will be something in future for the patients. And we discussed a lot about the rare disease and other elements. There is an acute need of having the clinical trials in the country. So I think that's basically what the gist about why we need the clinical trial in the country. And it's not only about the new medications. Even the disease areas where we already have medications, there is an opportunity to bring in better medication with lesser side effects, more affordability, more accessibility. For all those elements, we do require clinical trials. And to compare two groups of medications, which one is better, to make that decision, doctors also require the data. And from where will that data come apart from the clinical trials? So that's the need of having clinical trials in the country.
Great. Thanks a lot, Dr. Vaibhav. So, clinical trials over the past decades has transformed a lot, right? Now, earlier we used to look at your toxin for the virus, but now a lot of the unmet medical need is about autoimmune diseases, cancer, which is these are the genes, right? Things your body is developing on its own, right? So I believe there's been a lot of work that's happened around genomics, our understanding of it. Maybe to Mr. Dushyant, I saw that you've done very interesting work around genomics in India, right? So can you maybe talk a bit more about how newer technologies like genomics can improve clinical trials and research and bring in newer treatments for patients?
Hello everyone, my name is Dushyant Singh Baghel and I have a company called Nucleum Informatics and I'm a genomics researcher and then I'm an entrepreneur now. Journey of genomics is extremely challenging but extremely proliferative and successful in cancer genomics as well as in clinical trials as well. So what we try to do in genomics is basically we sequence the genomes and find out any alteration happening in the genetic structure, and of course in case of cancer we also would like to know the genetic function of those altered genes. So these type of information are very crucial if you are targeting any specific gene and your disease is linked with that gene. So having that information with any clinical trial company or pharmaceutical company is very, very important. As far as research is concerned, you have rightly said, Uttara, we have done tremendous job in terms of sequencing COVID genome. And this is a very small 30,000 bases genome. And every single base that we sequence, we have two types of technologies now, short read sequencing technology of 150 base pair long, then long read sequencing technology. So now we have technology which can sequence 30,000 bases in one go. So we have evolved from sequencing base by base to sequencing the entire genome in one go. So you can imagine how fast this whole technology is growing, and that's the reason we were able to sequence all different variants which were coming regularly in India, and we were able to find out the core gene set which can become the target for that target for the disease, and then for therapeutic application as well. So similar lines, if you have any new therapeutic drug or new drug to be developed, you can use genomics technology to find out which gene is altered or which gene is linked with this particular disease. Of course, for the there are multiple genes which are involved with drug absorption, like ADME genes. Those information can be also linked and can be analyzed. So I personally feel it's a very, very good research in terms of understanding and developing genomics knowledge and using it for clinical trials, especially linked to cancer genomics.
Thanks a lot, Mr. Shanta. Vasudha Madam, you have been leading one of the big patient organizations, been a pioneer in working with patients with kidney problems, right? So we heard about how clinical trials can be important, how the next level of technologies like genomics are helping, right? From a patient perspective, right, how critical is research and improvements in technologies and clinical trials?
So, my name is Vasundhara Raghavan. I represent India's largest patient advocacy group, Kidney Warriors Foundation, that works for kidney patients across the country. And we are part of the National Dialysis Program of the Government of India. As far as clinical trial goes, kidney patients need several types of researches to come through. One is in the prevention area, or rather in the progression, slowing down the progression of the disease. So there are a couple of medicines that are around the corner, and if it can give them a good span of life, that is the pre-dialysis stage, then many people will be happy to be there and not start dialysis. Then we also need something for people on dialysis where they can get erythropoietin, which is there. Now we have tablet form and also the cold chain injections. But if we can get that as a cost effective, you know, the expenses of this medication can be very unusually high. So that if that could happen, we'll be happy. Better machines. Maybe we can have a dialysis machine, which is a portable dialysis machine, which research is going on in overseas. But I think India being, you know, we have a lot of intellectual capital. People can bring about new research by the time the US comes out with their research. I think if we can develop something for dialysis, new machines, simpler ways, good medications for post-transplant with less side effects, and even maybe the organ, you know, if we can have that printable kidney or anything that can solve the problem, anything that can be cost effective and make a huge change for people in India. Because the disease is growing very fast and more people are coming into kidney disease.
Thanks a lot, ma'am. Very good points. A couple of them, I think, actually come up as further questions to our co-panelist, right? You talked about preventive treatments, right? And maybe Mr. Dushyant, I would like to get your views on how clinical trials or genomics and research can help in preventive wellness, even before someone becomes a patient. How can we prevent that?
Very good question, Uttara. You know, our genetic structure is already defined. So that genetic structure for expression needs an environment, and if you identify that genetic structure early, we can predict with certain environment what could be the result or what could be the phenotype of that gene. So taking this concept, there are many solutions now available. Something like Thermo Fisher has developed one panel called Axiom Asia Precision Medicine Research Array, So this panel has more than 5,40,000 SNP markers, and these SNP markers are associated with different type of metabolic disorders, rare cancers, diabetes, and many other diseases, probably more than 1,000 diseases you can screen from one single DNA chip. So you can imagine if somebody has history of any genetic disease in their family, they can do the testing and find out if they have any polygenic risk score for certain type of genetic diseases or not. Another is example, there are many wellness tests nowadays available. Many of the driver mutations, Vaibhav, as you know, in case of cancer, there are many driver mutations, many genes which are playing important role in tumor progression as well as disease progression. Those small panels are also available. These are very, 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 very economical in terms of, their pricing. They are not very costly. In 8 to 10,000 rupees, you can get yourself tested if you have any biological relative who is having these type of disease, or you have a history of certain type of diseases. So it's always helpful to have your genetic profile done so that you know what are you trying to deal with. And of course, everybody has a disease to deal with today or tomorrow. So if you know today, it's always better to take care, take the right diet, take care of your lifestyle, and then take a right decision to reach to the right doctor on time. That's the whole idea of prevention, that you do not have to wait for the clinical trials to take care of your health.
Sure. Great. Thanks, Dushyant. I think as for IHW, it's one of the things we talk about prevention and good air, good water, good food, good health, right? So one of the other things that Vanda Madam talked about was, she spoke about cost effectiveness, and that in India we have a good amount of intellectual ability, right? Unfortunately, we don't see that too many clinical trials in India, right? So, Dr. Vaibhav, maybe what should be done to get more clinical trials and faster research in India?
Yeah, so I think we have the patient pool. We need to develop certain infrastructures. Like I will give an example. So there are, I think Amitabh also mentioned about the gene therapy and cell therapy trials, but there are not too many centers which are JC accredited for that type of therapy. So if we are entering into new therapeutic areas, we require centers which are equipped with the proper instruments or techniques which are required for those trials. So that infrastructure creation is something that we need to look into. Second point is about the advocacy with the government agencies, and Indian Society of Clinical Research is doing very good job in that respect with making the regulations friendly so that their patient safety and well-being is taken care of, but at the same time it becomes easier for researchers, and not only the pharmaceutical researchers, it's also the investigators to initiate their trials as well. We make it easier, and I think the government has taken a very good step with that respect in the recent NDCT, New Drug and the Clinical Trials Act, is well balanced with that respect. Certain elements need a bit implementation, so that's where there is a lag, and that requires a continuous advocacy with the government agencies. The third element is about patient education. We need a dialogue, and I think both Vandana ji and Bhavna ji in the patient panel were also discussing about that we need to have more partnership with them. There is a CTRI registry, which is Clinical Trial Registry of India, available, but I'm not sure how many patients know this, and they go on the website and check whether they are eligible for any of the trials which are available there. So I think those kind of measures we need so that we can have better participation in the clinical trials, and we have proportionate number of trials in India so that our patients also benefit from the newer therapies.
Thanks a lot, Dr. Vaibhav. So one of the things that's been a challenge in India is about the notion of clinical trials, right? So earlier there used to be a lot of clinical trials in India. Then there's unfortunately some not good happenings, and then the pendulum swung the other way. Clinical trials went down. So that is a kind of hesitance, right? So maybe I would like to hear from Vasudha Madam of what is the kind of messaging that can be given, should be given to patients. What should they be aware of so that more patients are willing to enroll in clinical trials and so that more new products are coming to the market faster?
Firstly, patients do not know much about the clinical trials that are happening. There is a lot of hesitancy, at least for kidney patients, because when the thing is about biopsy, or even if a drug is being administered, they are very scared that if they have not started dialysis, maybe the biopsy will create a rise in the creatinine, and they may have to start the dialysis. The same thing with any drug that is being given as a clinical trial, whether this will have a very harmful effect on them. And they are not willing to participate. They don't have that little guts, that, come on, let's try it out. That experimentation is not there. There are too many people trying to tell them, no, I don't think you should do it. So there is no direct communication between the company doing this trial with this person who's going to be under the trial, to make him feel good, make him feel that this trial will help you, and it's ethical, we've got everything signed up, and there could be a chance that you will start dialysis, but we can't be sure. The whole information needs to be conveyed. 2 years back, I was approached by a US foundation. They were doing slow progressive medication for IgA nephropathy, and they sought my help to get the patients listed in the sites. So I had to contact the nephrologist, and we had a talk on why clinical trial is important and why people should participate, because these things will give rise to newer medications and probably it will help them in the long run. So we, as a patient body, we are actually pushing the patients towards the trial, but we need to have the support from the other stakeholders to make them feel confident that yes, we need to go in for this trial. So that's a very huge responsibility for the pharma companies.
Sure, ma'am. Maybe following upon that, so what is that a patient expects from a clinical trial? What is the expectation of a patient from a clinical trial or research?
Some relief. Firstly, if you get a medicine which will slow the progression, and they can be there on without dialysis for long, that will be good. That will make them feel really good. There are many rare diseases in kidney disease also, where they have polycystic kidneys, Alport syndrome. So if all these have that, just like the IgA nephropathy, they have tried to make this medicine which will slow the progression. So if they have these type of medications for all, and also if there can be some way genetically, if they can be found out whether this can be not transferred to the next generation. Because you see, that is the big concern that people have. That I've had this kidney disease, I hope it doesn't, firstly, it doesn't reoccur after my transplant. Secondly, my next generation, so reproductive thing doesn't stop. So these are the two aspects that are very critical for them.
Sure. Thanks a lot, madam. Maybe Dr. Vaibhav, since you conduct a lot of clinical trials in India, right? So we heard from Vasula madam about what's the patient expectations, how to do the messaging. So how is patient centricity managed in clinical trials?
Okay, so there are a lot of good initiatives which are happening in terms of patient centricity. I think Roche has recently launched their program on patient centricity in India. We have our own program which is called SPICE, which is Sanofi's patient-centric initiative for clinical engagements, which extends far beyond the clinical trials. But what exactly are we talking about in patient centricity? So we need to hear from the patients. That's what I think Vandana ji was talking about, that the patient association should get a seat at the table. So what as an industry we are doing about it? So I can talk about my company. So 80% of our protocols, clinical trial protocols, before we implement it in any country, get reviewed at a patient panel where we walk them through, of course, not all the data, there could be a company confidential data as well, but the elements which are relevant to the patients, we walk through to that and we identify what will be the pain points that the patient will be suffering from. To give a concrete example, for example, if you are doing a trial in hemophilia for an agent which needs to be administered in a baby, and we need to extract blood samples at regular interval. How much blood sample should we extract from a child that the parent will be comfortable with? That's an important question. We need that information from the child will not be able to communicate, but we need that apprehension from the parents. How can we assuage that? How can we make it understand why it is required and what are the elements behind that? So that's something we need to listen to the patients. The other important elements is that there are certain protocol related elements which are required for getting a regulatory approval. But patients are not concerned with the elements which are important for the regulators. So again, to give an example, if a study is for multiple sclerosis, the element that regulators are looking into is brain lesions. But patient is not concerned with brain lesions. He's concerned with his daily working. Can he walk? Is his main concern. So we need to have the patient reported outcomes or the patient endpoints in the trials as well, apart from the endpoints which the regulators are required for the drug registration. So that is also an important element. So we make sure that in the protocol, we have this patient reported outcomes as well as patient related endpoints also captured so that we make it patient centric. The other elements is about experience. How does the patient experience trial while they are into it? Do they get a priority appointment with the doctor? Do they get their transportation accounted for? Do the patient which is coming in the morning who might be a farmer, may not have a breakfast, attend the thing? For a trial, they may have to go on fasting for 18 hours. Are we making sure that their comfort is taken care of? They have the food available at the end of the procedures. So all these elements you will know when you actually walk the patient journey and know what all the patient is experiences at all the touch points in the clinical trials, and you make sure that those touch points are taken care of or at least assuaged and the patient is informed about it. The other element is about having a patient-informed development. So it's not only in terms of the clinical trials, but also after that, how will you make it accessible and what are the patient-related elements that you are taking into consideration when launching that molecule, when making it available as an access. The other element is there might be certain therapeutic agents which can be given to the patient at home. The patient need not visit the clinical trial site every time just because their supply has run out. We can have the direct to patient transfer of medication. We can, especially for rare diseases, it becomes very challenging because the patient might be located 500 kilometers from the trial site. They may not travel just to get an infusion. Can we have partnership with agencies? We now have good systems in terms of the nurses as well as laboratories who can actually go to the patient's home and provide the solution. And this is not applicable only for clinical trials, even for routine access as well. In our rare disease portfolios, we have partnership with laboratories who have tie-up with the Center of Excellence which Government of India has appointed. They provide access to the patient by going to the patient's home and providing the infusion. So we need to take care of all these patient-related elements to really say that we are a patient-centric organization.
Thanks, Dr. Vaibhav. So we talked about hemophilia. So I've done a good amount of, I got a passion or I'm keen on hemoglobinopathies. That's an area that's of interest to me, right? And Madam also talked about hereditary disorders, right? So this is an example of hereditary disorder, which in 2-3 generations we can in a way prevent new births on that, right? That comes to the question I wanted to ask Mr. Dushyant, right? Because gene sequencing and genomics is the holy grail of being able to provide precision medicine, right? India's been, it's picking up a lot in India right now, but still we are a long way to go in that, right? So what is the kind of ecosystem level improvements needed to improve genomics research in the country?
Very valid point, Uttara. I'll take you to 2008. I came from my work in Switzerland and they had the entire genomics laboratory full of genome sequencing instruments, bioinformatics support system. So when I came back to India, I realized I should start something like that in India. And we got some funding after many rounds of discussion with multiple companies, and we started a small laboratory. The challenge what we faced was the moment we buy the technology and then we go to the market, the new technology comes up and then the entire sequencing technology has to be changed. So this challenge, especially in terms of creating a genomics infrastructure, is very challenging, because even though government funds it, there is a new technology will come over and the old sequencer has to be wiped out. So this is the first challenge that industry has to take care. Second challenge in genomics infrastructure is understanding of Indian human genome sequence. We don't have any large efforts except Indigen project, which is a very, very small project if you consider the large scale programs happening across the globe. We don't have genetic profile of our own citizens. You know, we have 4,500 distinct population currently available in the country. These 4,500 distinct population have different type of genotypes. Their expression pattern is different. We were talking about the patient safety, especially when you select the patient in clinical trials, your ADME gene or there are some group of genes which are responsible for acting with the drugs. So their adversity will be different from one genotype to other. So if we don't have the entire genetic makeup of these subgroups, at least some representatives of those subgroups, we don't know what sort of genotype we are dealing with. So one information that we have to generate is a large scale genomics program that can give us the entire genome sequence of these 4,500 subpopulation. The next thing would be introducing, I think so, genomics should be introduced in clinical trials. Every single drug which is going inside the body will work according to genome. This is already known, proven and tested. So any patient that has been selected for trial number 1, 2, 3, or even after approval for randomized testing, just to see how the drug is working in the market, you keep doing some trials after the approval as well. So after that also, if you come up with some models where genomics can be integrated to find out which patient is actually or which patient's genotype is suitable for this drug type, that makes sense. So precision medicine, not the personalized medicine. Many of the people get confused that we want pharma companies to create a new drug or new dose for every single population subtype. That's not possible. What we are trying to tell you or convince pharma companies or the policy makers, use genomics tool and find out the genotype which is specifically designed, and use that genotype as the proof to find out which drug will work based on this genotype. So that's the precision medicine concept, where medicine is improved based on the genotype, medicine is given based on the genotype. So what it does is allows patients to be tested well before they are tested. They are not guinea pigs, right? They are already suffering from some of the disease. They are already going through so much in terms of their finances, in terms of their economical and social and mental behavior. When this type of situation is happening, already all the expressions in the genes are changing. You know, environment is 70% in terms of, the genetic expression. So when you have such social pressure happening in that genome, the drug will or will not work. I don't know. But if some sort of a check is there for selection of those patients, you know that this genotype is safer for this particular drug. That is what we are trying to communicate, and that's what policy makers should understand. So I would come back to the fourth point, which is linked with the research. And why this is not being used, because we have, this is a very, very budding technology. Genomics is growing technology. We have so much of research happening. We come across with many things in one way. I am not going to blame the researchers, but it's very difficult for any genomic researchers to say this particular inhibitor or this particular gene or this particular mutation is only responsible for this particular disease. So selection based on these type of genetic biomarkers or molecular markers needs some sort of intervention from the experts. So some sort of a complex but comprehensive assessment should be done before we take any patient selection program. So I would recommend, there are some biomarkers which are important biomarkers, especially if you talk about cancer genomics. We have many biomarkers nowadays, the driver mutations we call them. If you see those driver mutations, many of the times we have found, especially in case of few of the NSCLC programs that we are working with, we only screen SNPs. So you might be knowing that only we look at the single nucleotide polymorphism. For those who are from different background, I can inform you that this is a single nucleotide or single base change in the genome. So if we only look at SNP markers, then there are only 1 million variants in human genome. If you compare two genomes, let's say mine and Uttara, you can find out 1 million places where these genomes will be different. There are 1 million places like that. But this is single base change. But if you talk about insertion, deletion, translocation, transversion, or chromosomal rearrangement, there are so many bigger changes happening in the genome. Especially in case of cancer, so 50 base pair changes, 1 base pair changes, and then or even some sort of a chemical treatment or exposure to some of the extreme environment can also cause some epigenetic changes. So we have to look at epigenetic change. You have to look at the single nucleotide polymorphism, you have to look at the structural variations, and all these information along with some metabolic compounds also. These studies has to be done comprehensively to assess the health of the patient and then select the patient for clinical trial. So if there is any policy maker here, we would request please include genomic studies for every clinical trial. At least give us some 400, 500 cohorts to study whether this drug is suitable for this particular patient type or not.
Great. Thanks a lot, Mr. Dushan. I think we're almost on time. So one of the things you talked about was about lung cancer, right? So one of the things, so in lung cancer, at least I think there are 10 mutations, driver mutations identified, and where there are medicines targeting that. But say head and neck cancer, in India head and neck cancer is the most common cancer because of oral tobacco use. We don't have that level of research happening. So my wish and hope is that we move into a future where we have more research for diseases particular to India, right, or even neglected tropical disease like a malaria, dengue. We have better environment to conduct clinical trials, genomic research, more empowered and knowledgeable patients, and the right set of approach from the organizations which conduct clinical trials with patient centricity in mind. So with that, I like to thank all three of you for taking part in this panel discussion. It's been a pleasure interacting and gaining your insights from you. Thank you.
Thank you.
Thank you so much for sharing your insights along with us. We request you to please step ahead for a group photo op, and then post that we shall be presenting the mementos. Ladies and gentlemen, can we please thank them for sharing their insights along with us? To present the mementos, I would request Mr. Uttara Kumar to kindly present the mementos to Dr. Vaibhav Sarvi, Mr. Dushan Singh Bagel, and Ms. Vasundhara Raghavan. Well, I believe we should just not stop clapping to thank the dignitaries present on the dais. Thank you so much for sharing your insights. On time, yes, absolutely. Thank you so much for finishing it off on time. Next, we have a spotlight session delivered by Mr. Raghavendra Godwagu, CEO, AMP Group. A very warm welcome to you, sir. We request you to please join us on the dais and share your insights along with us. A very warm welcome to you, sir.
This one, right? Start working. So good evening. Friday, 6:15 and a spotlight session. And you can imagine how tough it is for me as well as for you all to listen. So what I'll do is I'll quickly take you through the few slides. I'll not take the 10 minutes that has been allotted to me on a story that has been started by a professor and a student where they actually wanted to develop a multiplex platform, a diagnostic platform that can be rapid, accurate, and as economical as possible. So Dr. Pavan Aslapuram is the founder of this company along with his professor Mats Nilsson in Sweden. They are from Karolinska Institute, and that's where we have our R&D. And we have our manufacturing center in Genome Valley, which is in Hyderabad. So I've taken over as a global CEO last year. Before this, I was leading GE Healthcare Life Sciences for India and South Asia. So just to give you the perspective of the incidence on the TB, as we all know, TB is one of the deadliest diseases. Imagine if COVID was not there, this is supposed to be one of the deadliest and most infectious disease, what we have all have seen it. And many of us are not aware that this is almost like 11,000 years old disease, and still we are struggling to find a cure. And then of course, there is cure, but unfortunately that has left with multi-drug resistance. Now if you look at the data points about the disease, on an average you see 4,000 deaths every day across the world, and almost 1.8 million new cases every year across the world. And the kind of money that is spent is almost $10 billion in terms of trying to work on this. And now the biggest challenge here is not the TB, while TB is 1 in 3, but one of the most dangerous thing that across the world that's going through is the multi-drug resistance pattern. What it means is, the patient has already developed the resistance, and then, doctor is still trying to give him the same disease, and obviously it's not going to work. And how is the situation in India? India is no different, and we all know India is actually the hub. Stands number 1 in terms of the TB incidences. As per the National TB Elimination Program, there are almost like 172 incidents or 172 patients per lakh population. And you can imagine on a 1.4 billion population, you can imagine the kind of incidents that India is going through. And what's the reason for this? Multiple reasons, but one of the reasons is that, not availability of proper diagnosis at the remotest places, and that's where you find this disease as as remote and very unhygienic conditions is where you find this disease, and that's how it gets spread all across. So that's one of the reasons why it's not getting under control and it's just spreading as rapidly as possible. Now what we are trying to do at MP, we have developed these kits. So basically what we do is we've developed kit, a platform basically, which is, we've started with the TB, but this can be expanded to the other diseases as well. A very economical one. The other biggest advantage is that you don't need any huge setups, unlike the current existing platforms that are available. So you can actually use the infrastructure that has been installed for COVID, a simple PCR machine, and then you do testing, and then you can actually move forward with the diagnosis. Now if you, yeah. Sorry. So this is a very unique platform, unlike the RT-PCR or any other platforms that are available. So what we call as a padlock probe technology, rolling circle amplification model. This has been invented by Mats Nilsson, who is the founder of this technology. And then the innovation comes in here, where you actually see, if you have to use this technology, you're supposed to have a very high-end platforms, especially the scanners, where because you use the fluorescence dyes. And that's where the innovation came in. Instead of using a laser, fluorescence dyes and a laser platform, the technology has been developed in such a way that you can actually have a very visual kind of an inspection. So the beauty of this kit is we are actually bringing in the precision of a PCR, which we all know how precision the genetics and then the oligos would bring in. And if you are able to bring in the precision of a PCR and a rapid format of reading, and that's where the whole accessibility or point of care kind of platform is available now. And what we do, I mean, the whole process is very simple. And we all know at this point in time it is the sputum samples because of the availability of because this is more of a lung kind of a disease, and then the sample source is more of sputum. You pick up the sputum, you do a hit lysis, then you amplify the DNA, a simple PCR, because you have to enrich the DNA, and there are about 4 or 5 steps to be very precise, which are again, like I've said, patented processes. You use the padlock probe technology. And then this is where the whole innovation comes in. As you can see, there's a cassette there, which is as simple as like a pregnancy kit or things like that. You put up the outcome of the amplification, you are going to put the drop on that, and then you can see there are about 7 or 8 sets of genes that have been tagged onto this platform. So you see a positive, negative for TB on this. If you get a signal, this means that it is positive for the TB. Not just the TB, but you also get the pattern for the multi-drug resistance, which is rifampicin and isoniazid at this point in time. So we have actually coded the genes of rifampicin and the isoniazid on the platform. And then when you amplify the sample and then you subject that onto this cassette, you're going to get the results in a very readable format. It is like as simple as looking at the marker and then say, yes, this person is positive to TB. Let's start the treatment. And then within the treatment, you'll know if this patient is a resistance to rifampicin or isoniazid. If it is resistance to rifampicin, obviously the choice is not rifampicin, but you have to move to the other drugs. Similarly, isoniazid, same thing applies here. At this point in time, we have developed the kit for 2 antibiotics, which is rifampicin and isoniazid. As we move on, we have developed some more platforms. Now the USP is very simple, like I've said, very cost effective. No huge setup is required. You don't require any sophisticated equipments or a huge infrastructure. A simple normal PCR machine and then simple laboratory reagents are more than enough to actually detect the TB. And then of course results are very accurate because we are using the molecular probes, and then scalability is something that we are looking at. And we have been already recognized by the WHO. You can actually see the kit on the WHO website as well. We have done this is a usual process that you do. You go through the trial. So our clinical partners or the research partners are ICMR certified labs, CMC Vellore, and then NIRT. And we are also doing trials with multiple places on various platforms. So here, as you can see, the sensitivity and specificity is much, much higher than what you see in the routine, what's currently available, as high as 97% in terms of the pooled samples, and the sensitivity on the drug resistance is almost like 100%. And we've already got the certification from these organizations to go ahead and apply for the CDSO licenses. And then we've got the CDSO license, and then we are up for commercials. Since the technology is a very unique technology, this has been patented in 21 countries. We've already got patents in 21 countries. We are working with 14 different countries, 34 different labs across the world on enabling this platform. Our mission is, can we eradicate TB globally? Obviously, we do not want to be left out in terms of AI and ML, so we are also developing a platform where you can actually, though it is a simple yes and no types, but we are also developing an AI-based scanner, and also data can actually get pushed into any of the databases that the government is looking at. This is the second kit that I was talking, not just to rifampicin and isoniazid at this point in time, but we've also got in the fluoroquinols, and then obviously the fourth line of drug is what we will be developing. So obviously we'll have a simple positive negative for TB as one kit, then TB, and then your rifampicin and isoniazid, and the third one would be with the fluoroquines. And that's the pipeline of products that we are going to develop. And this would be one of the first of its kind across, where you'll be able to see the multi-drug resistance of 3 drugs on one single sample, on one single kit. As you can see, we've been, like I've said, we've been granted patents in 21 different countries. We are recognized by the Gates Foundation. We are funded by the Gates Foundation, European Innovation Council as well. And we have been identified as one of the only companies in the world who've got both European as well as the Gates Foundation grants to develop the kits. And here is, you have the trademarks and all that has been applied. This is our lab, our manufacturing center in Hyderabad, where we currently have a capacity of 24 million tests. And then we are actually planning to scale it up to 100 million kits going forward. That's it. Thank you. I said I'll not take too much of time, and then, yeah, thank you so much. Thanks for the time.
Thank you. Thank you so much, sir, for sharing your insights along with us. Moving on to the last session for the day today. In the first Patient First Summit, we have had an in-depth discussion on various topics which would support building stronger health systems in India with patient care and values at its core. Introducing the last panel discussion, for which the topic is Closing the Care Gap, Strategies for Achieving Healthcare Equity in India. I would like to invite on stage the moderator for this session. This session is moderated once again by Mr. Prabhat Sinha, Director, Public and Government Affairs, Boehringer Ingelheim, India. A very warm welcome to you, sir. The panel members who are joining in for this discussion are Mr. Jitendra Kumar, Innovative Access Lead, Takeda. A very warm welcome to you, sir. Would also like to invite Dr. Jayakumar Reddy, Executive Vice President, Mercer Marsh Benefits Marsh. A very warm welcome to you, sir. Ladies and gentlemen, would be great if we all welcome our dignitaries with a huge round of applause. Would also like to invite Ms. Uma Kalekar, Director, Mayor Organics, and Dr. Sanjay Pandey, Head of the Department of Andrology and Reconstructive Urology, Kokilaben Hospital, Mumbai. A very warm welcome to you.
So good. So I'm standing, in fact, we four are standing between this session and the award ceremony that you are going to have. But believe me, for many of the organizations who are going to get award is basically those who will be who had come up with some innovative model to address this care gap, what we are going to talk about. So in this session, we are trying to make it shorter so that we will be able to make up some time, but let's see how we go about it. So before I start, what I'll do, so for us, when we talked about this session, the core of, you have heard a lot of discussion happening from clinical trial to, what patients want. Now we have come towards the end, and what we are going to talk about, considering all these challenges that we have, what is that care gap that exists, right? And if there is a care gap, how we are going to, or different organizations, and we have again a diversity sitting here, how these companies, organizations or institutions are trying to close this care gap. And again, that is something, some of the learning that you might get from it, and we will initiate that conversation. So before that, if I just invite each one of you to introduce yourself and also your organization very briefly. So may I start, Jitendra ji, from you?
Okay. Thank you. Thank you, Prabhat ji. So before I formally introduce myself, I would like to extend my gratitude to IHW Council for inviting me here and making me a part of this panel. And being the last of the session of today, so I also want to congratulate all the speakers and the panelists today who have given their thoughts on bringing a patient-first mindset. So hello everyone, very good evening, and I'm Jitendra Kumar, Innovative Access Lead from Takeda. I have more than 20 years of experience in pharma industry in different segments.
Hi, good evening to everyone. And first of all, thanks to IHW inviting us for this panel discussion. So myself, I am Dr. Jayakumar Reddy. I am a part of Mercer Marsh Benefits. We are a broking company which provides insurance solutions to all the corporates.
and I've been into this industry for last 17 years. And one of the good topic which has been introduced as a gap. So I think we are the right person to fill the gap.
Hello everyone, I'm Uma Karekar. First of all, let me thank IHW for the great work that they are doing. I think the concept with which they have done today's program, it will help industry, it will help doctors at the same time, it will help the patients. I'm Uma and I am Director for Mayor of Diagnostics. We are a group company of Diagnostics UK, which is UK's #1 nutraceutical company. And we are dealing with all the nutraceutical, and we are innovative in nutraceutical care for all the segment, be it children or women and men. So I'm very happy to be part of this panel. Thank you.
Good evening, everybody. I'm Dr. Sanjay Pandey, Head of Department of Urology at the Kokilaben Dhirubhai Ambani Hospital. While taking healthcare to a different seat altogether in the operating room every day, it's nice to be under this roof right now with luminaries who actually partner, though they differ, they come together, and that's how we probably take this subject forward. So filling the gap, I'm very glad to be on this panel today. Thank you so much for inviting.
Thank you. So as you know, as you see, actually we have 4 panelists. While Dr. Sanjay represents service delivery, a hospital, we have Mr. Jitendra, who is representing Takeda, a pharmaceutical company, innovative company. Then Mr. Jay Kumar is representing kind of an insurance broking organization, and Ms. Uma from a nutraceutical. So it's a variety of expertise that we have, and that's why we will start that once we understand from the care gap, and I think the gap, when each one of you will see this gap, you will see from a different lens. At hospital, Dr. Sanjay will see the gap, and maybe what from an insurance perspective will see maybe a different. So I think insurance has come up a lot in today's discussion when we talked about access. So I will start from you. When we see this care gap, knowing that still almost 70% of us, we pay out of pocket to get access to care. For Ayushman Bharat definitely has given access to 50% of our population. But still the missing middle, what Kamalji talked about, they still, many of them don't have insurance, or if they have an insurance which is not adequate or comprehensive. So how do you see from an insurance broking perspective that where the gap exists as of now?
Thanks, Prabhat. The insurance, it's a big subject to discuss. If I want to discuss this particular insurance affordability, I can speak for the whole day. The gap, what we have seen is that the adequate and affordability. So whether an insurance is adequate for me, still now what we have seen is that we have gone to the corporate or a retail or an individual, does not see that whether my particular coverage is adequate or not. Because due to the inflation, the cost of the medical care has been gone to a different level. And the very important is that most of our are there in this corporate world, and we have seen that the corporate, when it covers for me, for my family, but I don't take my own policy. They feel that, yes, I am covered for my own, so I don't need to worry. But when they exit to a particular organization, then they feel that I need to cover. So the right time is that when you should get covered. Because most of them, they feel is that when I'm ill, then I should be covered. But the insurance does not cover if you are having any disease or something that, then they feel that why I do not cover. So the biggest gap is that the right time to take insurance and the right coverage that helps to fill this particular gap.
So as a follow-up question on that, even let's say I have an adequate insurance, but does my insurance cover all the things or all the ailment that comes, right? There are a lot of fine prints when it comes to insurance. Let's say in cancer care, whether targeted therapies are covered, I need to be hospitalized and all. So from the patient's perspective or from caregiver perspective, those are also very important questions. So how do you see that changing? Has that changed?
Yes, definitely there's a lot of change been happening because IRDA, which has been there, so they are studying a lot of studies. So recently we have seen is that mental health, which was not covered earlier, so they started covering these therapies. yes, in terms of retail, there is a little gap where the complete coverage is not there. But in terms of corporate client, yes, most of the diseases are getting covered now. And the coverage is provided, but yes, definitely there is an additional premium which has to be paid for that. But the coverage is enough to cover all those particular diseases now. But the very important is that what I see is that the prevention, because I was just making a note of all the sessions, most of them were speaking about the prevention part, and which is lacking behind. Because most of the coverage what we see is the IPD. IPD is most of the corporates or most of the individual takes a corporate policies which covers an IPD. But still we have not seen that the OPD policy has been not covered. OPD is a policy which has been covered into the insurance program that helps into the prevention part. So that will help a particular, because now what happens is that usually corporate what they see is that my ICR has been, that is the claim ratio which has been increased over and behind. Then after that my premium gets increased, then CO4 comes into the picture, then they cuts the cost. But to cut the cost, we need to see that what is the ROI for that. Once you take an OPD policy on that, so that OPD policy, when a particular employee feels that my OPD is covered, then definitely he will go for a prevention, because an OPD covers a consultation, a vaccination program, and even an annual checkup program. These three, when it is covered, definitely he is going for a first health checkup without any hesitation that yes, I'm suffering from this particular disease, I can go and take this particular first consultation. As a prevention method, I can go for a vaccination, I can go for an annual health checkup. Because we have seen that most of the claims which has been coming to the chronic diseases like diabetes, hypertension, cardiac, these are the many diseases which has come. But if this could be prevented at the early stage by taking an OPD policy, definitely I think the larger impact on the IPD policies will not have a more impact. So first is that the prevention is the very, very important role where I see that could fill this particular gap.
Very nice point. So now if I move from insurance, once you have an insurance, then definitely next time when you need something, you go to a hospital. So Dr. Sanjay, if I ask you now, in your vast experience, now when you are at one of the most sophisticated hospital in Mumbai, how you see now access to this care is transforming, and whether it's insurance or awareness, how that trend is changing in your perspective?
Good question. Thank you so much. And it becomes more relevant when we heard the insurance sector come up. So let me just give you a little perspective and a short note and then take it forward. Today's healthcare by an individual who's seeking healthcare has changed dramatically, multifold. Have a look at this. We had this motto called, you do your best and God will do the rest. That was a motto we followed maybe in the era pre-pandemic or in the era where we thought that when it's trouble, knock the doors of a doctor or a hospital or healthcare and things will happen. And then came this sad or a pandemic in disguise, which brought everybody to understand that let's bring health to the front row seat. And that's where we wonderfully heard the prevention angle today. Because had it been prevented, we would not have seen this light of the day. So now, bringing health to the front row seat is probably an individual's responsibility. And I think everybody looks into it. So when you look into the healthcare situation in India right now, on one side, the government sector institutes, then the private group practices, nursing homes, and the corporate sector of one of them, I become a part of. I still speak as a doctor to a patient. I look at it that an individual wants the best. So when I heard our colleagues speak on insurance, there are two sectors which are really not covered right now in insurances. One is congenital diseases. It was no fault of his that he was born with a congenital disease as his hypospadias or an absent vagina and an MRKH syndrome. It's no fault of an individual. She or he looks good on the day to the mother and father, but there are congenital issues which keep them completely away. They will need one surgery, multiple surgeries, corrections all their life, and insurance in India does not cover it at all. I know it. And individuals since that era till today take it forward, and therefore the healthcare gap which was there all the time has continued to stay on that. Similarly, in technology, that I do robotics for the last 12 years in various genitourinary cancers and reconstruction, I gather that healthcare insurance did not cover it in the initial days. It still covers it only partly. But look at the Indian consumer or the customer or the healthcare needy, the patient. He walks in and says, I'm ready to pay for it. Yeah. So today things have changed. They want to pay for everything and want the best. People fly in from different states, different two-tier cities to the healthcare where they probably get an answer which probably could be better. So the gap is gradually getting filled up. I know the gap will get bigger because we still are the most populous country in the world. On one side are the government hospitals where on Saturday the OPDs close at 12 o'clock, the operation theaters close at 11 o'clock. So where on earth can surgeon fulfill his desires of completing that many surgeries as I did till 12 o'clock at night yesterday? It is not possible. So the healthcare needs are growing. I understand that as a doctor, as a hospital, I think we have plunged into ways, all hospitals plunge into ways to look into how can we make healthcare accessible. And that's where you will find the outpatient department costs have been brought down, many hospitals. Not that they want to get more patients in, but want people to access and get to know, to reach that level, and thereafter it's fine. So I think once you know that you have a cancer, you will jump in and get it treated. Once you have a quality of life disease like incontinence of urine or erectile dysfunction, you love to postpone in the same era as you did in the pre-pandemic era. So the dividing healthcare into two aspects. One is the accidents, traumas, cancers where you need at that very hour and you panic the button because need of other. On the other side, a quality of life diseases, all of them. I would just rate incontinence of urine is one, where the healthcare need and the gap cannot be bridged because individuals know they can wear diapers, they can postpone it till it becomes something as troublesome as on the stage. I'm wearing a white pant. If I leak today, it'll be embarrassing for me and therefore I will take a jump and probably get myself treated tomorrow. If somebody of your and my age has a bedwetting tonight, you will see the first urologist in the world. But a child bedwets between 6 to 15 years every day and the mother takes the child for cough and cold and loose motion but forgets that bedwetting is also an important issue to take it forward. So quality of life issues will continue and that will be in domain of the individuals who need to get treated. On the other side, hospitals have moved forward and I think the care is getting better and better with the gap.
Very rightly said. And I think what remains with me, one of the things you said, the people want the best. And even the quality of life indicators are changing. And I think people are appreciating that, what even quality of care, what are those determinants. So very rightly said. Now, once we go to hospital, the other thing comes is the medicine, right? So that brings me to Jitendraji, to you, is as healthcare is transforming, a lot of innovative treatments are coming. Since morning we have been hearing that there is a latest innovative treatment available, but does this treatment available to everyone who need this, right? And it's always going to be a North Star. It's not easy that everybody gets everything in one go. There has been a lot of things happening from government, from industry. So if you could share, for example, what Takeda has been doing in this space to make access possible with some of the innovative approaches.
So thank you, Prabhat, for this wonderful question. Before I come to the solution or what Takeda is doing here, let me get into the problem statement first, the gap which we are talking about. As you have rightly shared, that the perspective of gap is very different to every individual and every segment. From a Takeda perspective or from the industry perspective, we have been talking about access to the treatment is one of the gap. So let me start with some of the data points, and I think one of the data point which we have shared in the earlier session was 62% of the population still have to pay from their own pocket when it comes for accessing any kind of the treatment. And believe me, the latest data also suggests that this scenario is not going to change even in a decade. So the latest data suggests that approximately 45% of the population in next 10 years still will have to pay from their own pocket. Means majority of the population will have to pay from their own pocket. So let me come to the population now. When we talk about the population, it is very common that most of the people, even today in many of the sessions, we talked about 1.4 billion population. But some interesting data point. Top 3% of the population which we consider as an elite population, although it is only 3% of the population, but if you look at the number of the population in this segment is equivalent to the total population of many of European countries, even many of the European countries combined together. When we look at the bottom, poor population, it is approximately 35% of the population. The size of this population is approximately the size of the US population or Brazil population. And the same case is to the other segment of the population. So when we talk or think about India, it is not 1.4 billion population in terms of the number. But when we talk about the diversity, we should be considering this diverse not only in terms of this country, in terms of the language, in terms of food, and even in the earlier session in terms of gene. But there is a huge diversity in terms of the economic scale. So whenever we are thinking of a solution, let's think India as a different segments. And at Takeda, what we are doing, we are not doing a single solution for everyone in the country. We are making the solution tailor made. So we are customizing our solutions as per the segment of the country. So we have a different solution for somebody who is at the top, and somebody at the bottom of the pyramid in the economic scale, he will have a different solutions. So we have support programs in Takeda, which is helping the patient from a different paying capacity with a different support solutions. So one thing which we are doing right now is a customized solution for each population segment in the country.
Okay. So there is assistance based on my income level. I can get access to certain therapies, right?
Yes. Yes, absolutely right.
Okay.
So we have the commercial availability of the drug, as well as we know that your paying capacity is entirely different than the mine, and somebody has a different paying capacity. And when we talk about providing the treatment, so it is very difficult for an individual who is in a remote area, who is not able to even earn more than ₹1 lakh in a year. How he can afford that? So even the patient body was talking about let the drug should be available to everyone. And for that, you need to think very differently. You need to be very innovative in providing solutions. And that is what at Takeda we try to build in that.
Okay. So when I was talking to Ms. Uma before this session, when the cost, many times when we feel that there is an issue with access, equity is not there because cost of treatment or cost of care is very high. But now you will hear from Ms. Uma that even when a cost of care is maybe as low as 200 or 500 rupees for a lot of issues with women health, majority of the time these services are free or at a very, very nominal rate. But still, if we see the access index or number of women accessing those services may not differ from a very tertiary care thing to that. So is it always the cost which is important, or is there something else?
Yeah, thank you, Prabhat. I feel that cost today, we know that how much we are spending on mobiles and internet. Even you will see a car cleaner and he's sitting there with the Instagram. So I feel that more than cost, it is the awareness that is very important, that we are ourselves responsible for our health. And especially I feel that women, that they need to do this. I'll just give you the example that we do BMD camp, that is bone density, across India. Every month we are doing around 500 camps minimum. And we find that so many women there and who are having not taking the dietary calcium right, whether it is a milk, yogurt or the cheese. So that dietary intake is not there. And as a result, and they are not taking calcium, and as a result we are finding that so many of them in the osteopenia, osteoporosis stage. So these tests we are going and we are doing it at different levels, at the doctors, at clinics, even B and C class towns, and also we are visiting the corporates to ensure that this awareness is being created. We go along with the doctors. So I think these kind of initiatives which will help us to reach out to the patient, and then by that way those women will be definitely knowing that what will happen if at all she doesn't do this. That is very important. Another one example I like to tell you is simple thing of taking iron, folic acid and B12 in the first trimester is not known by so many women, and as a result we see so many birth defects. We support a foundation called Spina Bifida Foundation, which is very detrimental, and the child is paralyzed, right? Half portion of the body is paralyzed, and then in the rural places we see that many of the girls are denied treatment. They even do not, they consider that it is all right if at all she remains untreated, and there are many problems. So I think that creating this awareness and reaching out to them, educating them is one of the important area, and for that what we do is we have these patient education leaflets which we do it distribute during the camps, and that is also been translated in all the regional languages, so that even if it is not, they cannot read English, they will be able to get the right information.
Okay. So it's not many times not the cost only, but I think education and awareness also plays a critical role. Now, if I go on the other round and I'll start, Dr. Sanjay, from you. Now, there are many challenges when it comes to equity. It's such a wider topic. It's a goal actually, that equity. But moving towards that equity in today's time, what could be two important bottleneck or challenge you feel at your setting in a hospital setting as a clinician? You see that you have a patient and you want to give those services to that, and sometime you feel, no, since I am practicing in India, had it been any other country, situation would have been different. Have you ever felt that? Or
So you brought it right actually. When you said you're practicing in India, you have got some nuances which you really can't break the bridge, is where maybe the government could have done wonders by taking it forward. If I go back to United Kingdom and to United States and even Canada, where a lot of such implants are covered by the government itself. That means these implants, if used in India, would cost anything between 6 to 15 lakh Indian rupees. And they're all battery driven, which means that there could be a requirement of a battery change every 5 years, because the technology which comes to India is sadly a technology which is not upgraded to what it should be in the Western world, where the batteries have been removed completely. It's all AI right now. So the technology which comes to India is the implantable devices of the sacral neuromodulation one, which controls your bowel and bladder completely. For all these neurogenic elements of brain, spine, and all diseases which have happened. Imagine the implant will cost somebody here 10 to 15 lakh Indian rupees. Whereas my colleague, whom I met in Amsterdam last week, was implanting it free to patients who are needy, who are from that entire geographical region called the Netherlands. So there is a healthcare need which an individual doctor or individual hospital cannot do. It could be the Apollo Healths and the Max and the Kokila Bains and all that available around can only probably switch the gear to a different level to bring about advocacy on one aspect, which Madam rightly said. Awareness is the key. And therefore people get to know that this I have seen on the YouTube, this I have seen here, this I have seen on digital health, and something which can be done. So patient of that kind comes across, it's the gap which out here is the money matter then. Because most of these devices which we get in around, which are implantable, is the money matters. Other side, when I look into, as a doctor again, and a larger perspective rather than me being a urologist, when I look into the healthcare equity getting bridged, it's surely unfair and unjust that the government hospital systems which so good have not got upgraded to that level around. Whereas the shows have been run in that era when we started private healthcare with the Apollo as the word, and then so many players came and walked in around. Similarly, the medicines which are available today, if somebody says I cannot afford this medicine, which is a chronic disease medicine, for example, a prostate disease, well, medicine could be lifelong. The cheaper medicines should have the similar kind of efficacy available. If I downgrade those medicines on an individual who paid a price to a good medication and got the result, and now knows that I have to take this medicine lifelong to be as good or better than this, he goes back and perhaps takes the medicines at a different level, which I won't talk today, then he probably may not get that level around. So on both sides, the medical care and the surgical care in India could be much better if the so-called bridging the gap on the equity is when the government hospitals could challenge the private tertiary care sectors around. So upgradation is required, upgradation happens around, but it all slows down, the instruments don't get repaired, and our colleagues who are better than the best in the government hospitals don't get to utilize their efforts to that level. So you see patients jumping the gun, attempting to take the sword on themselves and say, I will get treated, let me go to a tertiary care hospital and get it treated. That's what today's motto is. If you continue to do what you always did, you will always get what you always got. So they need to scale themselves up. For us to look at that too, as a healthcare individual, I do face this music all the time, because people do come to a tertiary care setup with huge amount of expectations. The same expectation may be much lower in Agartala and in Nagarcoil, but they'll land up in Delhi, Bombay, Calcutta and Madras, where actually not the entire India lives. India only lives in a very small subset out there. The major India lives in 2-tier cities and beyond in the rural areas, and that gap has to be filled up. Important.
Yeah. And as you say this, because now with a lot of effort has gone, we hear from government, whether it's a National Digital Health Mission, Ayushman Bharat, even the almost majority, more than 50% hospitals which are getting claim under Ayushman Bharat are actually from private healthcare. So slowly, I think people are getting that choice to choose care.
Absolutely. For example, the transplants which were missing in this country, become completely a matter of days in two-tier cities only by the wonderful ZTCC and zonal committees created by the government. So government has scaled itself very high. I think it's just that we are beaten by the population we have created for ourselves. Otherwise, I think we are on the right road, right path. We are arriving there somewhere.
Yeah. Now, Jitendraji, if I come to you now, as Dr. Sanjay was it's government is playing and government has to play a bigger role. Otherwise, there is no option for such a big country if we leave around those top population and then few who got coverage from central insurance, CGHS, ESIC, Army, Railways. There is a huge missing middle that exists, right? And as you said about these various access or patient assistance program, but executing these programs as an organization, what kind of challenges you feel that you come across or how you tackle that? Because still reaching out to a bigger set of population in this country is not easy. And I think each industry, whether it's a hospital or a pharma or even to insurance, for example, everybody is facing challenge in that.
So I think this is another very good question. And that too, when we talk about the industry and the company where we have a limited resources, when your presence is very limited to just the metro cities. While we talk about the execution of such program, I think few of the challenges we face are like the size of the country. Since we have limited resources and the patient is very much divided into a wide geography, catering to all those patients is always very difficult. Although we strive very hard with our channel partners and the other stakeholders so that we can have a broader reach, but unfortunately it's very difficult to reach every patient. So what we try to do, like coordinating with the hospital setups, primarily in the bigger centers, we try to encourage those setups to, if it is possible, to give the therapy to the patient in those locations. That would be really great. So currently I can say that for every problem we cannot have solution at the immediate point, but definitely with the course of time you learn how to handle those challenges and you keep on evolving. So we also try to keep on evolving considering those challenges coming to us. But I think the best thing is to collaborate, and till now we are finding a great coordination between different stakeholders, and that is helping us to move forward. And hopefully in coming future we may learn some more during this journey, and we'll love to share with the other stakeholders as well.
Okay. So number itself is a challenge, right? And but as you rightly said, this number can only be reached once different stakeholders come together and try to address. So this brings to another question, Mr. Jayakumar, to you, is you talked about a very right thing around prevention, and I think majority of our healthcare system is more treatment based. We are waiting people to get hospitalized. That is how even our Ayushman Bharat, the NHA is working, though we have health and wellness center, but I think in general the perception is that the focus is more on getting people treated in the hospital. Now, but you rightly said that we need to move towards prevention. But how do we get that? What we need to do differently to reach to that stage?
So Prabhat, first of all, I will tell you that exactly where is the issue. So we need to check that where is the gap. What is the gap over there? So I'll just classify into three different categories first of all. One is the social, second is the economic, and the third is the environment. Social means, for example, Ayushman Bharat. And what we see is that whether in India, across all the population have the right to take the right treatment at the right hospitals. There could be that Ayushman Bharat, yes, they are giving a coverage of 5 lakh rupees, whether this 5 lakh rupees is enough for me as a floater, whether I know that whether I cover under the Ayushman Bharat. So that is very important that the socially that whether in India across all the, it could be like example he said that Mr. Jitendra said that a lower wages will not be able to afford going to a bigger hospitals or bigger tertiary care hospitals like Brij Candy or Leelavati. But what is his mistake? Whether he will be covered or not. That is one in terms of social. The second is the economic part where we come into the cost part. Whether it is affordable for me, because the cost plays a very important role to fill the particular gap. So I'll just emphasize on the economic part. And third, the very important thing is the environmental change. I think we spoke a lot about the COVID. That was one of the biggest set of example what we have seen is COVID. Recently what we have seen is that in Mumbai, we used to hear in Delhi that there was air pollution happening, lot of problems. Now we can see that again in Mumbai also the same problem has been arrived for an air pollution. What is it? How we can fill this particular gap? One is the prevention, and I again further categorize that what is how to fill this particular gap. One is the adequate. So adequate could be there whether we have got adequate infrastructure, because we have seen in COVID that most of the patients did not get bed, they got expired, they were not able to approach to particular hospitals, particular infrastructure. That is one, adequate. Other is affordable healthcare. So what I spoke, whether the healthcare is affordable for me or not affordable for me, that we need to decide. So that there are different things to fill the gap. For example, you can take an insurance program, or government has provided different like Ayushman Bharat for the lower category, whether it's affordable for me. The last and the very important what I see is the quality part, because the quality has a lot of impact on that particular thing, because I get a right quality of treatment or not. Because we have seen, as doctor said, that the government hospitals, we have seen recently that there was a lot of death happening in the northern side of Maharashtra, where a lot of death has happened because of due to the infrastructure. So these three, if you have an adequate, affordable quality and the prevention, what I spoke, and definitely I think this could fill up the gap.
Very rightly said. Umaji, if I ask you, the space where you work, I think government is spending a lot of focus on this, especially the women health at a primary level, right? Majority of the thing what we discussed is at secondary or tertiary level, but women health at primary level where government is spending huge amount, right? Now, being a private sector player in that space working along with government, what you feel needs to be done differently? Otherwise, this problem is not going to reduce. This number is going to increase and increase. So with your, as you said, 500 camps across the country of this size will not be enough, but at least you are piloting and showing a path. So what is the future looks like? How we can have 50,000 camps or reach in coming years?
Yeah, thank you, Prabhat. I feel that the most important thing that is needed today is creating the awareness. So when it comes to the women's health, I know that if at all they will go to the government hospital or primary health care center, then they will get those medicines over there. But the thing is that for them, they must reach there and they should feel that there is need to treat this. So I think that overall, if at all you see the nutrition, the depletion in the nutrition has happened with the food, because there is no more much of organic farming and all that. And with that, overall the nutrition level of the people is not very good. And we have seen that during COVID time, that so many people had a very less immunity. It is irrespective of the age and gender. And we feel that it is very important that for creating the awareness, the government, if at all it takes the initiative of creating the awareness of these simple things, like I told you, the birth defect, which is one of, if at all the child, today 7 per 1,000 children are born with that spina bifida. And the birth defect, overall birth defect percentage is quite high. And afterwards the child is born with that birth defect, and even the nation will have so much of money to be spent on that child. And then the family also gets completely affected, and especially the women in the house, she completely gets affected when the child is born with a birth defect. So I feel that creating awareness, so along with corporate, even if at all government will show this kind of awareness film or a short film before in the movie theaters, in the newspaper, in the television, after the whatever serials or whatever programs which are happening, that will help us to create the awareness amidst the people, and then they will feel they might be suffering silently. There will be many of the women or men, they will be suffering silently. They may not be aware, oh, this can be treated. They will be like, I will tell you that in 90s, when there was no much awareness about menopause in Indian women. Any problem will come, then the other women in the house will say, no, it will happen, because you are in this age and this will happen, and you have to just take it lightly. But now there's awareness. And people definitely go with the symptoms when they have this kind of phase, when they face this kind of problems, they do good. But still, I would say, how many percentage of women must be going to the doctors to tell that they are having palpitation, they have got night sweats, they are having hot flushes? The women suffer silently. So I feel that the most important thing that is needed today is the family also should support women, and they should ensure that women should not neglect whatever suffering she has, and she should go and visit the doctor. And at the same time, public awareness, if at all government can take this initiative and they can tie up with the corporate. I'm sure that corporates will be more than willing to help government, because this BMD machine which I told you, we have got every state we have got 4 machines, and we have employed BMD operator, and this test which is being charged, we are doing free of cost. So I'm sure that all the corporates also will support government, and this kind of initiative will help us to have the preventive measures in place.
Yeah, sure. So I think you gave a very solid point, which is education and awareness, and it, I think, is a common thing at every level, right? And now with all this digital and social media and all, I think if we use it constructively, there is a better way to reach out to people and make them aware. Equity also is important, like you touched about gender. I remember years back, 20 years back almost, we did a study in Haryana, and almost more men went to private setup, while more female went to government setup. So there are a lot of other determinants which talks about equity. So it's again a very vast topic, but thank you so much, each one of you, to bring issue. I think from insurance, how prevention is important, from how, the one point, as I said, stuck to my mind is the aspiration of people to get best of care wherever it is possible, at tertiary, primary and secondary level, and also a lot of effort from like Pharma to come up with innovative models to kind of bridge this gap and provide access. So thank you, each one of you, for your time and your thoughts. And with this, we close up this session, and I could only save 6 minutes, but I think you will enjoy that 6 minutes. Thank you.
Thank you, Prabhat.
Thank you so much.
Well done.
Thank you, Prabhat.
Thank you, Prabhat. Very good.
For a group photo op. Thank you so much, sir. We request you all to please step ahead, and thank you so much for sharing your insights. And we are glad that you all joined this discussion at the second edition of Patient First Summit and Awards. Ladies and gentlemen, can we please put our hands together and thank them for sharing their insights. I would like to invite Mr. Vivekanand Mishra, Vice President, IHW Council, to kindly join us on stage and present a token of memento. A very warm welcome to you. We shall be now felicitating Mr. Jitendra Kumar, Innovative Access Lead, Takeda. A very warm welcome to you. We shall now be felicitating Dr. Jayakumar Reddy, Ms. Uma Kalekar. Well, I believe we should just not stop clapping. Dr. Sanjay Pandey. We may now capture the most interesting moment of the day. We conclude with the last session, and we conclude the second edition of Patient First Summit. The sessions have been very, very interesting. So much knowledge that has been shared. Once again, I thank all the dignitaries, all the partners, all the sponsors who have been actively participating to make this day come to reality. Thank you so much for that. So ladies and gentlemen, we do conclude the Patient First Summit sessions, but we now move on to the Patient First Award ceremony. So I know that when we talk about the award ceremony, we all have a next level of excitement. So are we all excited for the award ceremony, aren't we, ladies and gentlemen? Well, so hold on to your breath a little tight, because now we shall begin with the award ceremony. May I request all our guests who are waiting outside in the pre-function area to kindly join us inside, as we are certain that you wouldn't want to miss out on even a single moment of the Patient First award ceremony. It's that moment of the day right now, ladies and gentlemen, wherein we shall be presenting awards. Well, I'm certain that it wasn't an easy decision to make. We shall be explaining and sharing the context of the award ceremony segment and how did the jury members decide who the jury members are, how many participants were there, and who all receives an award today in what all categories. There's a lot of excitement. There is a lot of input to be given, and there is a lot of smile to be seen today when the participants, when the award winners, they come on stage. Before we start the award ceremony, we have a 5-minute short refreshment break, just in case if you wish to take. So before we begin with the award ceremony, we just take a small breather of 5 minutes. Just in case if you wish to grab a cup of tea or coffee, that many of us have already done. In case if you wish to do so, you may. 5 minutes, which means 7:17 p.m. is the time that we start with the award ceremony. We look forward to see you all on the other side. Thank you.
In a world where health defines potential, diseases become barriers to growth. Weaving dreams of a world without sickness and full of well-being, the Integrated Health and Well-being Council was born. At its core, the Council stands for the high five of health. Good air, good food, good water, good living, and good health care for everyone. Aligned with the United Nations Sustainable Development Goals, the Council firmly works towards making sure health reaches every corner of the world. IHW Council has built prestigious forums for holistic health discourse, like India Health and Wellness Summit and Awards, CSR Health Impact Awards, CME Excellence Movement, Ayushman Bharat Conclave, Jal Shakti Conclave, Digital Health Summit, Patient First Summit, the Good Air Movement and Summit, Rapid Global Cancer Alliance, and the She Alliance for Spirituality in Health and the Environment. These initiatives have received wholehearted support from policymakers, industry captains, community leaders, health experts, celebrities, and influencers. Respected brands and advocates have also joined the Council, becoming allies in the mission for a healthier world.
I think this wellness is an important initiative. I will definitely be interested to know the conclusions of your deliberations, and I'll definitely take these issues and your suggestions forward to the logical conclusion.
हेल्थ सर्विसेज कैसी होनी चाहिए,
ये तो महत्वपूर्ण विषय है ही, पर उसके पहले हमको हॉस्पिटल या डॉक्टर के पास जाने की जरूरत न पड़े, इसके लिए हमारे एयर पोल्यूशन और वाटर पोल्यूशन को हम कैसे सुधारें, इस बात पर जोर देने की आवश्यकता है।
कहते हैं क्षिति जल पावक गगन समीरा, पंच तत्व निर्मित यह अदम शरीरा। ये पंच तत्वों से निर्मित यह शरीर पुनः पंच तत्व में ही मिल जाता है। तो हमें उन पंच तत्व का, जिससे इस शरीर की रचना हुई है, आकाश, पृथ्वी, अग्नि, वायु, जल, इन सबका ख्याल ही नहीं रखना, बल्कि इन पंच तत्वों का रक्षा करना हमारा पहला कर्तव्य हो जाता है।
In the digital world, the Council reaches millions with credible source of knowledge empowering them to protect their health and prevent diseases. Through its various initiatives harnessing the power of social media, the Council impacts over 100 million lives annually. Join IHW Council in creating a world where limitless potential knows no bounds. Together, we can achieve a happier, healthier world for all.
So ladies and gentlemen, welcome back to the second Patient First Awards 2023. Ladies and gentlemen, would be nice enough if we all can put our hands together. Welcome this evening on a very positive note and some smile across the entire room over here. Well, so good evening, ladies and gentlemen. I'm your host, Kashita, and we've been interacting since morning, have gained a lot of knowledge with various topics throughout. Now it is time to introduce you all to the Integrated Health and Wellbeing Council. They are delighted to bring to you the second edition of IHW Patient First Awards 2023, ladies and gentlemen. After a section of many discussions and deliberations on the most important and sought-after segment of the healthcare delivery mechanism, patient-centricity and advocacy, which has to be and will be the key drivers of the modern healthcare delivery ecosystem. We thank all the dignitaries and key speakers for sharing their thoughts and ideas. Ladies and gentlemen, now we have one of the most awaited section of the day, as we present the second edition of IHW First Award 2023. The Integrated Health and Wellbeing Council is not-for-profit institution aligned and inspired by the UN Global Agenda of holistic approach to social development goals. We feel extremely proud to drive 9 out of 17 SDG goals through holistic high-five health awareness, advocacy, and action agenda of the IHW Council. Our belief and principle reflect in our high-five missions to achieve good health, good food, good water, good air, and good lifestyle for all to create a world of good health and well-being. The advocacy and awareness impact we have created in last decade through the action of our missions involving global leaders, countries, relevant ministries, and government bodies, health, environment and education, policymakers, medical technology, solutions and services, infrastructure providers, researchers, academia, professionals, health enthusiasts, and influencers. Key stakeholders and grassroots level has been an inspiring journey. It is our extreme pleasure and privilege to conceptualize and organize such meaningful initiatives for the healthcare provider, individuals, patient-centric organizations, advocacy groups, and agencies engaged in sustainable and responsible work for humanity and uplifting the health of communities and societies through various platforms. There is a bit more because this is very, very precious to us as much as it is for you. This recognition from India's premier health awareness and advocacy will bring to the fore the credible and outstanding contribution of institutions, organizations, healthcare service providers, all level of patients groups and individuals focusing on various illness and diseases to bring patient centricity and advocacy to the core of health and healthcare ecosystem. IHW Council, with its second edition of IHW Patient First Awards, aims to highlight the positive change and focus on these organizations, groups, and individuals to bring about this permanent change in reducing health disparities and providing much needed care and guidance to the patients at all stages. In this edition, we have received around 100 nominations, and the IHW Awards team has evaluated and screened more than 70 final entries and presented them to the respected jury for further evaluation and marking. It is just that we have a process of selecting winners. It doesn't mean that the efforts of others are less or more. For us, all initiatives are remarkable and valuable. And we respect all to continue this encouraging work irrespective of their selection to this year's awards. There has been a tremendous amount of work and planning that's gone into making this day possible, as we mentioned earlier. And I would like to once again thank all our partners for making this evening very special. Can we please put our hands together for all the partners for being a very, very vital part of this evening. We are extremely thankful to our esteemed jury members. Each of them are highly decorated. Each one of them is highly decorated and recognized public figures and decision takers, promoters and propagators of good health for their guidance and support in recognizing the efforts of the deserving organizations working and contributing towards building the health of the nation through their remarkable efforts. It is now time to introduce the jury members. They will be here, the names will be displayed on the screen, so make sure that you have your attention on the big screen as well. The very first jury member is Dr. Randeep Guleria, former director, AIIMS, New Delhi. I believe that we should just not stop clapping for the jury members. Dr. Atul Mohan Kochar, CEO, NABH. Dr. Padma Srivastava, Head Neurosciences Center, All India Institute of Medical Sciences, New Delhi. Dr. T.S. Clare, Chairman, Fortis Heart and Vascular Institute, Gurugram and Vasant Kunj, New Delhi. Dr. Shubnam Singh, Principal Advisor, Health Confederation of Indian Industry, CII. Dr. Sanjay Pandey, Head of the Department of Andrology and Reconstructive Urology, Kokilaben Hospital, Mumbai. Dr. Rajendra K. Dhamija, Professor of Neurology and Director, IHBS. Dr. Govind K. Makharia, Professor, Department of Gastroenterology and Human Nutrition, All India Institute of Medical Sciences, New Delhi. Professor Shefali Gulati, Program Director, Pediatric Neurology, Program, Faculty in Charge, Center of Excellence and Advanced Research for Childhood Neurodevelopment Disorders and Child Neurology Division, Department of Pediatrics, AIIMS, New Delhi. Dr. Chandra Sekhara, Medical Director, Chandre Rheumatology and Immunology Center and Research and President-elect IRA. Mr. Bhupendra Kumar Rana, Chief Executive Officer, Quality and Accreditation Institute, QAI. Dr. Rakesh Sahai, Professor of Endocrinology, Osmania Medical College and Osmania General Hospital and President-elect RSSDI. Well, I believe we just have last two names to go. Please don't stop clapping, ladies and gentlemen, for the jury members. Dr. Hema Divakar, Chair, Well Women Healthcare Committee, FIGO, and Medical Director, Divakar's Specialty Hospital. And Mr. Kamal Narayan, CEO, IHW Council. Once again, a very big thank you to all of you, to all the participants who have wholeheartedly supported this initiative by being present over here today. Without any further ado, ladies and gentlemen, let's begin the celebration of IHW Patient First Awards. To begin with, I would request and invite Mr. Kamal Narayan, CEO of IHW Council, to please join us on stage and share his insights and a bit of his excitement for the award ceremony.
Good evening, everyone. So, after a day-long sessions of insightful deliberations on how we as a country can create a healthcare system which really cares for its most critical component, that is patient. And we all heard some really insightful, inspiring, motivating aspects of reimagining our healthcare system. We have now reached to one of the most exciting, most awaited part of this program today, when we are going to celebrate the work of the people who have really taken the lead in making possible what we have been discussing since morning. The good part here is that we as a country, we as the community of healthcare providers, healthcare facilitators, and healthcare promoters are waking up to the whole notion of this important approach that when we are planning, when we are provisioning, when we are delivering healthcare, it has to be the best for the patient who are the beneficiaries of it, and who are the people who are coming to us, giving this opportunity to us to serve them at a time when they are most distressed. And it is in our hand, capability to bring that most required relief to our patients. Many of you have already started that wonderful work. When we were going through the work of many of the people, the organizations, the institutions which was sent to us to evaluate as part of the second Patient First Award from IHW Council, we were really inspired to see that how we are using technology, we are digitizing many aspects of healthcare, diagnostics, screening, ensuring that the most critical approach to make the patients feel that they are the part of this whole process, and they are not only the part but they are the center of this whole process, which is to engage them, educate them, empower them, and also to make them adhere to what is most essential for their health, has been absolutely remarkable. And I'm happy that we are seeing this journey beginning well. When we started last year this Patient First Award and also the summit, it was a relatively new idea. Not that many of you were not practicing it, but because not many of us were talking about it. And when we start talking about some idea, when we start asking for certain aspect of healthcare, they start becoming the part of the whole system. And that's where we are happy from the council that we were privileged and fortunate to start that journey. We saw many of the institutions coming forward last year, showcasing their work, but they were still in very limited numbers. This time it was altogether different phenomena. We saw a lot of work coming to us, showcasing their different innovations, approaches, mechanisms, and the passion which they brought in to ensure that patients are given the top priority in the healthcare delivery, in the medicine delivery, in the drug discovery, in clinical trials, in research, and almost every aspect of healthcare. So with that, I extend a very warm welcome to all of you for being part of this program today, and also congratulate all the winners and also those who might have not been in the shortlisted winners of the work this year, but at the same time we do acknowledge and recognize that their work was too of great value, great contribution, and I am sure that the work which you have started doing itself is an award in itself. So please do recognize and clap for yourself as well. Those who have got are going to be recognized, but those who could not make it to it, but at the same time their work is also very, very important when it comes to achieving the mission like bringing patient at the center of the care. Thank you so much.
Thank you so much, sir. We would now like to invite our, so you may take a seat, and or else you may stay back with us on stage. You're open to do a small cardio right now. Thank you so much, sir. Can we please thank sir once again for sharing his insights? And I feel that this is more of an emotion that's coming out. It's now time to invite our jury, Dr. Sanjay Pandey, Head of Department of Andrology and Reconstructive Urology, Kokilaben Hospital, Mumbai. So please join us on stage to share your insights on this awards ceremony.
Good evening, everyone. Thank you, Kamalji. Thank you, IHW Council. Thank you, everybody, for making this happen. To me, it looked like a dream when we started being a jury and looking at the kind of work which was being projected. But lo and behold, the kind of work that has been shown and showcased in the jury panel and what we took forward, it was difficult to decide and tell apart between two people who have done work on each and every segment. My colleague jury members would believe that this was an onerous task to actually, for the IHW Council to have gone through and looked at stratification of the work that individuals have done or the groups have done or the pharma companies and hospitals have done. Magic is something you make every day. But I know that what got us here will not get us there unless we clap for them who continue to strive and work hard in healthcare. Healthcare is something which India needs more, and probably each of us in this august audience today would look forward to having these kind of distinctions being served to somebody. And as Kamalji rightly said, for those who don't come on stage, continue to be winners for all of us. I had a very tough time to be telling apart between two individuals or two groups who actually made it to the final marks around. So extremely impressed with the kind of deliberations which happened in the sessions which went ahead to finally come to this session. It looks like that we have arrived at a point in time where health givers in various segments, which includes the insurance, the pharma, the care givers in awareness section, and then you have a great council which actually teams up with such wonderful teams around, and many more whom we don't normally speak loud and clear about, are actually combining together to actually take this subject forward. Putting patients first is probably the right to patients' care and right to health, which Indian government has taken forward, and all of us are a part of it. To me, it's a very humbling and an honorable moment to be out here today with leaders in the field and to be with the jury members who have done onerous work on the subject and their own lifetime. So thank you so much for inviting us. It was a great way to move forward, to be a jury and to look at the amount of work which is being done in India, to touch lives of people by initiatives which teams have done as pharmaceutical companies, as care providers, is just beyond me. I think it is a learning which my teachers say every day is a new learning. To me, it's a learning all these last few weeks being a jury, and now today to culminate into a program where we meet all of you. Thank you so much for inviting. Thank you for being a part of this wonderful program. Claps.
Thank you, sir. So please stay back with us. Thank you so much, sir. Thank you so much for sharing your emotions. And we request you to please stay back with us and would request Mr. Kamal Narayan, CEO IHW Council, to kindly join us back on stage to present the award ceremony. Ladies and gentlemen, please put your hands together as we begin with the very first category. The very first category is Patient-centric Pharmaceutical Company in Diabetes Care. And the Bronze Award in this category goes to... Any guesses? You may take your own organization's name as well. So we start with this. The Bronze Award in this category goes to Glenmark Pharmaceuticals. We request the entire team present over here of Glenmark Pharmaceuticals to kindly join us on stage. Wishing you a hearty congratulations. Once again, wishing a hearty congratulations to Glenmark Pharmaceuticals. Moving on to the next category, the Silver Award in this category goes to Lupin Limited. A hearty congratulations to the entire team of Lupin Limited. We request the entire team to kindly join us on stage. A very warm welcome to you. And wishing a hearty congratulations with some Zordar Taliyan, please. Thank you. Moving on to the next award, which is the Gold Award in this category. And the award goes to Biocon Biologics. Here's wishing a hearty congratulations to the entire team present here. Ladies and gentlemen, Zordar Taliyan ho jaye, please. Biocon Biologics, congratulations. Now we move on to the next category, which is Patient-centric Pharmaceutical Company in Women's Health. And the Silver Award in this category goes to Alembic Pharmaceuticals. We request the entire team of Alembic Pharmaceuticals to kindly join us on stage. Here's wishing you all a hearty congratulations. Very Zordar Taliyan ho jaye, ladies and gentlemen, for Alembic Pharmaceuticals. Thank you once again, and once again wishing you all a hearty congratulations. We move on to the next category, which is Patient-centric Pharmaceutical Company in Child Health. The Bronze Award in this category goes to Pfizer India. Everybody, please welcome the team of Pfizer India with some Zordar Taliyan. A hearty congratulations to you all. It is indeed a moment to cherish. This category is Patient-centric Pharmaceutical Company in Child Health. In this category, the Silver Award goes to JB Chemicals and Pharmaceuticals. We request the entire team to kindly join us on stage. Here's wishing you all a hearty congratulations. Of course, with some zordar talia, ladies and gentlemen. Please put your hands together. Let's congratulate JB Pharmaceuticals, good people for good health. Moving on to the next category, which is patient-centric pharmaceutical company in gastroenterology and hepatology. The bronze award in this category goes to, I would request the team to please hang on. JB Chemicals and Pharmaceuticals receives the next award as well. Here's wishing a hearty congratulations to JB Chemicals and Pharmaceuticals. They received the bronze award in the category of patient-centric pharmaceutical company in gastroenterology and hepatology. A hearty congratulations to you all. Moving on to the silver award in this category, which goes to Zydus Life Sciences. A hearty congratulations to the team of Zydus Life Sciences. Congratulations! Congratulations once again. Moving on to the next category, which is patient-centric pharmaceutical company in kidney care. The bronze award in this category goes to JB Chemicals and Pharmaceuticals. We request the respective team to kindly join us on stage to receive the award. A hearty congratulations once again to the team of JB Chemicals and Pharmaceuticals. So, in the same category, the silver award now goes to Dr. Reddy's Laboratories. Ladies and gentlemen, it is so good to see a full house right now. Then why can we not hear the sound of the claps out here for the award winners? Here's wishing a hearty congratulations to Dr. Reddy's Laboratories. Once again, wishing a hearty congratulations. The second silver award in this category goes to Biocon Biologics. Ladies and gentlemen, please congratulate the team of Biocon Biologics. It's some zordar taaliyan, please. A hearty congratulations once again. We now move on to the next category, which is patient-centric pharmaceutical company in cardiology. The bronze award in this category goes to Zydus Life Sciences International Markets. Very warm welcome to the team of Zydus Life Sciences International Market. Wishing you all a hearty congratulations. Congratulations once again. The next category also is the Bronze Award in this category. And this award goes to, I thought of creating a little bit of moment of silence. Can you all please tell me who do you think the award winner would be? You are absolutely correct और आप जीत चुके हैं. Glenmark Pharmaceuticals take charge at 18 My Telma Promise PSP. The Bronze Award winners, the team of Glenmark Pharmaceuticals. Congratulations to you all. Indeed, a moment of pride. The next award is a Silver Award in this category. And the award goes to AstraZeneca India Pharma. Welcoming the team of AstraZeneca India Pharma and wishing them a hearty congratulations. So this category had a lot of awards. We now shall be announcing the name of the award winner in the Gold Award. And the award goes to Glenmark Pharmaceuticals India First, Heart First. Welcoming the team of Glenmark Pharmaceuticals India First, Heart First on stage and wishing you all a hearty congratulations. Ladies and gentlemen, can we please put our hands together and congratulate the entire team. A hearty congratulations to the entire team. The next category is Patient-centric Pharmaceutical Company in Rare Diseases. And the Silver Award goes to Takeda Pharmaceuticals. Welcoming the entire team of Takeda Pharmaceuticals on stage and wishing you all a hearty congratulations. Ladies and gentlemen, थोड़ी जोरदार तालियां हो जाए for the award winners on stage. Once again, wishing you all a hearty congratulations. Moving on to the next category, which is Patient-centric Pharmaceutical Company in Pulmonology. The Gold Award in this category goes to Lupin Limited. And the team joyfully starts to walk up on stage, wishing you all a hearty congratulations. The entire team of Lupin Limited receives the Gold Award in the category of Patient-centric Pharmaceutical Company in Pulmonology. Congratulations. Thank you. Moving on to the next category, which is Patient-centric Pharmaceutical Company in Derma Care. The Gold Award in this category goes to Glenmark Pharmaceuticals. We request the respective team for this award to kindly join us on stage and receive the award. Congratulations. Thank you. We now move on to the next category, which is patient-centric pharmaceutical company of the year category. And the award goes to Pfizer India. Patient-centric pharmaceutical company of the year, Pfizer India. As the team walks up on stage, let's congratulate them, ladies and gentlemen. Once again, wishing you all a hearty congratulations. Thank you. Moving on to the next category, which is patient-centric diagnostic lab. The silver award in this category goes to AMP Diagnostics. We request the respective team to kindly join us on stage to receive the award. Wishing you a hearty congratulations. In the same category, the gold award goes to IHS Diagnostics Limited. Well, we can reduce the volume of the music and we may hear the sound of the claps coming from the audience to cheer up and congratulate the award winner. A hearty congratulations to you. Moving on to the next category, which is patient-centric healthcare startups. The gold award goes to Purple Ribbon. A hearty congratulations. They received the award in the category of patient-centric healthcare startups. Moving on to the next category, which is emerging patient-centric healthcare leader. And the award goes to an individual, Dr. Vikas Chandra Savarkar. Congratulations. Yours wishing a hearty congratulations to the emerging patient-centric healthcare leader, Dr. Vikas Chandra Savarkar. Congratulations. We really appreciate the kind of enthusiasm that you are putting in. Thank you so much, presenters, for presenting the award. Thank you. Ladies and gentlemen, please thank our presenters for presenting the awards. Moving on to the next category, we shall now invite Mr. Prabhat Sinha, Director, Public and Government Affairs, Boehringer Ingelheim, India. I had a great tongue twister today, sir, but I'm glad that it's been right pronounced. Very warm welcome to you, and we shall also be inviting Mr. Vivekanand Mishra, Vice President, IHW. Please join us on stage to present the next set of awards. Please, जोरदार तालियों के साथ, let's welcome our presenters on stage. So, we now move to the hospital category. Patient-centric hospital in women's health. The bronze award in this category goes to KIMS Health, ladies and gentlemen. Let's congratulate Kim's Health on winning the Bronze Award in this category. The next award is a Silver Award. In this category, the award goes to Jahangir Hospital. We request the team members of Jahangir Hospital to kindly join us on stage and receive the award. We have one person cheering up in the audience. Can we all join her, ladies and gentlemen? A hearty congratulations to you. Moving on to the next category, which is Patient-centric Hospital in Pulmonology. We only have Bronze Award in this category, and the award goes to Kim's Health, ladies and gentlemen. We request the team to kindly join us on stage to receive the award for Kim's Health. Congratulations! Devi और सज्जनों, थोड़ी जोरदार तालियां हो जाए for the award winner on stage. Thank you so much. Moving on to the next category, which is Patient-centric Hospital in Diabetes Care. Again, we only have one award in this category, and the Bronze Award goes to Malabar Institute of Medical Sciences. Welcoming the team on stage and wishing a hearty congratulations. A hearty congratulations to the entire team. We now move on to the next category, which is Patient-centric Hospital in Reproductive Health. We have two Bronze Awards in this category. So the very first Bronze Award goes to Komali Fertility Center. Congratulations. They received the Bronze Award in the category of Patient-centric Hospital and Reproductive Health. Congratulations. Thank you. And the second Bronze Award goes to Jahangir Hospital. Congratulations once again. Maybe if you cheer up once again, we all join you. We are just pointing on to the lady who's taking pictures of the award winner in her mobile phone. If you maybe cheer up once again, we all join you in clapping hands. Yeah. Congratulations once again. Moving on to the next category, which is Patient-centric Hospital in Child Care. And the Bronze Award goes to C.K. Birla Hospital's CMRI. We request the team to kindly join us on stage. आपको बहुत-बहुत बधाई. Congratulations on winning the Bronze Award. C.K. Birla Hospital, CMRI. Congratulations. Moving on to the next category, which is Patient-centric Hospital in Gastroenterology and Hepatology. We have two Bronze Awards in this category. The first Bronze Award goes to, any guesses? the lady who's been cheering up? Well, it goes to Jahangir Hospital. We can repeat the drill. Lights, camera, action. Congratulations to you. Moving on to the second award in this category, and it goes to Renova NIGL Hospitals, a unit of Tejaswini Healthcare Private Limited. We request the team to kindly join us on stage to receive the award. The category is Patient-centric Hospital in Gastroenterology and Hepatology. So we shall present the award once we have the award winner present over here. Moving on to the next category now, which is Patient-centric Hospital in Kidney Care. And the bronze award in this category goes to Mahatma Gandhi Medical College and Hospital, Jaipur. Here's wishing a hearty congratulations to the entire team. Congratulations to you. Moving on to the next category, which is Patient-centric Hospital in Orthopedic and Rheumatic Diseases. In this category as well, we have 2 bronze awards. The first bronze award goes to C.K. Birla Hospital, CMRI. A hearty congratulations to the entire team of C.K. Birla Hospital's CMRI. Bronze award in the category of Patient-centric Hospital in Orthopedic and Rheumatic Diseases. Congratulations. Ajay Devi or Sajno, please. Moving on to the second bronze award, and this award goes to Zenova Hospital. Support here in the crowd. Let's join her in putting our hands together. Wishing a hearty congratulations to Congratulations. Jahangir Hospital bags the Bronze Award in this category of Patient-centric Regional Hospital of the Year. Moving on to the next Bronze Award in the same category. And the award goes to Yashoda Super Speciality Hospital. We request the team members from the respective hospital to kindly join us on stage to receive the award. So we may present this award once we have the team members present here. Moving on to the next award, which is the Bronze Award in this category. And this award goes to Mahatma Gandhi Medical College and Hospital, Jaipur. Ladies and gentlemen, let's congratulate the entire team of Mahatma Gandhi Medical College and Hospital, Jaipur. Congratulations. Moving on to the next award, which is the last Bronze Award in this category. And this award goes to Continental Hospital. A hearty congratulations to the team of Continental Hospitals. Everybody, please put your hands together. Moving on to the next award in the same category, that is Patient-centric National Hospital of the Year. And the award goes to Apollo Hospital Enterprise Limited. A hearty congratulations to the entire team. Congratulations once again. We request all the award winners to please stay back in the room because we have something very interesting coming up. So please do not go anywhere. It's now time to announce the second last award in this evening. Patient-centric Multi-Speciality Hospital of the Year. And the silver award goes to Jupiter Hospital. Welcoming the entire team of Jupiter Hospital. Congratulations to you all. Zordar taaliyan ho jaye. It's the second last award, ladies and gentlemen. Thank you. Now, moving on to the last award of the evening, which is in the category of Digital Healthcare Technology Solutions of the Year. And the silver award goes to Walters Kluwer. Here's a huge team of Walters Kluwer joining us on stage. And everybody in the audience, being the last award receiver, you all can take their pictures and share it along with them either on AirDrop or Bluetooth. Anyhow, that's convenient. Everybody, आखिरी award है, थोड़ी जोरदार तालियां हो जाए, please. Oh, the silence, right? Wishing a hearty congratulations to all the award winners, ladies and gentlemen. So, once again, congratulations, and may the good work continue. You all are doing amazing work. Thank you so much. Please continue doing the same. May I request now all the winners from today's evening to kindly join us on stage for a group photograph. I would request Mr. Kamal to kindly join us back on stage to be a part of this group photograph. A heartfelt thank you to the presenters. Please be a part of this group photograph. Kamal sir, welcome back. All the award winners, please, are requested to join us on stage. Post this, we have the dinner and cocktails being served in the same pre-function area. Please do enjoy that. Hope you all had a great evening today. If yes, please make sure that you put your hands together for all the award winners on stage, ladies and gentlemen. So we have, okay, the number of award winners that we have here is ample. So we have 2 stairs down as well. So maybe we can spread a bit and get a good photograph as well. Okay. So if any, do we have, oh, look at the paparazzi over here. Mumbai right now, right? Okay, so anybody who's not visible, maybe ma'am, ma'am who's trying to fit in and let the face be showcased. Ma'am, maybe you can step down and join us here. We request the entire IHW team to kindly join us for the group photograph. Dr. Asavari, Himani, where are you running away? You just cannot escape it, sorry. We request Neha as well. Neha ji, aa jaiye please. So, do we have all the award winners here on stage? Anybody else that we have to invite? Neha. Does she choose to ignore us? There she is, Miss Neha. Oh my goodness, you're looking so beautiful in this sari. Okay, ladies and gentlemen, are we ready? Can we all give a nice victory sign with our trophies? A hearty congratulations to you all. It is the second edition of Patient First Summit and Awards. Now that the award winners are here, can we all say it aloud for the... Oh, the paparazzi is saying that we have to respect the media people if you need the pictures right. Everybody, once again, victory sign. Anyhow, that's comfortable. Let's not cover anyone's face. Victory sign, smiles all around. And zordar taaliyan, of course. And let's not forget to say 3 cheers. Hip hip! Hip hip! Hip hip! Thank you so much, ladies and gentlemen. I'm your host, Kashida. Hope to see you all in the next edition. Thank you.
came for. Lightning strikes every time she moves, and everybody's watching her. Baby, this is what you came for. Lightning strikes every time she moves, and everybody's watching her. Oh, just look at it. Gotta be this way. We say nothing more than we need. I see your place when we leave. Baby, this is what you came for. Lightning strikes every time she moves. Everybody's watching her. Oh, just look at it. We drunk and all of our thumbs went up in the air. Funkin' in the wind, listen to the thunder rolling over and over. We down the river, we drunk and all of our thumbs went up in the air.